Well, good morning. Hi, I'm Wade Schrader. I'm a pediatric orthopedic surgeon and from Wilmington, Delaware, and I'm the incoming president of the American Academy of Cerebral Palsy and Developmental Medicine. So I want to be the first to welcome you all to our community forum. I want to thank you all for coming today. The Academy is so proud of our community council, and I personally have been involved in it for so many years, and it's so great to see the evolution of what used to be family days and used to be family forums, and now have really kind of grown into this great meeting that they've planned for you today. And so I want to congratulate the community council on behalf of all the board of directors for all of their hard work through the year, all their phone calls and plans, and I think they've got a great program put together for you today. And then, of course, we want to thank our generous host here at the Shirley Ryan Ability Labs. This is a beautiful space to have this beautiful meeting. And so thank you all for that. They've been such great, generous supporters of the Academy and of our families. And so it's just our privilege to work with such great people. And so I'm going to take, that's all the time I'm going to take. I'm going to turn it over to Dr. Rick Lieber, who's the Chief Scientific Officer here at the lab, and he's going to give some introductory comments. So, Rick, thanks so much again.
I just echo with Wade. I've been coming to AACPDM since '84. That was my first meeting and learned a lot. I was a frog muscle mechanics guy in San Diego. And a guy named David Sutherland, a big shot orthopedic surgeon in this CP space, said, come talk to a bunch of physicians and therapists and parents about muscle. And I go, yeah, but what's CP? And so over the years, I've learned a little bit more from colleagues. His junior colleague, Hank Chambers, and I have been good friends. And I'm really committed to the cause because we can do so much together. But my job today, I'm the Chief Scientific Officer here. I moved here in 2014 from San Diego after 32 years there to build this hospital, which is pretty cool. And our CEO at the time said, hey, can we get you to come to Chicago? Remember, I'm in San Diego. Can we get you to, and I'm from California. Can we get you to come to Chicago and help us build a hospital? What are the odds? And I said, the odds are 0. I'll freeze to death. And she goes, no, we're going to build this great hospital. And we were trying to do the same kind of thing in San Diego, and yet she told me, we have this vision for therapists, doctors, scientists, who'd I miss? Physicians, they're kind of important, to all be together for the same cause, to make patients better. And one of the big patient populations here is kids with pediatric issues. So AACPDM is right on target for us, and parents, we marinate in parents, and we love parents. And you know, I'm a nerd, so I do a lot of research, but if I ever really want to know what's going on, I ask a parent, and they'll tell you the truth, which is great. So will the patients. So official welcome on behalf of the hospital. I think you'll have a great time here. I think you'll have a great time in the whole meeting if you go to some of the nerdy sessions as well. And my job today is first, I'm a surrogate for Shirley Ryan, who got sick. Shirley Ryan, who is our obviously benefactor namesake of the hospital, has been in the advocacy world, especially in cerebral palsy and developmental medicine, for 4 decades. She founded an organization called pathways.org. If you would do me a favor, if you would download the app and tell her I told you to download the app. She goes, Rick, I'm sick, but you got to tell him to download the app. So I told you to download the app. Could you please download the app? Like if there's a little blip today, my stock goes up with her. She'll be happy. Download the app. Just remember, download the app. It is a great app. We actually have a major developmental project going on in our hospital, and we use the app quite a bit with parents. And it's very parent-friendly and parent-focused. So Shirley Ryan, obviously a major benefactor to help build the hospital and an advocate for child disability, has been with us for quite a while. And we're doing many things together. So let me tell you a little bit about the hospital. Obviously, I'm the Chief Scientific Officer. My colleague, you don't see here, is a guy named Jim Sleewa. He's the Chief Medical Officer. And our CEO used to tell us, you guys are joined at the hip. Jim, Chief Medical Officer, don't do anything that's scientifically stupid. And Rick will tell you if it's stupid. Rick, don't do anything that has no clinical relevance and doesn't help our patients, because we don't want to waste our time. Time is short. And so Jim and I talk all the time. I come to him with a hammer. Hey, Jim, I can measure fingernails to 3 microns. And he just goes, that's stupid. Or he'll say to me, hey, Rick, we're gonna, I don't know, measure the aura of patients with an iPhone. And I go, I don't think we are, Jim. Stuff like that. We go back and forth. We keep each other honest. And it's a great partnership. And we've partnered people at various layers below. And it's different, much as I love universities, and obviously anyone who's been educated has come out of the university, we're more like a small business than we are a university, and I'll explain why. First of all, just to orient you, we've co-localized research and clinical space all throughout the building. So you're in a 1.2 million square foot, 26 floor building, I forgot. And we basically are organized in two sides. You see on the left-hand side of the slide, the innovation centers. That's code for inpatient facilities. We have 282 beds here, so it's a big rehabilitation hospital. Floor 18 is our pediatric floor, and during the tour you'll see it. I always say pediatrics is sort of like everything, but the other inpatient areas are organized by anatomical issues, not by clinical issues. So doctors, therapists, even scientists tend to say, oh, it's a stroke patient, it's a brain injury patient, it's a CP patient. That's really not how we think here. We think, oh, there's an issue with brains or spinal cords, or in my case, I love muscles, so muscles and bones. So we organize the innovation centers anatomically. We organize what we call the ability labs, which is where the therapy happens. We organize those functionally. Because you could have a brain injury patient who needs to walk on a treadmill, or you could have a brain injury patient who needs arm function. So we organize, you can see here, think and speak, which is, for like aphasia, post-stroke, things like that. Legs and walking, arms and hands, strength and endurance, where they're ready basically to eject out of the building. And then, like I said, pediatrics. Pediatrics, as you know, kids sort of need to be together. They are all huddled in one place, and they're kind of like the whole hospital in one place. And it even includes cancer rehab, which is pretty interesting. So let me talk a little bit about, I did do an MBA at UCSD because I was starting to do more leadership, and they kept telling me, you're a terrible leader, like you need some training. I go, yeah, I'm a muscle guy. They go, yeah, but we need to train you how to do some stuff. So they paid for me to get an MBA. And what I learned was, as scientists and in medical research and science, we're running small businesses. So I talk here about the business of science. These are all obviously logos of companies. And there's a great line by Stephen Covey in leadership. It says, begin with the end in mind. So I always, whenever I'm hiring someone, I always say to them, well, what's your goal? And if they say, my goal is to measure fingernail lengths in, spinal cord injury patients, I'm kind of like, I don't know. But if, what's your goal? My goal is to make it so kids can walk and not have to get surgery for contractures. I like that goal. So our goal is to make patients better. And I was mentioning to someone before we started, when I first got here, I'd talk to an engineer and I'd say, okay, like which of our patients are you helping? And they'd say, well, I'm not that kind of doctor. And I'd say, well, yeah, but we're paying your salary, you're in our space, you're marinating in patients, you gotta help our patients. So we talk a lot about beginning with the end in mind and focusing on the patient population, whoever that person is appropriate. We have actually now a pretty big research operation. We've got 45 researchers in the building. This is this is the flavor of them. And rehabilitation tends to attract engineers. You'll hear from one this morning. We have mostly engineers and neuroscientists. And then we have a bunch of other kinds of people. And the nice thing about this is you can, this is sort of like a university in a bottle. Like normally in a university, the engineering school, the medical school, the biological schools are different schools. So to make collaborations, there's a lot of what we would call friction. Here, we live with each other. We try to get together quite a bit. When there's a problem that requires engineering expertise, we ask engineers, biological expertise, biologists, et cetera, and the goal is basically, just like you hear in most things, the wisdom of crowds. You get a bunch of smart people together, focused on the same problem, and resources. I mean, I gotta say, one of the reasons this place, I think, is being successful is the city of Chicago. I'm not from here, so I feel like I can brag on it. The city of Chicago is extremely generous. So we have, scientists typically make their living by writing research grants and getting enough money to do a project. So I could be a well-meaning scientist in Albuquerque, but if I can't get a grant to do the work, even though it's a great idea, I can't do it. Here, we can fund at least part of what people do from philanthropy. And I would say we have about $150 million research portfolio. Of that 150, between 10 and $30 million, depending on the year, comes directly from philanthropy. And the reason I hedge on the number is when everybody has tons of grants, we save money. And when they don't, we spend money. So this group of people you're seeing it's a dynamic group. We're hiring new people. We're trying to expand. Obviously, we have space limitations in the building. One of the things you'll see on your tour today is the biologics lab up on the 26th floor, which is pretty rare for a rehab hospital. You'll see some interesting things. We try to work on human tissues and cells and stuff like that. And then how do we do it? So our umbrella, I would say, structure for getting research going is what we call a research accelerator program. And there's a lot of flavors to the research accelerator program. Basically, I think of it as kind of forced speed dating. So you have, I have a really smart, let's say, biologist, and we have some really important clinical problems. We force them, quote unquote, these are smart adults, they know what they're doing. We force them to get together and do important things. One of the things I think we've been most successful at is this thing called an idea lab. And actually right in this room, we get a bunch of people together who have very different backgrounds, and somebody presents an idea. Hey, I have an idea. I'm gonna measure, range of motion in every stroke patient on the right side and the left side for the next 10 years. And then an engineer says, wait, how are you gonna measure it? Or a physician says, why do you even need to do that? Like an administrator, is there one on there? Ooh, we should have had one. We don't have any administrators. We're anti-administrators, or not really. Our administrators here are great, but because I'm one of them. We have a bunch of administrators who will say, how are you gonna afford it, right? So there's a bunch of people who get together, and I would say we've done probably 50, 60, 70 of these, and I'd say 5 or 10 are good ideas, which makes sense, right? Most ideas, when you learn in the business world, most ideas are bad. So get a bad idea, talk about it, throw it away, go to the next idea. So we try to do that a lot. We can do that so long as we are paying for it. We can't do it. Once you get a grant, the weird thing about a grant, I'm just telling you, don't tell anybody, but I'm just telling you, once you get a 5-year grant, you're gonna do something like that. You're not really free to pivot instantaneously because you don't want to give your money back. So the academic world intrinsically is slow and conservative, and if you want to make patients better, you're going to have a more nimble structure, which is part of what we're trying to do. I thought this was interesting too. Another thing we'll do, after the idea lab, like the next stage would be, okay, let's say a physician and an engineer get together, or a therapist and a neuroscientist get together, and they have an idea. But you can't just say, okay, do stuff. You have to pay for it. So we have these things called catalyst grants. And I'm really proud of this graph. This is, so we've been doing this now, you can see, for about 7 years. We have about 2,000 humans in the building. We probably have maybe, we have 200 or 300 therapists. We have, like I told you, 45 scientists, 80 physicians. But we've gotten 700 applications for catalyst grants. We get a lot of catalyst grants from non-clinical people. My favorite one is, somebody had an idea. One of my favorite environmental services guy said, we were out there like beating the bushes for catalyst grants. One of my favorite guys said, hey, I got an idea. Every time I wax the floor, and we do therapy in the hallway. Every time I wax the floor, people look like they walk funny. And I go, it's probably too slippery. He goes, I don't think so. And I go, why? He goes, because feel it. And I go, yeah, you're right. So we hooked him up with one of our therapists, and we did, here's the nerd in me, a 2x2 two-way analysis of variance, where we had shiny floor, dull looking, wait, let me do this again. Slippery floor, dull looking, sticky floor, shiny looking, and the various combinations, okay? And then we had the nerds set up sensors in the hallway and had people walk on the different floors. And this guy clearly showed that shiny floors that reflect light a lot, people walk funny in. It's not how slippery the floor, it's how shiny it is. So he came up with a new wax, and we're selling wax. We're in the wax business now. So this building is very entrepreneurial. We're in the wax business, we're in the plinth business, we're in the rehab device business. What other kind of business? We're in like the floor cleaning products business. and obviously the rehab business. And I will tell you, you know, obviously you have to always justify yourself to the board. In the end, we've put about $400,000 into these big grants, Catalyst grants, and those have turned into about $4 million, which is pretty cool. So there's a great return on investment. That's the way it's working in the research world. You'll see a little bit more. I know you're going to hear from 3 really good scientists this morning. I think it's cool that Iona is here, Prakash is here. Prakash better be here pretty soon. And Brenna's here. And they're very different types of scientists. So I think you'll see that there's a lot of that stuff going on. I'll be back at 4:30 to help walk you around. And other than that, I'll just say official welcome. Thanks.
Welcome, everybody. I'm Angela Harris. I'm the chair for the Community Council. Sorry, a little shorter than our speakers. Welcome to the Community Forum. It's been a couple years since we've done this in person. The past couple years have been virtual, so we're really excited about today. We have a lineup of some exceptional speakers today. So I live outside of Toronto, Canada. I'm a parent to an 18-year-old young woman who was born at 25 weeks. She has ataxia, dystonia, and spasticity. She just graduated from high school with honors, and she travels around the world in a marching band. So pretty impressed with what she's been able to overcome, despite some of her diagnosis, and as well, she has a hearing impairment. So the Community Council is a small group of individuals with lived experience. So some of our members have cerebral palsy, and some of us are parents of children and youth with cerebral palsy. We work with the Academy with many of the committees, and we're providing our views to, I'm only gonna get this microphone. Here we go. So as the Community Council, our members, we provide views to those of those with lived experience to the committees. So whether it's work with publications, whether it's with the care pathway committees, and also with planning the forum. We have some great speakers today. And outside of working on as a parent with a child with cerebral palsy, I'm also a nurse, and I organize our cerebral palsy clinics and our Botox clinics at our Children's Treatment Center as well. So I hope you enjoy the gift from the Academy today. I'd like the rest of our Community Council members, I'll just introduce you, just give a wave, but if you have any questions during the day, please feel free to reach out to any of us. And throughout the day, there'll be some other additional council members that will come. So we've got Jen Lyman there, Brenda Agnew, Lynn Fogel, and then at the back we have Amy Cutler. She's in Chicago, so she knows a little bit more than we do about the ins and outs of Chicago. But if there's anything throughout the day, just feel free to reach out to us with any questions. So thank you for today.
Well, I'm Jen Lyman, and I am thrilled to introduce the first of our hot topic speakers today, Dr. Iona Novak. It's truly my honor. Dr. Novak is here from Cerebral Palsy Alliance and Allied Health in Sydney, Australia. So she traveled from around the world to get here. Iona is an international keynote speaker and Fulbright scholar. She is widely regarded as a trusted source on evidence-based practice. Her research aims to discover, test, and translate new treatments in priority areas identified by people with cerebral palsy. Iona has made significant contributions nationally and internationally in early diagnosis and the discovery of new therapies. She's going to be speaking today on stem cells and giving us a stem cell update, and I've heard and seen some of it, and it's really exciting. So, Iona, welcome. Thank you.
Well, good morning, everyone. Can you hear me okay? Yeah, it's lovely to be here. I was saying this morning, this is my favorite session always of the American Academy Conference. So I'm really honored to be here with you this morning. And let's consider this a dialogue. If you've got questions and things, we can take them. So we're going to talk about this topic today, the potential of cell therapies for cerebral palsy. Where are we at today? So I think there's been a lot of hope in this field, and there's also been a lot of hype. So we're going to try and cut through and get a bit of a summary of where we're up to, because I'm sure if you have a go at trying to read about this topic, there's thousands and thousands of journal articles, and there's hundreds of web pages that sell you lots of good ideas. But where are we at scientifically, and what are the best possibilities? So I'm going to review this paper that we wrote recently. If you want a copy of it, that QR code will take you to the full text paper if that's something you'd like to talk about. So we've been doing stem cell research with people with cerebral palsy for 15 years now, and at least 2,400 people have had a stem cell treatment in a clinical trial. So that's actually a lot. It's almost more patients than in most of the proven interventions in cerebral palsy. So it's an interesting conundrum because there's been actually a lot of research, but there still isn't any treatment that's been approved. So we're going to have a look at why is that? Is it just hope or is it hype, and try and cut through to the bottom of that. So if we start a little bit further back, and those of you in the room will be even more familiar with this with your own lived experience, but there are a lot of treatment options for people with cerebral palsy. There are over 180 in the published literature. There's even more on the internet. So when you come to make a decision, should I do this or that, there's a lot of information to sift through. Another thing that's been happening is there's been a lot of work in the prevention of cerebral palsy. And in high-income countries, the rate has fallen by 30 to 40% in places like Australia. It's less certain in the US how much it's fallen because you have a different registry system to us. But we can see that very early interventions with mothers during pregnancy and with babies in neonatal intensive care is actually preventing some cerebral palsy. And for me, what that means that we can do more. It means that brain repair options are available. It's about timing of treatment, understanding the best treatments, and so this is an exciting fact. I guess it's also important to say we really understand a lot more about cerebral palsy and its causes these days, and we know that some of the cause of cerebral palsy is genetic. So that's why no two people with cerebral palsy are the same, the causes can be different, the presentations can be different, and that's why stem cell therapy is not really a one-size-fits-all. There's lots of cells and lots of different people. So we'll try and go through that. But what we are learning a lot more about is the different types of cells that might be helpful for people with cerebral palsy, which doses they need to be at, when to give them, and how to give them. So we'll go through these. So just to backtrack a little bit, if stem cells is not your jam and you're not very familiar, stem cells really have to do two things. So first of all, they have to be able to make copies of themselves, and we call that in science renewal. So they make copies, identical copies of themselves, like a big photocopier. The other thing they have to be able to do is choose a career. So if they don't choose a career, they're embryonic. If they choose a career and they specialise, or what we call differentiate, then they have a certain job. And once they've chosen a job, they can't go backwards unless you use a particular technology. So that means if it chooses to be a blood stem cell, then it's going to make more blood stem cells. It'll make white blood stem cells, red blood cells, etc. Whereas you can't use a blood cell to repair a brain, but you could use a brain cell to repair a brain. Do you understand what I mean? So the differentiation, the job it chooses, somewhat determines what the cell's capable of doing, what it's specialised for. So there are a lot of different cells under investigation for cerebral palsy. Some of the best known ones are umbilical cord blood, which comes from the umbilical cord, which most people are going to throw away. So it's an easy type of blood to collect and to store and to freeze. It can also come from the placenta, so amnion epithelial cells. Then we can have neural cells, brain stem cells, which are the ones, of course, we're very interested in with people who've had a brain injury. And then we can have other cells, so hematopoietic, which is a fancy name for blood, stem cells, and they can be in your bone marrow, so in your big long bones in your leg, in the femur, or they can be in your fat and knee joints. So you're probably making stem cells as you're sitting there in your joint tissue. And so how do all stem cells work? Well, all stem cells can have one of the following three actions, but some of them have more than one. So they could be anti-inflammatory. So I think we talk a lot about inflammation in conditions like arthritis and inflammation in general with a range of health conditions today. We're going to talk about inflammation in cerebral palsy. They might be able to replace damaged cells. So blood cells can replace damaged blood cells. Brain cells can replace damaged brain cells. So it depends on what they're differentiated to do to what they can replace. But they can also do what we call trophic effects. So that's about growing new things. So if you put a blood cell in a brain, it can't make more brain cells, but it can talk to all the structures around an injury and make more blood vessels, which produces more blood to an area that's injured, which can help heal. So there are lots of different things they can do, and that's why they help people with cerebral palsy in different ways. So this is an important chart written some time ago by Professor Donna Ferrero, who's a keynote at this conference, but we've added a little bit to it. So if you think about a brain injury and you think about it as a time of loss of oxygen, that's one way a brain injury can happen. We tended to think about that as minutes without oxygen or hours without oxygen, and we think about that as a short-term injury. But what Donna Ferrero was able to show is that injury pattern actually goes for at least a week. So even though you've got the oxygen back on board, your oxygen levels are back up, the cell processes that are happening in the brain, cells can still be reacting and some of them dying. So that process actually goes on for a week, depending on how long the injury was. But what we know now is in this blue bar that we've put on here, we've been able to show in work with people with cerebral palsy that inflammation persists at least 4 years after the injury. So it probably goes longer, it's just that that's where the studies we were looking at cut off. So there's this persistent inflammation, and inflammation, you probably know, isn't really healthy. It's great at the beginning of the injury because it starts a healing process, but then when it's not put in check, it can get out of control and make a lot of cell mechanisms do sort of naughty things. And so inflammation is very difficult if it's long term, but we know it's long term in people with cerebral palsy. But I said before that one of the jobs of stem cells is they're anti-inflammatory. And this is why we think stem cells might have a role for people with cerebral palsy, because there is this persistent inflammation. It's what we call a treatment target. So when we're starting to think about the timing of different cells, I've got down the bottom there in orange some of the things that work against the early injury and can rescue some of those cell processes are umbilical cord blood, mesenchymal stem cells, and hematopoietic stem cells. Whereas if you wanted to do something really late and all the oxidative stress and other processes are finished now and you've just got inflammation to work on, or you've just got a repair target, then you'd want to use a neural stem cell. So we're starting to understand more about the timing of the different kinds of cells. So what about safety? Well, there's, as I said, thousands of people have had cells if they have cerebral palsy now, but also in other indications. And we know that umbilical cord blood, it's been used for 50 years in a range of treatments, is very, very safe. It's safe if it's your own umbilical cord blood, and it's safe if it's a sibling's cord blood, and it's also safe if it's an unrelated donor. So that's been one of the questions, and that's been really important that we've been able to show recently that unrelated donor cord blood is very safe, because most people don't know before they're born they're going to have cerebral palsy. They don't store a cord blood unit, so it limits how feasible that treatment is. But we now know you can use an unrelated donor cord very safely, and so that's really going to expand options for treatments for people. And we also know that neural stem cells from a donor are safe. You can't, of course, use your own. I can donate a kidney, I can donate blood, but if I tried to donate some brain, I'd actually end up with a brain injury myself. So you have to actually, deal with brain stem cells in a different way. So there are also sorts of considerations that we think about with stem cells. So we think about, are they coming from yourself or coming from a donor? If they're coming from yourself, are your cells in perfect condition, or are we going to increase the injury by giving you more injured cells, for example? If they're coming from a donor, is it a good match with you, or are you going to reject the cells because your immune system works out, well, they're not my cells, I'm going to clear them. There are moral and ethical complexities, but the sort of cells we're thinking about are cells that have already chosen a job. They're usually in discarded tissue, so we're not worrying about this issue. We're thinking about umbilical cord blood, cells that have been donated by organ donors, for example, under consent. We think about how do they work, because if you want to fix a problem, you need to get a solution that actually matches the problem. So we think about something called mechanisms of action. And then you think about when and how much and what are the risks. So let's have a look where we're up to. So a paper that we wrote in 2020 is called the traffic light paper. And if you want a copy of this, there's the QR code down the bottom. But I'm just going to show you today just the section on the stem cell piece. I've just pulled that out. So just to orientate you to this graph to start with, down the vertical axis, at the top are the effective treatments, and at the bottom, the red ones are the ineffective treatments. Then we have this dotted line called the worth it line. So things can be above the worth it line, the worth doing, or below the worth it line. So that's sort of how the schema works. So if they're green, they're proven to work. If they're red, they're proven not to work. And if they're yellow, more research would help us understand more about this. But we're looking for yellow things that are above the worth it line. So just to say here on the stem cell section, we've got one green light, umbilical cord blood. The size of the bubble is how much research has been done. So the bigger the bubble, the more research. So there's actually been a lot of work done in umbilical cord blood for people with cerebral palsy. Over 22 trials have been done and over 700 children, almost 800 in a trial. And there's been many, many more people who've privately bought cells. And so we can say that this definitely works, and I'm going to show you some data. It's not yet approved, but it's definitely effective. It's actually more effective than rehabilitation by itself. So we actually need to work really hard as a community of scientists, researchers and families together to actually get this approved. So that's a really exciting sort of state of the science for cerebral palsy. The next one is something called mesenchymal stem cells, and over 1,000 people with cerebral palsy have also had those. So you can see it's a bigger yellow bubble. It's rising, a bit like champagne, rising up towards the green, and it'll probably go green at some point, but it's a promising looking intervention as well. And then neural stem cells and bone marrow have had a smaller amounts of research. They're smaller bubbles. We know less about them, so they're sitting closer to the worth it line. So that gives you a bit of a snapshot of which things are working. You can see we don't have anything in the proven not to work category yet, so it's actually a promising sort of field. So what's involved? Well, it really depends on the kind of cell that you choose, what's involved. So there are two ways we can put cells back into the body. We can infuse them, so something like a drip that you have in your arm. So if you infuse things and they're going to circulate, after a while your body will say, they're not my cells, I'm going to clear them. That's what your immune system does. But it can have a temporary treatment benefit. So while it's in there circulating, it can make other things happen. That can have a lasting or a permanent effect, but the cells themselves are temporary. They only stay different amounts for different times. So mesenchymal stem cells visit for a day, umbilical cord blood visits for about 3 months, and hematopoietic stem cells, it depends how you put them in, how long they stick around. But they have a treatment effect. So if you thought about something like Botox that has, you put it in, it works and it wears off, it's a little bit like that with anything you infuse. The other way to put cells in is called a transplant. So we usually put them in via surgery, and before the surgery we clean your immune system so that it doesn't reject the cells. So if you thought about having a heart transplant, you take anti-rejection drugs. It's a little bit like that. We clear the system down, the immune system. We put the cells in, we transplant them, and we also give you anti-rejection medication so that you don't clear the cells. And so that's a transplant. It's much more involved medically, but you have to do that for something like neural stem cells because they don't stick around otherwise and they don't have any benefit. So there are different, how invasive it is depends on which way you put the cells in. Where is it done? They can be done in hospitals. If it's an infusion, they could also be done in an outpatient service. Always you want a team that's very familiar because anytime you don't want to have an allergic reaction to the product or something like that, you want people on standby to be able to support. Who is it for? So as research progresses, we're understanding better about who to treat and when. So in childhood, we could think about umbilical cord blood, and we know it works better than mesenchymal, and that's probably because it sticks around a bit longer. In infancy, we think mesenchymal stem cells might be very helpful, and we can treat earlier. How much is needed? Well, there's a trend towards higher doses, but they're not interchangeable between the different cell types, so that's important. So where are we going next? I'll just finish with 1 or 2 slides showing where the field's heading. So we're going to see probably a big phase 3 trial next. So if you look at these different columns, that's the different phases of research. We start at safety, then we look at preliminary efficacy, and then we do a definitive trial, which is the red column, which is what a regulator needs to see. Something like the FDA needs to see something in the red column before they approve a treatment. That's what I think will happen next in the United States of America. We're using umbilical cord blood for CP, and that's when you'll get an approval number. I think we're getting close to that actually happening. This is data that we have recently done. It's unpublished, but just to show you that we've combined all the children around the world that have had umbilical cord blood. And the first thing we can see here is that there's what we call a dose response curve. So the higher the dose, the bigger the result for gross motor function. So this graph actually tells us that we haven't even hit the maximum dose we could go. So we could push doses higher. The field started really small, really conservatively, but we can probably go higher, which is good news for everyone that's had a small benefit, because maybe we could go up to a bigger benefit. And this curve, interestingly, perhaps it's a little bit disappointing, but perhaps not surprising, we can see an age response curve. So younger children do better. That's probably because they got more inflammation. So there's more cells for them to target. This is with umbilical cord. And lastly, we've been able to push these trials down into newborns. So we've been doing an umbilical cord blood trial in Australia with babies born very preterm. And we're also just about to open a trial for babies born with a stroke that are going to get 2 doses of mesenchymal stem cells in the first week of life and look at their outcomes to see if it reduces cerebral palsy. So if you want to understand a little bit more, you could go to this QR code. It'll take you to our website, and we've got a whole bunch of videos there that go through that with 2 of my amazing colleagues, Megan and Madison, who are scientists and are really good at explaining science. So thank you very much for your time.
So yeah, I'd like to introduce Dr. Brenna Argall. She's an associate professor of mechanical engineering, computer science, and physical medicine and rehabilitation at Northwestern University. Just gonna get yourself attached. I'll get out of your way a little bit. So she's the founder and director of the Assistive and Rehabilitation Robotics Lab here at the Shirley Ryan Ability Lab. So Brenna's gonna share her exciting work on partial autonomy powered wheelchairs and what the future holds for wheelchair users.
Thank you for the invitation to speak here today. So within the world of rehabilitation, of course, our first line of defense is to try to rehabilitate the body itself. But when a gap in function remains, we often fill that gap with functionally assistive machines. And there's a persistent challenge across this domain of how to control these machines, how to capture control signals from bodies with motor impairments in order to effectively control these machines. So this is perhaps most severely presented in the control of upper limb prostheses, where you have an array of EMGs that are trying to capture control signals to control a high-dimensional robotic arm and hand. But we even see this with powered wheelchairs. So a powered wheelchair is a 2-dimensional control problem. You control speed and you control heading. And we can see here with different levels of spinal cord injury, for example, the interfaces that are available for people to use. So you start out with a joystick, maybe even a 3-axis joystick, which you wouldn't need for a wheelchair, but you could use for another type of assistive machine that needed more degrees of freedom. A 3-axis joystick also has twist. And as you go up, you're limited now to head arrays and then to sip and puffs. And what happens as these interfaces become more limited is that they're limited in a number of different ways. So one is the continuity or the proportionality of the control signal. So you go from issuing a continuous control signal, where when you deflect the joystick farther, you go faster, to a discrete, where it's just flipping a switch on and off, and you're always going the same speed. You also get limited in the dimensionality of the signal, where instead of issuing a 2-dimensional control signal, you're issuing a 1-dimensional control signal. And so now you can't fully cover the full control space at the same time, simultaneously. This is all the more exacerbated as the machine itself becomes more complex to control. So this is the Canova arm, or the Jaco robotic arm from Canova Robotics. It's designed to be mounted to a powered wheelchair, and it's sold with this 3-axis joystick. Just to position the end effector of, or the hand of a robotic arm is a 6-dimensional control problem. You need to define or specify position in 3D and orientation in 3D. So already this 3-axis joystick can't do everything at once, and you have to cycle between what are called control modes. So you push a button, you can control in position, push another button, you can control in orientation, push another button, you can control the gripper. So now, if you need to use one of these more limited interfaces, you are switching between even more control modes, and it just becomes all the more cumbersome. So here's an example of what this can look like. So this is actually a Miko robotic arm, which is the predecessor, the research predecessor to the JACO, in my lab a number of years ago, being operated by someone with a high spinal cord injury. You can see that he is pushing the buttons with a utility cuff and a pen in the utility cuff, because he doesn't have the finger function to actually press the buttons. And that also you would have just seen, I think, just now. He actually did a mode switch, then tried to move the arm, saw that he was not in the control mode that he thought he was, and then had to mode switch again. And that's a very typical thing that needs to happen. And this is even using a 2-dimensional continuous interface. So to sort of recap what I just discussed, there's a number of challenges to assistive machine operation. The ones that I just highlighted are the human impairment itself. And this impairment will actually mask and filter the information that the person would like to provide to the machine. Then there's the limitations of the control interface that are accessible to them. And this interface is limited in its dimensionality as well as its continuity. And then there's this catch-22 of machine complexity, where oftentimes the more complex motor impairments require more complex assistance, and that usually requires a higher dimensional control signal, which is all the more difficult to provide. So one solution that the research field has been addressing for quite some time is to turn these assistive machines into assistive robots. And what happens when you do that is that you need to add sensors that are able to perceive the external world, So what this can look like, for example, this is data that's being pulled from a Microsoft Kinect. So if any of you have ever used an Xbox, the sensor that is looking at you when you use the Xbox is the same sensor as we had on the early version of my wheelchair. What it's providing is a camera image, and then you see how it looks like it's flickering. That's because there's hundreds of thousands of depth points, so points that are coming back with a specific location in 3D space, and this gives depth information back to the system, which you can imagine is very useful for autonomous robot navigation, so you know what not to drive into. So you add on this external sensing, and then you reason about it with computing and artificial intelligence. You reason about both the information you're getting from the sensors, but also the information you're getting from the human. So in general, it is often the case that people don't want a 100% driverless car solution. They want to still be in the control loop. And so we're getting signals from them through whatever control interface it is that they use to drive their wheelchair, and we're reasoning about this, as well as the sensor information that we're getting, and trying to figure out what it is that we think they'd like to do, assessing that signal that we're getting for safety, and then figuring out if we should modify it in some way to get them where they want to go, but to do it in a safe way. And so then once you've done that, you have an assistive robot. So just to position this work within the larger space of rehabilitation robotics, so I tend to think of rehabilitation robotics in 2 big bins. One bin is robots that aim to rehabilitate the human body. So the Locomat would be a great example of this. These are robots that are moving human limbs or supporting humans in some way to rehabilitate their own body. The other big category are robots that replace lost function. These are the ones I talked about in the beginning of the talk. They're bridging this gap in function. And when we think about adding autonomy to these machines, there's a distinction that makes a big difference. And it's whether or not they're worn on the body, like a prosthesis or an exoskeleton, and whether or not they're not worn on the body, like a wheelchair. And the reason why is because you have to add those sensors and that computing, and it needs to go somewhere. So if it's all embedded inside of your prosthetic limb, and then it's all that additional weight, and you had to somehow get it inside, and it's just hanging off of the arm, that is a much harder engineering problem to solve from a human factors perspective than just throwing it on the wheelchair that's already carrying the person and pulling from the wheelchair's batteries. Okay, so within this approach, The devil is really in the details when it comes to this computing and AI. Particularly, how are you going to share control with the human? So now you've got control information that's coming from your robotics autonomy system that can drive itself if it needs to, and from the human. And so how do you reason about how much to consider one versus the other, or when to prioritize one over the other? So when we consider that we should be developing assistive partial autonomy, there's a couple of things that my lab prioritizes. One is that the control sharing should be judicious. The reason why is because if the autonomy steps in at the wrong time or with the wrong signal, they're actually taking control away from the person. They're making them less able, which is exactly what we are not trying to achieve. So you can imagine, perhaps in the exception of cases for extreme safety, that just not doing anything is actually the better thing to do, to not intervene. And then also the fact that the information that we're getting from the human is masked and it's filtered. Their true intent is masked and filtered both by their motor impairment as well as the interfaces that are accessible to them. All right, so I'm going to talk about this judicious control sharing first. So these are all control sharing paradigms that come from the robotic wheelchair literature. So these are academic researchers involved in what are called smart wheelchair research. These have all been published. And the way that they differ from each other is that the way that this is color-coded is that the signal you're getting from the human is in red. The signal that you're getting from the autonomy, so this is the robotics autonomy, is in blue. And then the signal that you're actually choosing to execute is in purple. And there's a couple of different things. So one thing is that the human is actually, or the autonomy system is actually trying to infer the human's intent from the control signals that they're getting. So you can see at the top, we have a paradigm for what we call immediate goal inference, where we basically just take the human's control signal, we forward project it a half second in the future. So we're saying, I don't think I know that much about what you're trying to do. I'm just guessing if you said go forward, in a half second you'd like to be there. That's all the inference we're making. And then we get a temporary sub-goal to send to our robotics planner that can plan a safe path to it. We also have higher level algorithms that you see on the bottom here, for example, that can detect a doorway. And so you can detect that this is a feature of the environment that often is difficult to navigate. And so we're going to say that that is actually our navigation goal, if we're getting the right signals from the human, that it seems like that's where they want to go. And you can see that depending on what goal we choose, the planner is going to do different things. And depending on how we're then arbitrating between the human and the planner and the autonomy planner's signals, the actual purple arrow that we're going to get out of it changes as well. So we might blend the two. So you just sort of find something in the middle that's safe but as close as possible to the human's control signal. It might be that we filter it. So we basically say the human signal just can't exceed the autonomy signal. We're going to keep the human signal, except we're going to scale it down so that it's safe. Because we're presuming that the autonomy signal is safe because it has this sensor information from the environment. Or we can do something that's a little bit more aggressive, like switching, where we basically say, we're going to get you close with your control signals, we'll get you close to the door, and then to actually get the door, we're just going to take over the control 100% just for navigating through the doorway, because that's a tough thing to do. And then we'll give control back once we're on the other side of the door. So we implemented all of these on my robotic wheelchair. This is not something we had seen in the literature before. We had seen lots of comparisons of partial autonomy to full autonomy, or full or partial autonomy to no autonomy. But a side-by-side comparison of these different ways to share control we had not seen before. So we implemented all of them, and what you might notice is that they don't look that different from each other. And this is what we saw in the data too. According to the measures that we normally use to evaluate robotics autonomy, like number of collisions, task completion time, none of them were statistically different from each other. What we did see, however, was a difference in preference. So we asked everyone to rate their most preferred and their least preferred, and we allowed for as many ties as they wanted. And what you can see is that while we do have a general trend of some being more preferred in general, every single paradigm was actually chosen at least once by someone as their most preferred paradigm. What we also saw, and we did have some work also where we tried to predict that preference using just computable data from the wheelchair. What we also saw is that about 50% of the time people switched their preference when they switched the interface that they were using. So all of the participants in this study came in one session day, they used the joystick, and in a second session day, they used the head array, and we switched which one came first. You see here that there's 2 to 4 sessions. That's actually because the sitting tolerance of some of our spinal cord injured participants meant we had to split some of the sessions in 2. But it meant that everyone, the interfaces themselves happened on different days. And so what we don't really know is whether or not this switch in preference had to do with the interface itself, or if it's just an overtime, if it was familiarity with the autonomy. But our big takeaways from this study were basically that we should be giving people options, and we should expect that those options will change over time, or that people's preference over those options will change over time. So I'm going to add to my list here that one thing that's missing within the literature of this work are longitudinal and real-world evaluations. So typically when people come into academic labs and evaluate one of these shared control paradigms with robotic arms or robotic wheelchairs, they come in for one session, maybe 2 sessions. So we are always evaluating novel interactions with these technologies. And obviously, that is not what things are going to look like necessarily long term. We all change in how we interact with technology over time. You compound that with the fact that actually people's bodies are changing as they're undergoing rehabilitation. And so we know that things are going to be changing over time, and we have not studied that yet, we as a field, my lab included. So this study and a number of other studies my lab had done established for us the need for customization. So then the question is, how do you actually achieve it? How do you achieve it so that this system can change on its own and do it in a way that is not going to throw the person off because it's changing and now they can't anticipate what it's doing, but is still changing enough to meet their needs? To start answering this question, we performed in my lab a large-scale usage characterization study. So what this looked like was that we had 62 sessions. We had 20 spinal cord injured participants and 42 uninjured participants. And we had them operate 3 interfaces. The uninjured participants operated all 3 interfaces. The injured participants operated the interfaces that they could. So we had a head array, we had a joystick, and we had a sip and puff. And we also had 7 tasks. So and for those of you who are going on the tours later today, you'll see this obstacle course that we have, this wheelchair obstacle course that we have up on floor 19. This is where my lab evaluates our robotic wheelchair. It consists of a number of characteristics or environmental features that can be difficult to navigate in a powered wheelchair. So this is where we do a lot of testing, and actually inpatients use this as well. They do use this a lot for therapy. And then we did, at the start of each session, we gathered 3 baselines. One was a clinical standard that some of you maybe are familiar with, the wheelchair skills test, and 2 of them were tasks that we developed on our own. And these were virtual tasks. One was a command following task, where we would just present a target prompt as an arrow, and we would ask people to reproduce it with their interface. And then the second was a trajectory following task, where we basically had an outline, a very crude outline of a 2D wheelchair, and a direction prompt that said, go this way, and then you're trying to stay on that white path, or you might have a direction prompt that's telling you to go backwards. And what we were trying to do with these assessment tasks was try to decouple operation of the wheelchair itself, which can be complicated by the environment, by perception, and just see how well people can actually use the interface, operate the interface, and also do a little bit of path planning in their head and operate the interface. What we weren't expecting was how much we would get from this. So we first published our initial findings from just doing this first 5 minutes of data collection in each session in ICAR in 2019, and then we've actually continued to evolve this. We've turned this into an app that therapists can use. We have a beta release on the Android Play Store, and we're currently having therapists evaluate this in my lab. So it's available free to download. It is still very beta, but certainly send me an email if it's something that you might be interested for yourself or clinical teams that you work with. All right, so when we did this initial analysis, one thing that we saw was that between the interfaces, we did not see a significant difference in success. So whether or not you're using a joystick or you're using a sip and puff or a head array, everyone, the ability to eventually reproduce that arrow command prompt was similar across, not statistically different across all the interfaces. What we did see, however, was a difference in response time. And this has a number of different implications for robotics autonomy that I don't really have time to get into here. But one thing we looked at additionally was that all of our spinal cord injured participants were an expert in one interface because they're wheelchair drivers in their daily life. So we divided out their data into the interface that they were an expert at using and the other interfaces that they were not experts in. And what we saw was that this difference in response time started to normalize. So it also can improve with expertise. And so this, again, is telling us that people are going to be changing in how they're interacting with machines over time. So we thought we were onto something here. And this has actually initiated a whole new line of research in my lab that we're calling interface-aware assistive autonomy. And what we're doing is we are actually modeling the person, a specific person operating a specific interface, and we're reasoning about that. So we can now think about when we're going to provide robotics assistance, we can now think about if it seems like this isn't the signal you wanted to give the wheelchair, because, for example, it's about to run into a table. Are there characteristics in how you tend to operate your interface that would suggest that actually maybe you meant this other signal that sometimes you issue instead of this, and we can then send that other signal to the machine. So that's the general flavor of this work. I don't have time to go into any more of this in detail, but it's an exciting new direction for my lab, and we don't know of anyone else within the assistive robotics field that is taking this view or this approach to providing assistance. Okay, I will actually skip over this in the interest of time. The final thing that I wanted to speak about today is that my lab is involved in an exciting initiative that's being offered through the National Science Foundation. It's their Convergence Accelerator Program, and this is aimed at specifically translating technology out of research and into the real world. I'm leading team H354, and what we are aiming to specifically address are barriers to independent mobility. There are two barriers that we're focusing on in particular. One is a dearth of control interfaces that are able to capture control signals from bodies with motor impairments wherever they have residual movement. So not requiring people to meet the form factor of the device, and instead having the device conform to the user and where they have motor ability. The second is a relative lack of assistance, safety assistance, but actually even just driving assistance options in powered wheelchairs. So we have all seen throughout the rest of society driverless car solutions, like robotics autonomy showing up all over the place, even just in our regular cars, right? Things like parking assist, lane assist, emergency braking, that kind of technology, there's no reason why that can't exist on powered wheelchairs. And so we are trying to get this technology out to market. We have a really great group of partners on this that include nonprofits and as well as industry. And I'm going to highlight in particular Lucy, which some of you may have heard of. Lucy is an aftermarket add-on to powered wheelchairs. It was the first and remains the only sensor-based safety system add-on for powered wheelchairs. They entered the market in 2020, and the kind of assistance they provide is what's called subtractive only. So they will stop you. They will, if you give a signal that's in this direction, and actually right there is going to be an obstacle, they'll maybe remove energy from your signal selectively so it looks like they're steering you, but they're actually never adding to your control signal. And of course, there's a lot of things that you can do if you actually have that active assistance. And so that's what we're doing in this project. We're adding my lab's active autonomy assistance into the Lucy system. So right there you can see the new wheelchair in my lab. We got this chair about 15 months ago. It was donated to us by Sunrise to be able to do this work. Lucy donated to us a system, and we rebuilt my lab's robotic wheelchair on top of the Lucy system, which is far more stable in terms of the sensor information it provides, because it's not cobbled together with academic levels of rigor. And so that's a major thing that we're doing here. And the third component to our work is what's listed here as thrust 2, the digital input mechanism. So right now, many of you might be familiar that the way that the wheelchair interface communicates with the wheelchair control system is through a 9-pin DBN serial cable. It's a printer cable, right? It can't be brought into the digital world. It can't be updated. It cannot provide bidirectional communication. And what we're developing is a digital API. It's actually already released, but we're expanding its capabilities. A digital API that uses common human interface device, HID protocols, for how to communicate between the wheelchair and the wheelchair's control system and any input device. So what this is enabling, because it's digital, Right now it works with Lucy because Lucy provides USB and as well as Bluetooth capabilities on the wheelchair. So you can actually connect any interfaces that get used for gaming, which there are much more advanced interfaces for gaming, for example. You can use that now to control your powered wheelchair. And what we just submitted 2 weeks ago, our phase 2 funding. So this was phase 1 funding, which is pretty much just to prepare you for phase 2. It's a 12-month grant. We've got 2.5 months left on it. And then for phase 2 is when you have 2 years of funding to really accelerate and get this all out the door. So we've submitted our phase 2 funding. I think about a third of teams who have phase 1 funding will get phase 2 funding. But fingers crossed, if we are able to do if we get the funding and we're able to do what we promise in that grant, it should be that active assistance is getting rolled out with Lucy products within about 2 years from now. And that also this new interface that we're developing, we're hoping to have sort of pre-production prototypes. We won't yet be to market yet, but we will be sending it to people to evaluate. And our aim is that our communication protocol will actually become the standard for powered wheelchairs. So that's all. I'd like to thank my current PhD students and some alumni whose work was featured in this talk. And I don't think we're taking questions, so I'll be happy to take your questions later. Yeah, okay.
Okay, so I'd like to introduce Chad Henawoka. Chad is a fourth-year medical student from Northwestern School of Medicine. Chad will be discussing his work with Dr. Jaya Balan, who's also here today, whatever heard, yeah, on metabolomics. So they're looking in the investigation of difference in metabolic markers in walking adolescents and young adults with cerebral palsy compared to those without. So their team's looking at using biological markers to develop novel, individualized rehabilitation regimes and exercise strategies for individuals. So thank you, Chad and Dr. Jaya Balan for coming today.
Hello, good morning. Good morning, everyone. Thanks so much. It's a true honor to be here to share our work. And on behalf of Dr. Jaya Balan, Dr. Dayanidhi, and the rest of our team, we're really excited to share the work that we've been doing on sort of a bigger project looking at adolescents and young adults with cerebral palsy and specifically looking at biomarkers. But today we're going to be really focusing on altered systemic metabolomics in ambulatory young adults with cerebral palsy. I have nothing to disclose. Sorry, there's... The animation didn't go through, but if you can see through this here, I'm going to kind of explain the text that you should be able to read behind this banner here. But essentially, so cerebral palsy manifests across a wide spectrum of functional capacities as characterized via the Gross Motor Function Classification Scale, or GMFCS, ranging from 1 to 5, from least to most functionally impaired. And even in those who are able to ambulate or walk independently, it has been shown that individuals with cerebral palsy spend more time in sedentary activity or are less active than the general population. And it is also associated with higher rates of numerous comorbidities or concurrent medical conditions, such as things like diabetes, high blood pressure, asthma, osteoarthritis, osteoporosis, and a number of physiologic abnormalities or alterations in the way that the body at the cell level operates to carry out function. And some of these things include altered cardiometabolic health, so like I mentioned, higher blood pressure, inadequate nutrition intake, as well as higher energy costs with activity, so requiring greater energy to perform certain functions, as well as reduced muscle mitochondrial content and activity with disuse. And so if you remember back to grade school science, the mitochondria is the organelle within the cell that helps to produce energy. And so in cerebral palsy, with disuse, you see in the muscle reduced mitochondrial content as well as activity, so less energy production. And so all of these findings really beg the question, could there be potential alterations in metabolism in individuals with cerebral palsy? And what metabolism is it converts the food and nutrition that we take in into energy. And one sort of new emerging field that has come up as a way to assess underlying metabolism is systemic metabolomics. And essentially what that does is it enables us to assess sort of from a big picture view the overall metabolic state of an individual by looking at specific metabolites or proteins and molecules in a patient's blood that can signal potential alterations in metabolism, or the way that we use that food and convert it into energy. And no study to date has really looked at systemic metabolomics between individuals with cerebral palsy compared to typically developing individuals. And so here from this banner that has been covering my slide, essentially it was the goal of our study was to systemically assess for potential differences in the metabolic state of adolescents and young adults with cerebral palsy compared to typically developing individuals. And so overall, we obtained serum samples from 38 individuals, 19 with cerebral palsy and 19 typically developing individuals. And in order to meet inclusion criteria for the study, participants had to be between the ages of 13 to 30, able to ambulate with a gross motor function classification scale of 1 through 3, and could not have had a prior lower extremity surgery within 6 months of participating. Additionally, in the typically developing group, individuals could not endorse any history of prior or current knee or hip pain. And what we essentially did was we drew blood samples from all of our participants through an IV. We spun it down through a centrifuge and separated the red blood cells from the plasma or serum. We stored that plasma and then ran it through a mass spectrometry analysis, which basically can tell us differences in relative abundance of what we looked at 261 different metabolites. And we were able to assess those metabolites for potential alterations when we compared the CP group compared to the typically developing group. And we also obtained functional measures by looking at the time that it took to walk 10 meters, to rise from a seated position. And we also used a Biodex dynamometer, which assessed lower extremity knee flexion and extension strength. And we correlated those functional outcomes with metabolite levels to see if there are any meaningful trends. And so here on the left, you can see the demographic breakdown of our participants, who were quite similar, aside from the cerebral palsy group being slightly younger with an average age of 19 years compared to 20 years in the typically developing group. And in the CP group, there were about approximately 2/3 of the cohort were GMFCS 1 and 2, and predominantly spastic type CP. And on the right here, you'll see a principal component analysis. And essentially what we did was we took the 261 metabolites across 38 participants, lots of variables there. And what we did was we condensed that into fewer variables to be able to assess, are there general differences between the two cohorts of CP versus TD. And you can see here in red is the cerebral palsy group, and in green is the typically developing group. And you notice how the data points, and each data point is a participant, they tend to cluster based on those groups. So what that essentially tells us is there are sort of big picture from a 10,000-foot view, there are significant alterations or differences between the metabolic profiles in these individuals. And on the left here, you'll see a metabolite set enrichment analysis, which basically, from a big picture, looking at specific metabolic pathways, indicated to us that there were certain metabolite sets that were altered in cerebral palsy. And on the right, with our pathway analysis, we look specifically at individual metabolites. And just to orient you, on the bottom here, you'll see on the left CP1 to CP19 were our cerebral palsy participants, and then TD1 to TD19. And you can see just grossly, based on the color difference, the relative abundances were pretty stark in terms of the contrast of metabolite levels. And in particular, you can see on the right-hand side at the top, spermidine and spermine were two metabolites that were relatively increased in the TD group, whereas the vast majority of the other metabolites were relatively increased in the CP group. And we also conducted a volcano plot analysis, which essentially helps us to visualize the magnitude of difference another way, with metabolites in red representing those that were significantly increased in CP, and metabolites in blue representing those that were significantly decreased. So you can again see spermine and spermidine in blue on the top left were significantly decreased in cerebral palsy, and then all of these metabolites in red were significantly increased, with those located in the upper right-hand region representing those that were most significantly different. And so when we took a closer look at the metabolites in that upper right-hand region, you can see here in blue is cerebral palsy, and in red is typically developing individuals, and you see for each of those metabolites the significant difference in levels, but they also fell into a number of subcategories, including essential and conditionally essential amino acids, metabolism breakdown products, and TCA cycle substrates, which I'll discuss in a little bit. But essentially, this gave us some potential indications as to underlying pathways that could be altered in cerebral palsy and leading to the trends that we were seeing in these metabolite levels. And when we analyzed the metabolites in relation to functional capacity, we found that valine was moderately correlated with function, such that higher levels of valine were associated with greater functional capacity. So you can see the graphs here on the left. You see valine in that vertical axis, and then you see that higher levels of valine were associated with greater knee extensor and flexor strength, and was also associated with faster 10-meter walk times, as well as time to rise from a seated position. And similar trends were also observed for a number of other metabolites, with each metabolite being associated with greater function for a specific functional measure. And importantly, in the TG group, there were no significant metabolic correlations to functional measures. And so overall, our findings demonstrate that the metabolic profiles in individuals with cerebral palsy is significantly different than that in typically developing individuals. But it is important to note that this represents a difference in abundance, but our data cannot definitively tell us whether this is due to particular underlying underlying causes of altered metabolism. But what we can hypothesize based on our current understanding of the metabolites that were most significantly different, which I'll walk us through here, as to potential pathways that could be altered in cerebral palsy and have significant clinical implications down the road. So first on the top left here, valine is a branched chain amino acid. It's involved in protein synthesis for muscle growth and can also be broken down from muscle cells for energy use and yield 2-ketoisovaleric in the process of breaking down muscle. And so relatively higher levels of valine and 2-ketoisovaleric acid in cerebral palsy could signify increased muscle breakdown, increased energy expenditures, or decreased branched chain amino acid breakdown. Tryptophan is another essential amino acid like valine. It is broken down via two different pathways, one of which is the kynurenine pathway. And the kynurenine pathway has been shown to be upregulated in skeletal muscle following endurance exercise. Thus, increased tryptophan, increased kynurenine, and increased kynurenic acid that we saw in cerebral palsy could be a sign of increased skeletal muscle activity and energy expenditure in cerebral palsy, as would be seen with endurance exercise. And histidine is an essential amino acid, and it's involved in the synthesis of carnosine. And essentially what carnosine is it works within the cell to prevent the buildup of toxic metabolites that can cause impaired skeletal muscle function and increasing skeletal muscle fatigue. And so higher histidine levels in CP could underscore lower carnosine levels and lead to increased skeletal muscle fatigue and an impaired function in cerebral palsy. On the bottom left here, you'll see these metabolites, which were the TCA cycle substrates. And the TCA cycle is what occurs within the mitochondria to generate energy. And so seeing higher levels of these TCA cycle substrates could be a sign of increased energy expenditure and an increased need for energy generation in the mitochondria. And creatinine is something that you may have heard when you go for your annual visits and you get your labs drawn. It's a marker of kidney function, but it also is directly broken down from muscle. And so increased creatinine in cerebral palsy could be a sign of increased muscle breakdown. But it is important to note that individuals with cerebral palsy have also been associated with higher rates of kidney disease, and so that could be a potential confounder for these levels that we saw. And then spermine and spermidine, which is the one that I pointed out earlier, Their exact role is still under investigation, but current animal models have shown anti-breakdown properties in skeletal muscle with spermidine. And spermidine is believed to be involved in the activation of autophagy. And what autophagy is the body's cell housekeeper for damaged organelles, so like the contents within the cell, that can build up and cause accelerated muscle atrophy or age-related muscle atrophy. And so autophagy helps to prevent that from happening. But spermidine and autophagy have both been shown to decrease with aging. So what we see from our study is that the decreased spermine and spermidine levels could be a sign of decreased autophagy, leading individuals to be predisposed to premature aging and muscle atrophy. And then lastly, when we correlated the metabolites to functional outcomes, we saw that higher levels of these metabolites were associated with greater functional capacity, and this could point to the possibility of the importance of these metabolites, and specifically many of these amino acids for movement capabilities in cerebral palsy. And so overall, I think our findings really have significant clinical implications down the road, because when we see sort of the general trends from our findings, we see increased skeletal muscle breakdown, increased energy expenditures, and we already know, as I had mentioned earlier, that in individuals with cerebral palsy, they tend to have inadequate nutritional intake to meet the demands that their body requires. And so our findings could have significant implications to optimize nutrition to meet the increased energy demands, as well as promote functional longevity in cerebral palsy. And certainly there were some limitations to our study. Of note, 15 of the 19 participants were higher functioning individuals with cerebral palsy, which could alter or skew the functional outcomes, as well as some of the metabolic trends potentially that we saw. And as I had mentioned earlier, these were systemic metabolites, so we drew them from the blood. But again, they can only tell us differences in abundance or concentration, as opposed to specifically what is going on at the tissue level with different metabolic pathways. And then lastly, these were non-fasting serum samples, which some of the metabolites, particularly the essential amino acids, are exclusively obtained in the diet. So that could potentially be a factor that could confound the findings that we saw in some of these metabolite levels. And so clearly, I think our work would encourage further investigation into sort of the underlying pathophysiologic mechanisms that could be contributing to these metabolic trends that we observed in this study. And so there are many people I'd like to thank, but I especially like to recognize the amazing participants and families who took part in our study, and as well as Dr. Jayabalan and Dr. Dayanidhi and the rest of our team for their incredible work on this project. So with that, I'd be happy to take any questions.
So thank you for our hot topic speakers. And we've got a couple minutes before our next panel. If anybody has any questions for any of our hot topic speakers.
I do have a question about the technology and the robotics, and just as I'm watching that, my son actually uses foot pedals, so you can add that for your slide next time.
Yeah.
It's another option.
Yep.
But I think where I'm challenged, and I'm really excited about the technology, I think but where I'm sort of challenged with the work is, I do take exception to the word rehab, and that's my own personal, our kids are not being rehabbed. They didn't have the functional ability prior.
Yeah.
But when I see the studies on spinal cord injury, again, I struggle with that because they're very, very different. You know, my son, again, GMFCS level 4 or 5, he has function of his right leg. He doesn't have those impairments that you might see with a spinal cord injury.
Yeah.
And so I'm curious to see, like, you know, the studies are only the studies so far. But when I see that, it's hard for me to equate what's happening there with children who have cerebral palsy, who are on a very different scale, who don't have injury to their spine, who have function in way different ways. You know, so I think that it's hard for me to grasp the possibilities beyond that, because I'm only seeing spinal cord injury. And again, those are adults who have sustained an injury, who prior had function, who no longer do.
Right.
Very, very different than our kids with CP. So when we're looking at that, I guess for the future, you know, where is this taking us as far as the ability to assess these technologies and these opportunities for kids with cerebral palsy?
Yeah, so I'd say with my lab's research, it comes down to how it is that you interact with an interface, how it is that you interact with an environment. That is what the robotics technology is helping out with, right? It's helping avoid collisions. It's helping get you to where you want to go, and maybe the signals you're issuing aren't quite getting you there. So our patient population that we started with being spinal cord injury was for two reasons. One is that we usually start studying in adults, and at this hospital, that is our biggest patient population outside of stroke. And so when I'm looking at recruiting participants in my studies, that's just what makes sense as a first step.
Right.
That's not where we're staying. I will also say that Lucy is used extensively by people with CP, including children.
Okay.
They've actually had it happen that people can get prescribed a power wheelchair that otherwise couldn't, because they can demonstrate that with Lucy, they can be safe. We're hoping that makes a difference in schools, right? When children maybe can't use their powered wheelchair in schools, but maybe with Lucy or with assistive technology, they'd be allowed to. So it's certainly on our pathway. Awesome. Lucy's already getting there. They're ahead of my lab, but I'm collaborating with them. So I'm hoping that, and the studies that we're planning, if we get that phase 2 funding, the studies that we're planning will be across, we're not limiting what diagnoses. It's if you're a powered wheelchair user, and we're going to try to get a spread of interface types and injury types, or diagnoses, disease types, everything.
I love it. I love your comment about the power chair with your school piece, because that's a point that we're at right now.
Yeah.
And we're having the conversation. He's 16. I'm trying to explain to him this is no different than his friends getting a license and having to control an automobile. You need to be the same conscious.
Yeah.
But the hesitation for him to bring that in is it's a big piece of motor equipment that can hurt people.
Right.
And he doesn't have the best accuracy with respect to how he's utilizing it. So that's really encouraging to hear.
Yeah.
Yeah.
And there are other aspects we need to consider as well within that. So, for example, are kids going to try to confound the autonomy, or are they going to always jump in front of it because it's kind of funny, right? And then the autonomy, like the kid can't actually drive their wheelchair. Lucy has a manual override. We'll always have a manual override. So we can get around that. But we're thinking about all those things.
Great. Thank you so much.
Of course. Do you use Braze at all? Braze, can you? Oh, yeah, that came from, that's in Canada, right? The Puja, yep. No, I've never used that technology, so I don't quite know how it compares, but I believe that's an alert system, correct? It doesn't actually add to your control system. Right, yeah, which is a great complement to this. And Lucy does give some feedback, but it also actually intervenes in your control signal. Yeah.
I think the thing that stood out to me, interestingly, is when you talked about how when people came into the clinic at different times and trialing different equipment, that was more maybe one of their preferred methods. And I just think about when we take our kids in for equipment and we have to, in one visit, decide what we're going to be using, with trialing limited options that are available, often getting a short-term loan, things like that. And I just think about how challenging it must be, for my daughter when we have to make a decision about her equipment and we don't have the time and all the resources necessarily to make a really, a long-term 5-year decision that we have to make in a really short period of time, and how that really can impact how someone is able to navigate the world.
Absolutely, and that, I don't have a great answer to that for the wheelchair hardware itself, but that is something we're trying to address with this flexible interface, because as someone's ability changes, so what we're doing is we're developing wireless sensors that you'll just stick on the body wherever it is that you have movement capability, and then we'll have an app that basically says, all right, stick your sensor, then move the way that you want to move in order to have the wheelchair go forward. Move the way that you want to move, and to do something like that. And if you wake up the next morning and your tone is different, you put it somewhere else, right? And so, and we have partners on our team with ALS who have degenerative conditions, and lots of times they jump straight from a joystick to an eye gaze interface, just because they don't know how quickly, from an insurance perspective, you don't know how quickly you're going to degenerate, so these intermediate interfaces along the way that perhaps could be useful in the short term, they just skip straight over it and go straight to eye gaze, which is a much more limited interface, single channel, right? You point and click with your eyes. And so the idea with this is that you have now control over the interface changing as abilities change. And so at least from that perspective, it could perhaps help a little bit that you're not investing, you're not committing to a 5-year placement, right? Sure.
Thanks for a great talk, Iona. I just had a very broad question. which is, based on the phase 2 clinical trials, obviously you did a great job with like sort of talking about stem cells, but stem cells have so many flavors, as you know. So would you be sort of like talk a little bit about what you think are the mechanisms of action for why umbilical cord blood cells would work through IV? And where possibly could the mechanisms of action be in terms of improving the gross motor functional capacities that you see?
Yeah, thank you. So umbilical cord blood has two mechanisms of action. It's anti-inflammatory, and it also includes mesenchymal stem cells, which are very anti-inflammatory as well. So umbilical cord blood is a mixed stem cell population with quite a few actions. So it's definitely anti-inflammatory. Secondly, it's trophic. And so it does improve the blood environment in the brain. So it crosses the blood-brain barrier when you put it in a drip. It will help with circulating inflammation, but inside the brain, it also triggers natural regeneration processes, so such as the building of new blood vessels alongside injury, which can support new growth around the area, and it can trigger sort of growth of more tissues to assist repair. So it's never going to replace the injury, and it's never going to replace the cells in the injury, but it promotes health around the site of the injury, and that's why we think it works, and it's why the anti-inflammatory properties, why we think it still works in 3-year-olds, as we could see on that data, because they have persistent inflammation.
Hi, I have a question too on stem cell. Do you think, you're talking about children, do you think stem cells will help in adults? Because my son is 30, and of course, we didn't have this back 25, 30 years ago. So what are the chances that this could help somebody that's already 30 years old?
Yeah, great question. So we can see in the umbilical cord blood studies, it's certainly been tried in young adults, and on average for the whole group with different ages it works. That's why we went back and did that individual patient meta-analysis, so we could see not just the average but an individual patient level. So it doesn't look as effective in older children or adults that it does in infants. However, we do think neural stem cells would still be helpful for adults. So there are many complexities to using neural stem cells, but they could technically be used at any age. So the complexities of using them is you have to use a transplant, because if you put those cells in a drip, they will not cross the fence around the brain, we call it the blood-brain barrier, and they don't get in there. So you have to place them in there, which means you have to have neurosurgery to place the cells in the first place. These cells, they don't like traveling, they don't like luggage, they don't like suitcases, they only move if they're inside the brain. So you have to place them there neurosurgically. The surgery itself is a little bit scary, of course, to sign up to neurosurgery always, but it's the same type of surgery they use with Parkinson's disease. So they take 4 MRIs, they build a model of your brain, they can practice the surgery, they can place the cells within a millimetre of where you want them with the injury. So actually, when it's been tried in preparation for cerebral palsy, very low complication, like 0 complication rate from the surgery themselves. The most difficult problem is the anti-rejection drugs of the cells. You have to take them for a long time, the anti-rejection drugs. So it's technically feasible. It's been shown to work in children in preparation for cerebral palsy. We actually had the money for the study. We had the site for the study. We had the cells for the study, but we couldn't find a single insurance company in the world that would actually insure us to do the trial. So we're a little bit held up. At the moment, it really, really frustrates me. I still think there's a lot of promise in that space. Yeah, it's just a little more complex.
Now, when you're talking about anti-rejection drugs, are you talking about like a cyclosporin or Imuran, a steroid-based?
Yes, that's the type of drugs we're talking about, yeah.
Okay, and do you have to get rid of so that you don't have rejection? Is there something that they do, like, to get rid of your immune system?
No, not beforehand with a neural stem cell transplant. You just need to take an anti-rejection drug afterwards. And we did see in the other early data that they asked people to stop at 6 months. Most parents in the trial said, you know what, I'm not giving up these anti-rejection drugs. So they actually could compare the people that kept taking them versus those that didn't, and those that kept taking had a prolonged benefit, and that's because the cells don't die. They stay where you put them. So we do think it's probably long-term anti-rejection. But there's a lot of expertise in transplant using anti-rejection drugs. So they're complex drugs, but we do think it's possible to use them long-term in cerebral palsy.
His father had a bone marrow transplant for leukemia, so he's been on anti-rejection medicine for 31 years now, because his bone marrow, he has chronic host versus grafts. So there are problems with anti-rejection, but if you keep watching them, you know, keep it under control. So
Yeah,
sounds
everybody
good.
needs a family like you.
Okay, I think we've got one last question. Do you have a question? Yeah.
Actually, my question is quite similar, and it's to Dr. Novak. What are sort of the differences that you've seen in GMFF1 children? Because I'm a parent of a 16-year-old, he's in that profile, and a lot of the people in my community, the CP community, are similar parents as well. So they're not so subscribed to the stem cell transplant because it is a very invasive surgery. So I'm just wondering, what kind of results have you seen in that for that population?
Yeah, so we do see in using umbilical cord blood in young children with GMFCS 1 to 3, they have a result that's twice as big as rehabilitation from one infusion of umbilical cord blood. So that's a really interesting phenomenon because I'm trained in rehabilitation, but it might take 90 hours of practice to get the result that you're getting from 20-minute infusion. So for me, the thinking is, well, you guys are all time poor, it's difficult for people to go to rehab. If we could get both to you, you could get a double result because they're working via different pathways. And so my ultimate aim would be to work with governments to get an approved indication for a simple procedure that you can have cells on top of rehabilitation. It might save you some time and some effort. Yeah, but in a 16-year-old, probably rehabilitation is the best pathway, not umbilical cord, unless we get you know, a neural stem cell to work. But I hear you would have to weigh up the benefits of a surgery against the potential benefits of a cell.
All right, thank you to our amazing panel for coming today. All right, and we're our next speaker. Okay.
All right, our next presentation is going to be on transition. My name is Lynn Fogel. I am also with the Community Council. I am a past chair of the Community Council, and it's really exciting that we're back here for an in-person community forum this year. I have a 21-year-old daughter with CP. She's a GMFCS4 and spastic triplegic. And I've been really, I've gotten so much out of my work with Community Council. I would encourage any family member who's here to look into getting involved with council if you have the time and the inclination. Today, I'm really excited to introduce this topic of transition. Having a 21-year-old, we are right in the thick of transition. My daughter just left high school. She's just starting to explore and participate in her activities that will be her adult life, right? And she's not a candidate to be a college student, and so we're looking at all kinds of other things. My job that I get paid for is that I work for the Ohio Family to Family Health Information Center. And one of the things that an F2F does is provide information and training to families. And a lot of the trainings we do at Ohio F2F are on transition topics. Families face this cliff that they feel like they're going to fall off of. And there's all kinds of things that you have to be prepared for and learn about before your child moves into this adult world. The medical transition is a huge, big part of it, and I'm really excited to be here and hear about this from our speakers today. So I am happy to introduce to you today Christina Sarmiento. Dr. Sarmiento is a physiatrist. My note won't come up for me, so I'm just going to do this from my memory. From Colorado, who has started a transition program at a children's hospital in Colorado. And Patty Herbst is from here in Illinois, correct, with the Center for Independence. Thank you for being here.
Awesome. Hi, everyone. Thank you so much for having me. I'm so honored to be invited to speak here. Like Lynn said, I'm Christina Sarmiento. I'm a physiatrist or a rehab physician at the University of Colorado. So just a little bit more about my background so you can understand where I'm coming from. So I trained in both adult and pediatric rehab medicine as well as general pediatrics. And throughout my training, saw this huge gap in care for adults with childhood onset disabilities. And that really became my passion. And so my career goal is to improve healthcare access and outcomes for individuals with CP and other childhood onset disabilities across the lifespan. And I do that in two roles, as a clinician and a researcher. And so I'll talk just a little bit about transition in general and then about some of the specific research that we're doing through our clinics. So as many of you know, there's increasing numbers of children with medical complexity, disabilities, special health care needs, however you define it, that are living and thriving into adulthood. And so right now there's a huge range of estimates, but it's estimated that 50 to 90% of kids with disabilities reach adulthood. So what that translates into is more than 500,000 youth just in the US alone that have complex medical needs entering adulthood every year. And fewer than half are receiving appropriate transition care. And transition is a really vulnerable time. So there's decreased access to services, insurance changes, decreased treatment adherence, and this all leads to poor health outcomes and a reliance on emergency services rather than established routine medical care. And poor transitions lead to poor continuity of care, lack of age and developmentally appropriate care, poor health outcomes, secondary complications, increased risk of psychosocial difficulties, decreased community participation, increased healthcare services usage, and again, that reliance on emergency services. And so just a little bit about cerebral palsy in general. I'm probably preaching to the choir here, but as we all know, it's caused by a non-progressive injury to the developing fetal or infant brain. And the reason I bring this up again is even though because I'm saying it's a non-progressive injury, it does not mean it's unchanging. And so there's this growing emphasis on viewing CP as a lifespan condition, and there's unique risks and considerations that we need to take into consideration of the care of adults with CP. And so right now, about 80% of individuals with CP are adults. And despite this, the majority of services, interventions, funding, research studies are focused on children. So the needs of adults with CP is a research priority, and that's according to both the National Institutes of Health as well as stakeholders that include adults with CP and family members. And kind of just another point to emphasis, so CP in adulthood is the focus of only 4% of CP-related NIH funding, despite being 80% of the population. So what's so special about adults? Like, why do we need to make this distinction? There's a growing body of research showing that adults with CP are at higher risk for many chronic illnesses, premature aging, and at a younger age than the general population. So this is a great systematic review by Smith and her colleagues about the need for ongoing neurologic and rehabilitation care for adults with CP. So adults with CP have a 2 times greater risk of stroke, 8 times greater risk of myelopathy, which is a compression of the spinal cord that can cause weakness, bowel or bladder issues, gait difficulties in people that are ambulatory. As well as loss of mobility in at least a third, chronic fatigue in more than 65%, and chronic pain in more than 60%. And this is all compared to the general population, like adults of the same age. So we really do need specialty care for adults with CP. There are many different medical and healthcare associations that also support the importance of healthcare transition. And so here's a few: the American Academy of Family Physicians, American Academy of Pediatrics, American College of Physicians, that wrote this consensus statement on the need for healthcare transitions for young adults with special healthcare needs. And this includes recommendations that include a written transition policy that's made by 14 years of age, the creation of a portable medical summary, and other kind of milestones during the transition process. And so I'd like to poll the audience here. So how many people, and if you would like to raise your hand, you don't have to, are a person with CP or the parent or family member of a person with CP? Okay. And then keep your hands up if you or that person is over 14 years of age. And now keep your hands up if they have a written transition plan. Okay, I'm seeing some hands, which I like. And now keep it up if that was written by the time they were 14 years of age. All right, okay. So we have some, but I think you could see like hands went down pretty precipitously. And so this tracks. So there's been studies that have surveyed pediatricians and showed that only 10% that thought transition planning in general should start before age 15. And only 25% reported helping adolescents create a portable medical summary. And so this is a great resource. GotTransition.org provides a lot of different transition-related resources, and I'll provide this website again at the end. And so they kind of outline these 6 core elements of transition that all take place from the time you're 14 until you've officially transitioned to adult care. And we're not going to go into details of this, but I show you this to detail and demonstrate all the different steps that are transition. And so I really don't think of transition as a step or a checkbox. It's a season of life and should be treated as such. And so what's the problem? Why, we have these recommendations. Why aren't they being instituted? What's the issue? So you can look at this from a lot of different perspectives. So from the patient or the family perspective, it's really hard to find adult providers with appropriate training. There's practice differences in the adult and pediatric model of care. It's really hard to leave a well-established relationship with someone that's known you for decades. There's decreased resources and support for young adults, and there's often a lack of guidance in the transition process. And so this is a care team map that was drawn by the parent of a child with medical complexity, kind of outlining all the people involved in their family and their child's life. And I'm sure that this resonates with a lot of people here. And I think I really love this map because I think it shows you why transition is so complex. It's because you're not just transitioning your pediatrician or your neurologist, you're transitioning virtually every single aspect of life. From a pediatric provider's perspective, it's really hard. There's not a lot of supported time, resources, personnel that's needed for the care coordination involved in transition. Similarly, it's hard to find adult providers. And similarly, it's really hard to give up a long-term relationship. And from the adult provider's perspective, they may not feel comfortable. They may not feel like they've had the appropriate training to manage congenital or chronic childhood conditions. It's really hard to manage psychosocial needs based on how our healthcare system is set up. Again, lack of support and resources for the care coordination that's necessary. And they may not receive an adequate transfer of information and feel overwhelmed at the prospect of having to assume care of someone that's had, an active medical history for the past 20 years. And so what we did at Colorado, I did my training there and then stayed on, so now I'm faculty there. And so as Lynn mentioned, given my area of interest, developed a transition program within our pediatric hospital, Children's Hospital Colorado, for youth with CP. And because I recognized one of the hugest barriers is finding adult providers that can provide specialty care, and because I did do clinical training in adult rehab medicine as well. I started an adults with CP clinic at our adult-based healthcare system, which is called UC Health. So I recognize I'm in a very nice position where I can transition patients to myself, which circumvents one whole area of the barriers, but you gotta start somewhere. But my long-term goal with this line of research that we're doing based in these clinics is to develop a patient and family-centered transition process from, oh gosh, this is flipped, pediatric to adult rehabilitation care for individuals with CP. And so again, this is kind of what I envision in my head as this spectrum of the season of transition. So there's transition preparation in the pediatric setting, then you're actually transitioning from pediatric to adult rehab medicine, in my case, and then overall, the goal is to improve lifespan care for adults and individuals in general with CP. And so the research we're doing right now is focusing on that actual transition process. So we're working with the young adults with CP in our clinic and their family members to identify, what do they value about their experience in our clinic, what are perceived barriers to the transition, and what might help facilitate or overcome those barriers. So our research objectives to understand the values of young adults with CP and their families, and again, those barriers and potential facilitators, and the goal is again to develop that patient and family-centered transition process. And these are our two pictures, our two hospitals there. So our Children's Hospital Colorado, and then university-affiliated UC Health. So this particular project I'm going to share some information with you about was a qualitative research study. So we did interviews with individuals with CP and or their caregivers. So we offered the option to do either individual interviews or dyadic interviews where it was the adult with CP and their caregiver together. We wanted to focus on adults, so we looked at those who were 18 years and older and who were actively followed in our pediatric rehab clinic and had not yet transitioned to adult care. So we did 20 interviews, 13 with the caregiver on their own, and then 7 dyadic interviews. So we had 27 participants total. No adult with CP chose to interview on their own. And from these interviews, we identified 4 major themes, detailed here or outlined here, but I'm going to go into detail about them on the next slides. So one was really the value and security of long-term relationships. So really, and I don't think this is surprising to anybody here, these relationships are critical to not only the patient, but the family's comfort and engagement in their care. And they're really strengthened by continuity. And so the longer these patients and their families were connected with this pediatric rehab provider, the more connected they felt, the more trust they felt in the clinic team in general. And honestly, the more anxiety-provoking the transition prospect felt. And a lot of participants described their pediatric providers as family or friends and had these personal points of connection that really strengthened the relationship. And it really seemed scary to start over with new providers who might not get it. And so these slides are gonna have some quotes from the interviews from the different participants. So related to this theme, one participant said, it's like coming to see old friends or even family when they came to their clinic visits at the Children's Hospital. And another participant talked about that fear, that anxiety-provoking aspect of transition. The uncertainty makes a whole other layer of stress. There's the stress about the fact of something, and then there's the stress about not knowing how it's going to work out, right? There's this whole extra layer of fear. It's just fear. Another theme that that came out of this data was that participants really felt rudderless, and that was a participant quote, navigating the logistics of transition. So they felt like they lacked the needed information to successfully transition, and they were overwhelmed by the number of changes that occur during that time period. And that makes me think of that care map I showed where, it's not just the medical that's transitioning, it's everything. And there were a lot of logistical challenges, from identifying appropriate providers, just the geography of it. In Colorado, we have patients and families that drive from the mountains and from other states, so the geography of it. Long wait times to get into new adult clinics, communication challenges, clinics that have caps on Medicaid patients, And so here are a couple more quotes. So I think that the transition, the year of 17, is truly awful. There's so many things that you have to go through as a parent that you, in some cases, are no longer considered a parent. You're considered a legal guardian. There's just so many hoops. And then another participant, where we got the quote for this theme title, said, not only do we feel rudderless, we don't have any information. I don't know. We feel we're sort of like shooting in the dark. A third theme was, again, those differences in the pediatric and adult models of care. So it's just not the same model. So a lot of our participants expressed feeling that adult systems were unable to meet the needs of complex patients like their children compared to pediatric healthcare systems. A lot of these participants had crafted over years and decades these really great and supportive pediatric healthcare teams that they just felt really met their needs. And so the prospect of starting that process over and having to recreate the dream team was really overwhelming. And a lot of participants just didn't know where they fit best. Some felt like everything is totally fine. We would love to be seen in the Children's Hospital forever. Others felt, we don't really feel like we fit here anymore. You know, I feel like adult issues are coming up and this just doesn't feel like the right place anymore. And some people just felt like they didn't fit in either place. And so this quote, I think, kind of gets at that. So I think that there are some adults that their bodies and stuff aren't quite the typical adult bodies. And that's so what, it's like, where do we fit? Because adult doctors also didn't train to be treating somebody whose body is like the patient or their child. And so that's what's really scary to me. And our fourth theme was this perceived lack of provider expertise and comfort in adult care. So some participants had tried to transition to adult care or maybe transitioned some specialties or not others, and recalled challenging encounters in the adult system. So some described the deer in the headlights look, or one participant recalled an anecdote where an adult care provider told them, I don't know what you want me to do, right? Other providers, or not other providers, other participants, you know, with the prospect of seeing maybe an adult provider who had some specialty or expertise knowledge in CP and aging or adults with CP, some were excited about that potential prospect, kind of like a fresh set of eyes with someone with a different lens of expertise. And some participants identified medical training as a means to improve this. And so one of these quotes is going to speak to that. So this top quote, she, the adult provider, knew less than we did. I'll be honest, it was concerning, right? And then this other participant said, you know, as people like my child are living longer, and as you all are going through your med school training and learning more about people like my child with multidisciplined areas of medical need, you'll be able to more help people like her and not have the deer in the headlights look when we walk through the door. We'll see less and less of that. And that's my big hope, is that this becomes a routine part of our medical training so that every provider feels really comfortable and capable and excited about treating patients with disabilities overall, particularly childhood onset disabilities or medical complexity. And so from these themes, we identified these facilitators or ways to help support the transition, and we divided them into 3 phases of transition that have been described previously. So transition preparation, the actual transfer of care, and then integrating into adult care. And so what came out of these interviews to prepare for transition, things that would be helpful: advanced planning and formal yet flexible transition policies, resources to assist with navigating the logistics, and information about adult providers ahead of the transition. And I think the possibility of joint visits between a pediatric and adult provider is a really great opportunity area. I recognize there are logistical and billing and time challenges to that, but I think, you know, if they're possible, they're awesome. The transfer of care, so improved connection and communication between the healthcare systems, a pediatric provider facilitated transition, including specific recommendations for providers, and transferring during a period of medical stability. To integrate into adult care, things that came out of these interviews were the importance of the family unit, so acknowledging the expertise of parents while still acknowledging the autonomy and adultness of the patient as age and developmentally appropriate. providers with expertise and comfort in treating adults with childhood onset disabilities, and interdisciplinary coordinated care. And so what do we need? We need a transition that's long-term, a developmental process, inclusive of all parties, flexible, supportive of emerging autonomy and adulthood, because it's a scary time, but it's an exciting time, and that's supportive of communication and education between pediatric and adult providers. And so what can you do now, right? Because we had a lot of teens and young adults represented in this room. So my challenge to you is, if your provider has not discussed transition, and this applies to not only your primary care provider, but all of your specialists, I encourage you to ask them if their clinic has a transition policy or plan. Just asking. They might not have one, but it starts the discussion, and I think acknowledging that elephant in the room is a huge first step and can honestly help alleviate a lot of the anxiety to just be talking about it and having a plan for it. Ask them if they have recommended clinics or providers in the adult system that they either know or that other patients they've transitioned have seen and recommended. And ask them about their anticipated or what their goal time frame is. A lot of this is really like clinic and specialty dependent. And if you're starting to plan the transition, I recommend involving your primary care provider. Consider staggering the transitions of different specialties. It might seem more confusing or more complicated to be transitioning different specialties at different times, but I think it can be less overwhelming to transition one thing at a time rather than having to transition everything all at once. You kind of spread out that period of, having providers that don't know you as well versus providers that do know you really well. And I think it can also help identify periods that are medically stable to transition the appropriate specialty. So let's say like seizures are super under control, haven't had a seizure in years, feel really good about that, but GI stuff is all over the place, having lots of issues. Well, maybe now's the time to transition neurology, but we wait for GI to be in a little bit better of a place. So I like the flexibility that that approach provides. Contact adult clinics well ahead of time. So don't be transitioned from the pediatric system without that appointment booked in the adult system, or at least having a near-term time frame for that. And then discuss creating a medical summary and emergency plan with your provider. So this is an example of a medical summary or an emergency care plan. I realized last night that these QR codes no longer work. I'm sorry, I think I signed up for like a free trial that expired unbeknownst to me. But I've also put the URL here. And so this includes information that you take with you to mostly emergency department visits, but really you can bring to any visit or just keep on your person. It includes information, details about like your baseline level of function, so that if you go into an emergency department and your right arm is really weak, you have this documentation that, oh no, your right arm's supposed to be strong, this is concerning, we need to work this up. It includes things like medications, school and clinic information, things that like common presenting reasons to the ED for the particular person, and oftentimes what might be going on. So maybe urinary tract infections are a big risk and they don't present in the typical way, but having this documentation of, oh, that's a red flag, and maybe that will help prompt the ED to do that workup, or the emergency department. And really, I think it's never too early to start the discussion. I think knowing what's coming, having a plan, or at least having a plan to make the plan, is a large part of the battle. And partnering with your pediatric providers is really, I think, the best way to go about it. These are a couple of those resources I mentioned. These QR codes no longer work as well, but it's Got Transition is just gottransition.org, and Family Voices, if you just Google Family Voices Transition, both of these sites have a lot of great resources about transition. We got some references there, and thank you. Thanks so much.
Did you see the video too? This is the video. Oh, that's great. So they're both there. Oh, right here. This is the video. Okay. And then so I have to come out of that and then just click on the video. Oh, definitely the slides.
Go to the parent engagement, 1 o'clock, I'll be back to her adaptive reading.
Oh, we have it on tab. Thank you. Well, hi, I'm short, so I'm going to pull it down. My name is Patty Herbst, and I'm the Executive Director of the Center for Independence Through Conductive Education, and we're located here in Chicago, in the Chicagoland area. Okay, now why isn't it doing this? Why? Sorry. Oh, thank you. Okay. So the center's mission is to help children with cerebral palsy achieve their highest level of independence. We provide intensive motor training programs based on conductive education, but we have PTs, OTs, and conductors delivering an intensive motor training program. And then we also offer job placement programs for young adults with varying disabilities throughout the Chicagoland area. We started in 1998 serving 6 children with cerebral palsy, and today we serve over 350 children and young adults with disabilities at 3 different sites in Countryside, which is about 12 miles west of here, in Brighton Park, which is the west side of Chicago, on 37th in California, and then also in Lake Zurich. And we're really proud that this year we'll be celebrating our 25th anniversary. Our transdisciplinary team includes PTs, OTs, conductive education teachers. On our job placement program, we also have employment specialists, job coaches, and we have a social worker on staff. Our programs, we provide, again, intensive therapy. We also do wheelchair orthotic, adaptive equipment evaluations. The Center for Independence is a huge proponent in inclusion in regular education classroom. We are a huge proponent that you have to prove to us that it doesn't work over and over again before we'll approve a self-contained classroom. And especially when we see school districts that are attempting to put a kindergartner or transitioning from kindergarten into first grade into a self-contained first grade classroom. So we do a lot of advocacy on that end as well. We provide free social work services, and then again, job placement. So today I'm here to talk to you about our job placement program primarily. Working Together Chicago provides job development, short-term job coaching, volunteer mentoring. We create paid employment throughout the Chicagoland area. All of our participants are paid at least minimum wage. Most of them are paid more than minimum wage. And the numbers of hours that they work can vary significantly. We have some folks that are working 8 hours a week, up to probably 30. But probably 20 is our average, but can go down to 8. It really depends on the nature of the disability and their health care too, their health. So obviously our goal is to promote a diverse, and equitable, and inclusive work environment by increasing numbers of people. Our program started because of a gap, and just like the vast majority of new programs, right, we saw a gap. And it was really motivated because of these 2 people. This is Annie Hunt, that's on the left. Both of these are graduates of our intensive motor training program as well. Annie's on the left. She is a GMFCS level 4, spastic quadriplegic. And my son, who's on the right, Justin, is also a level 4 spastic quad. He has really good use of his left hand. So Both Annie and Justin are children of the ADA. They are two of the first students that were fully included in a regular education classroom from kindergarten all the way through high school. They worked incredibly hard, hours and hours and hours and hours of homework at the dining room table, right? Anybody that's raising a child with a disability knows that you will go to school and then you come home and you do hours and hours and hours of homework and just relearning. Both Justin and Annie went to college. Annie went to U of I, got her master's degree in social work, and Justin went to Southern Illinois University and got a degree in history. Our entire staff was just so thrilled. That's our objective, is to get them out into the community and get them to college. They came home, could not find a job. Couldn't find a job. Annie's story is really sensitive. Annie could not get a clinical rotation to finish up her social work degree. She couldn't find a clinic. We live in Chicago. She couldn't find a clinic that was willing to take Annie because of her disability to complete her rotation. I can't even bear talking about that. So we fortunately were able to create a social work position for Annie at the center. I'm going to talk about that later. But we know that people with disabilities bring great value to the workforce. And there's lots and lots of research that supports the fact that people with disability bring value to the workforce. One, people with disabilities are highly motivated to work. Top recruits want to work for inclusive employers. Young people want to work with people with disabilities, and I think that that also is a reflection of the Americans with Disabilities Act. Able-bodied, typically developing children grew up alongside children with disabilities. They enter the workforce and they go, well, where's my friends with the disabilities? Why aren't they here too? We find that they are the biggest promoters of encouraging employment in the workforce. Customers want to see people with disabilities as well. Families have people with disabilities in their families, right? We want to go to the stores, we want to see them. We want to buy merchandise, buy services from employers that hire people with disabilities. There's lots and lots of research on work culture and job morale. The job morale and work culture improves when you have a person with a disability on staff. A couple things too, that the safety records of people with disabilities is identical of a typically developing person. That your workman's comp does not go up just because you hired a person with cerebral palsy. Something else that I failed to include on this also is that the vast majority of accommodations, workforce accommodations, are less than $500. Accommodations are not expensive. And there's lots of research to show that too. We just need to get the word out to employers. And then of course, people with disabilities remain on the job longer, and they're more punctual, and they don't call in sick as much as typically developing people. So all those great benefits, why aren't the doors just thrown open and people hiring people with disabilities? The Americans with Disabilities Act passed, I think, 27 years now, right? But yet, 70% of people with disabilities are still unemployed. That percentage has not changed at all in 25 years. And actually, the percentage of people with disabilities employed has actually gone down. So we're doing something wrong. And because of that, 35% of people with disabilities live in poverty. So I'm just going to talk about some of the barriers that we've identified to employment. Attitudes, both conscious and unconscious. Fear of hiring a person with a disability. How do we do that? There's not a lot of, that we don't have a lot of examples of it. Transportation, we all know that, especially if you have a child with a disability. Transportation is really difficult. Here in the Chicago area and within the city, the ability to be able to get accessible transportation goes way up. You go out into the suburbs, goes way down. You go out into the country, forget it. If you're in a rural area, transportation's horrible. So how do we get over that? There's also fear and confusion on behalf of the individual with a disability about working. Their own fear, and then also fear on behalf of the family. Like, what's going to happen if my loved one works? Are we going to lose our benefits? So there's so much fear about that too, that maybe they don't enter the workforce because of that. There's lack of experience. And what I'm going to be talking about today is also the job description. So when you're applying for a job and you have that job description, very rarely do people with disabilities meet each one of those job description tasks. And a lot of job descriptions must be able to pick up 50 pounds. Okay, John. Or must be able to drive a car. So a lot of job descriptions are a barrier to employment. And then we're finding most recently that artificial intelligence being used on job interviews is becoming a huge barrier. Because firstly, the computer is rating you based on typically developing a person. So if you can't maintain eye contact, you fail. We're not going to move forward. If your output is not as quick or your response isn't as quick, you failed. We're not going to move forward. Or if maybe you're using assistive technology to communicate. So sometimes we're even finding that we're attempting to set up an interview, and we can't even get to the HR department anymore. They're going to force you to go through an AI interview to do that. So, so those are some of the some serious problems. Today, I'm just going to focus on some of the strategies for improving employment outcome. One of them is networking. I don't think that, I hope that you all go home and you think about networking again. Connection with the Department of Rehab Services. Prior to graduation, you shouldn't be going to the Department of Rehab Services after you graduate. You need to meet them beforehand. And that seems simple, but it happens all the time. And then specifically, I'm going to talk about the center's job carving tool that we created. So again, strategies for improving it. Networking. Networking, I believe, is a person's most powerful tool in getting a job. And that's not just for people with disabilities. That's for typically developing people, right? If you think about your job and how you got your first job, you talk to your network. So it's absolutely crucial for a person with a disability to think about who's their network, where's my support system, and where would I be able to find that job. I personally think that small businesses are a really great resource. We have such a hard time getting into some of these big businesses. Big businesses say they want to be inclusive, that they want to hire. We have much more success finding a job at the little mom and pops that have made a commitment to hiring a person with a disability. So one of the things that we remind our adults with disabilities is to be flexible. And sometimes it's as simple as going onto Google Maps. Go to your home, find the map, open the map at your home, and then draw a circle, a visual circle, 5 miles from that radius, right? And then look at all of the employers within that area. There's lots of them. And then think about, who do I know? Who do we know? Who does my neighbor know, so that I could get our foot in the door? And then to volunteer and start early in high school by volunteering. So the Illinois Department of Rehab Services, and I'm from Illinois, so I'm going to talk about Illinois, but it's a federal program. And the Department of Rehab Services is throughout the United States. So it'd be called the Michigan Department of Rehab Services. All of us need to know how they work. And unfortunately, transition, Christine said medical transition, and I feel like my whole nervous system just blew up. And then I'm thinking, oh my gosh, medical transition, high school transition, employment transition, it's enough to give you a really bad stomach ache. It's terrible. So when a child, 3 through 18, 3 through 22, you have an individualized education plan through the public schools, right? When you graduate from high school, either at 18 or if you go through transition, you move to the Illinois Department of Rehab Services, and then you have an individualized employment program. You have another IEP. A lot of people don't know that the Department of Rehab Services, their objective is to get the person with a disability employed. Transitioning is incredibly confusing. There are so many different silos with respect to moving from childhood to adulthood. There's Medicaid, There's SSI, there's the Department of Rehab for employment, then there's Department of Rehab for any of the home-based waiver programs. And one of the biggest issues that we face is that they all work in silos. They all are a separate silo, and nobody talks to each other. Nobody talks to each other, and nobody has the roadmap for the person with a disability. And what's really unfortunate is that the high schools and the high school social workers and the high school special ed department don't know it either. And you would think that the people that would know the most would be our high schools, because they're responsible for starting that transition phase at 14. Half the time I felt like I was educating them. So it's really up to the parent to learn as much as possible, starting as soon as possible, about transition. So again, the Illinois Department of Rehab Services, their objective is to be able to help high school students plan for employment after transition. There's work incentive planning, so that if you do get a job, they're there to help you determine what's going to happen with your benefits, what benefits are at risk. And oftentimes we'll tell our participants, it's always better to lose SSI and to work and to gain 10 quarters of employment, because you will move into Social Security and you'll move out of Medicaid into Medicare. Sometimes just saying that's super confusing, but that is the reality. It's always better to work, even part-time. There are two different types of employment programs offered through the Department of Rehab Services. The first is supportive employment, a supportive employment program, and that serves people with significant disabilities that want to work, but they need ongoing support services to succeed on the job. That could be an on-site job coach that could go on for a year or more. And then there's also milestone contracts, and that means that the individual with a disability is quote-unquote job ready, that they'll receive 90 days of job coaching. They'll also receive job placement services, job exploration, and the Center for Independence has a milestone contract. That means that any of the candidates that we place in employment are quote-unquote job ready, that the center will provide 90 days of job coaching. We do a lot of job development and job exploration. And then we have free volunteer-led mentorship and job support after that 90 days is over, because we know that that ongoing mentorship and job coaching is still really important, even for people with disabilities who are considered job ready. So again, transitions start early, start really early. I've given you a couple resources that were really helpful to me. I know that Lynn said that in Ohio they have Family Voices. We have something similar. The ARC is a national organization. I know from experience that when my son was transitioning at 18, and I'm a CPA, trying to understand Social Security, Medicaid, SSI, the waivers, Pell Grants through DOORS, the work program, I was completely overwhelmed and absolutely confused. I took classes, free classes, online classes through the ARC, and I also went to some of their family workshops. They're fantastic. I probably had to take 3 before I even figured out that I was finally getting it. That's how complex it is. So they do have they have all of their workshops, their parent workshops online, so you can go and just take them at your leisure as well. They're about an hour and a half, 2 hours long. And then, of course, in Chicago, we have Access Living. They have ongoing workshops for transition and understanding government benefits. The Center for Independence offers ongoing workshops, too, semi-annually. You can see them on our Facebook. But I just highly recommend that you go through and you do that. They're really helpful. So today, though, I was invited to talk about our job carving tool. And the tool that we developed is an online survey. And when folks come in, when community-based providers come in and do some job carving, they typically will go in and they'll interview the employer to try to carve out a job from the employer. We spun it and we tipped it completely upside down, and we put that responsibility back on the employer. And that's because they know their business best. They know, and they also have, so this online tool is the survey is shifted out by the employer to their employees. The employee takes it and identifies tasks that can come off of their workload and shift it over to a person with a disability so that they're making their day more efficient, but they're carving out a job for the person with a disability. One of the other, I think one of the best parts of the online tool is it also identifies the internal champion of the employer. And that's been really important for us. So for example, the tool will identify, and I'm going to go to the next one. It's going to benchmark their disability decision-making where they are. The vast majority of employers, when they take this survey, their staff says, yeah, we want to be inclusive. We want to hire a person with a disability. They just don't know how and what the next steps are. But one of the other great things is that it also identifies those champions within, the people that want to be able to supervise a person with a disability, the person that wants to be able to go on and give ongoing career development opportunities. Because we know that if we place a person with a disability in a job and their supervisor didn't want it to happen, wasn't invested in it, it's going to fail. So identifying those champions from within is really important. So now I'm going to try to turn on the job carving tool, but I don't know how. So I was like, yeah, sorry. Yeah, to get it out of this. There. Oh, sorry.
Is that, where is it? Where did it go? No?
Oh, it's right there, I think.
There you go. Is it full screen?
Working Together Chicago approaches employment from the demand side. Our focus is on the employer and the benefits people with disabilities bring to the workplace. We support employers through the entire process, from hiring the right candidate to ensuring the employee thrives on the job. Working Together Chicago has created a state-of-the-art job carving tool that is led by the employer. The job carving survey challenges employers and their staff to examine their daily tasks and identify those that can be assigned to a person with a disability. The data from the survey helps improve overall workplace productivity and efficiency. The Working Together Chicago Job Carving Survey fills the needs of the employer while capitalizing on the skills and strengths of workers with disabilities.
When I took the survey, I want to say it took about 10 to 15 minutes.
So when I did the survey, it took me probably about 5 to 6 minutes to complete. The job carving report gave us specific information about what our staff felt the needs were in areas for someone to come and help them in terms of little tasks in the classroom or in the building. So I learned that there are duties that I have that I sometimes will give to my administrative assistant, or that I might even do myself, that I think probably someone with a disability could quite easily do. And having someone here and knowing that that person is here, it made me think a little bit more about the duties that I have and the jobs that I sort of parcel out to people that a person with a disability could really do very successfully.
When I took the survey, I definitely saw some opportunities that I could share with other people. I saw some ways, some tasks that I could give up that would increase my productivity throughout the day, would allow me to focus on larger goals while allowing someone else to help me with the small tasks that help me to reach those larger goals.
The job carving report starts broad, and it was able to narrow kind of the responses for us based on the needs of my staff here, either teachers or staff members.
The survey definitely challenged me because I wanted to make sure that I was given the most accurate answer for each question. As I mentioned before, it also encouraged me to reevaluate how I am spending my time each day.
So I think the survey did allow me to figure out how to create opportunities for others. You know, I'm kind of a type A person, so I like to do things myself. But I think it made me a little more introspective about, okay, I'm thinking about all these different things that she could do, or he could do, someone with a disability. And so it made me think more about that because of some of the things that were in the survey that I noticed. I was like, oh, kind of like a few aha moments about things that duties we could give to someone with a disability to do successfully.
I definitely found myself evaluating my daily tasks while taking the survey. I actually created a schedule after I took the survey just to see how often I completed certain tasks and how much time each task required of me.
Yeah, based on the results of our job carving tool, we were just given some specific things that we know that the person coming in to help us will be able to do every day, and we're going to be able to create a schedule based on those responses. Should be great.
So the feedback I got from my colleagues in regards to the survey was really positive. In the beginning, when you first arrived, I just noticed so many of them coming into the conference room because they wanted to complete the survey because they were really interested in having someone with a disability come and work here. I do think oftentimes when we send things out to our faculty, it's met with apathy, it's met with maybe a level of disinterest, but I really didn't see that here. I saw a lot of interest, a lot of people who were interested in just having this person be part of our school and part of our lives, and I think that's a really good thing for Marist High School because we really don't serve a lot of students with disabilities.
Inclusivity is a big word. It's for some people maybe a buzzword right now. But I think I've learned in my career as an educator that inclusion and diversity is everywhere. It's not necessarily something that you're born with. I think it's just how you treat one another, no matter who you are. So we're excited to just have another employee come in based on the needs of that person and to have them be a part of our school community here. So it should be really good.
Okay, so that's also where you can see the job carving tool video if you're interested in it. The Center for Independence, we're pretty small. We only have a staff of 34, but we like to say that, you know, we're not just going to talk the talk, we got to walk the walk. 8 of our staff are people with disabilities. Our entire front desk is made up of young adults with cerebral palsy. And we also, 2 of our classroom assistants have a physical disability, which is pretty amazing. And then also our social worker, Ani, has very profound CP. So we actually benefited from being able to hire Ani. And I can't tell you, you know, as a parent of a child with a really profound physical disability, 25 years ago, my son Justin didn't have many role models. He didn't have any role models, and certainly me, as a young mother, I had no role models either. And I think that that's the beauty of becoming a more inclusive environment, right, and the ADA, is that now when young families come in with their newly diagnosed baby, they're greeted at the front door by a person with a disability. They're introduced to our social worker who has cerebral palsy. And some of the folks that are in the classroom during our intensive motor training programs, cleaning up and getting it ready for the next, is a person with a disability. So you can see the future, and that there are options, that you might have been born with cerebral palsy, but you should have really great high expectations and expect to have a full, meaningful life that possibly includes employment, if that's what you want. I did a couple of other resources too. A lot of folks with cerebral palsy also need assistive technology. We're fortunate in Chicago that the University of Illinois Chicago has a really great AT program. So if you have gotten a job and you need more assistive technology at the workplace, the University of Chicago will come in and do an assessment for you and work with the employer. And then, of course, we're here at Shirley Ryan Ability Lab, and they also have a fantastic AT department, and we'll help you do that too. So thank you again for inviting me and for learning about our job training tool. All right.
All right, are there any questions?
Well, my first one, Patty, the job training tool was really cool. What struck me in the video was that it was a school, and that this was a school looking at hiring people with disabilities. And I was like, oh my gosh, you know, had they not thought of this before? But you're absolutely right. You know, my son hasn't had role models necessarily. Where are the teachers with disabilities? You know, where are the other people in the school that are employed with disabilities? So I think it's wonderful that the school had that open-minded and did this, and that, you know, they're actually employing people with disabilities. So that was really cool, and it was really cool that was the example. So thank you, and thank you for this product, because I think it's really awesome. And then I had a question for you. What type of physician, I know you're a physiatrist, and you're trained both, you know, as peds and adults, but from a primary care perspective, who are you referring to? Family physicians? Are you referring to internal medicine? Are you referring to geriatrics? Who are your go-tos?
Great question. I have found that my kind of list of primary care providers that I tend to refer to are either family medicine, who are also trained to care for people across the lifespan. Transition, you know, there's a buzz about it now, which I think is good because it's getting more attention and resources and energy. One of the medical specialties that's, I think, best poised is, some people call it like med peds. So you do your training in internal medicine as well as general pediatrics. And I think more and more medical students are choosing that field because they have an interest in caring for adults with childhood onset chronic diseases or disability or medical complexity. So I think those are the two that most of the people I tend to refer to are. But really, I think if you find a great internist who's passionate and able to go that extra mile, I think that's also awesome.
Any other questions?
Okay, my question is really not getting a job, but what happens, like my son has been a model and for disabilities he would wear the AFOs, he's in all kinds of magazines. He's also done a lot of background on films, but the problem we've had is he has been hired for jobs and we've gotten there and they said, you have to leave, you're a liability, you can't be here. I mean, what do you do for cases like that? Or when you go on a job, like he went on a job for Chicago Med and being there for about 8 hours and they were picking everybody over him to be a person in a wheelchair. He was the only one there with a disability. And I had actually had people coming up to me and saying, do you see what they're doing to your son? How do you go, I mean, what do you do for things like that?
Well, it's blatant discrimination, number one, and I would remind them of that when you're there. And there's so much research with respect to liability that people with disabilities at the workplace do not have more accidents or cause liability insurance to go up. But for any employer to come in and suggest that, that's just outright blatant discrimination. So if somebody said that to me, I'd say, well, I think you might back that up, you know, I would walk that back right away. It's unfortunate.
Yeah, he was hired for like a 7-day job.
Yeah.
When we got there, they made us stay. It was for a movie.
Yeah.
It was the Chicago Sun. And we sat there for about 3-4 hours and they said, no, we really can't use you. You have to go home. We don't really have a part for you.
Yeah.
And I said, you mean to tell me in the 1960s, people that went to, it was like a riot scene or who were they protesting, people that have disabilities don't protest.
Yeah.
I said, what are you trying to say? You don't have a wheelchair for someone to push you to this protest? They said, well, let us think about it. Maybe we could get a wheelchair. We need one from the 1960s. I said, no problem. I'll have a wheelchair by the next day from the 1960s. They never called.
Yeah.
And then they hired him again about a year ago. And they said, really, do you think we're really going to drive down there? And what did they say? You didn't have a disability. You were sick. You didn't tell us you were sick. He says, well, I'm not sick.
Yeah, that's unfortunate. That's discrimination. That's terrible.
And you're saying people like want to work with you.
Yeah.
We get a lot of people working with us.
Yeah, I think it's, again, that you're breaking barriers, you're the leader, and that I think is often the most difficult position to be in, right? When we're breaking those glass barriers. So, and it's fear on the behalf of the employer. What's going to happen? Right. Yeah. And people with disabilities have to be able to speak up about that more as well, that we should, right? That does that person have a disability? Right.
I'm going to also put my family support hat on for 1 second and say every state in the country has a disability rights organization, and it's a requirement that every state has it. And so I would reach out to your disability rights organization for Illinois, because I know Disability Rights Ohio would absolutely take on a case like that and argue it for you. So.
And I think Equip for Equality, right, in Chicago, would Equip for Equality is a pro bono law firm in Chicago. They would love to hear that.
Okay. I want to thank these two again for our transition program today. And thank everyone for being here so far. I hope you've had a good morning. We're going to take a break for lunch. We're going to come back at 1 o'clock, and we have a great program on mental health coming up.
All right. Okay, y'all, welcome back. I think people are trickling in, but I'm going to try to keep us on our time frame. And I'm Jen Lyman. I'm also, I guess, a past chair of this council, and this is a topic that is near and dear to my heart. Mental health, mood, movement disorders, and medications. And these two are phenomenal experts in this. They came a long way to talk about it. Heather Reardon is the director of the Phelps Center for Cerebral Palsy. She is a neurologist. I'm going to read the rest. There's a lot going on here. And she's at the Kennedy Krieger Institute. She's also an assistant professor of pediatric neurology at Johns Hopkins Hospital. Heather's clinical interests include the diagnosis of neurogenetic disorders, treatment of spasticity, and complex movement disorders, including dystonia and chorea. And then we have Dr. Aaron Halpton. He is a psychiatrist, and he, for both pediatrics and adults, is the Associate Director of Neuropsychology at Kennedy Krieger in the Department of Psychiatry. He's also a professor at Johns Hopkins University School of Medicine, and he specializes in working with individuals and their families struggling with the emotional, behavioral, and cognitive impact of neurodevelopmental disabilities and acquired brain injuries. So welcome, both of you. We are really looking forward to your talk. Thank you.
Thank you so much, Jen. It is an absolute pleasure to be with you guys today. Our goal is for this to be conversational, so please, if you guys have questions, don't hesitate to ask. We're going to have quite a bit of time at the end of our talk to make time for discussion and questions, but please, we want this to be about what you guys need to get out of it, not necessarily what we want to put on our slides, okay? Before we get started, just a few disclosures. Both Dr. Hopman and I have a few conflicts of interest, nothing that pertains to this talk. I think the other really important piece for us to discuss is that most of the treatments we'll be talking about when we do get to the part about medications are considered off-label. What that means is that the medications are not always FDA approved for the indications that we're discussing, and that's true of most things that we use for cerebral palsy and many things that we use in the world of mental health as well. So we just want to make sure that disclaimer is clear. So we're going to start out with an introduction to kind of the concepts of the intersection between psychiatry and neurology. I think very often, both in the way that it's treated and the way that we talk about, we think about them in very different disciplines, but they intersect a lot, as we're going to talk about. And I think that's important when we're talking about psychiatric symptoms in cerebral palsy, because we can't take it for granted that it's the same, or that we can approach it quite the same way or think about it the same way as we do in a neurotypical population. We're going to then segue into talking about different things that we can do to treat behavioral health symptoms and how to address that. We're going to go through a case example. Then, as I mentioned earlier, we're going to open it up to questions, conversation, discussion. I'm really hoping that we'll be able to have some good thought generation there, not just from us, answering questions, but also learning from each other as a group.
So again, thanks so much for having us and for inviting us to speak on this subject. So we wanted to just start off with talking about what neuropsychiatry is, because it is a medical subspecialty that people may not even have heard of, and it exists in some places but less so in others. So I'm a neuropsychiatrist. This means that so neuropsychiatrists are clinicians who work with individuals and their families who have really a broad range of conditions that affect the central nervous system that also impact cognition, emotion, behavior, and consciousness. So these are things that a lot of times psychiatrists may not be as, like people who are purely trained in psychiatry. Once you have potentially a physical cause or overlapping with neurological symptoms, they may be less comfortable with, and a lot of neurologists may not be trained or as experienced in working with like the behavioral or emotional manifestations of the conditions that they're otherwise working in. So we try to integrate these things. And this diagram here to the right is just giving a few examples. It's a little bit hard to read, I apologize for that. But in what these interrelationships are between underlying causes, especially for individuals with cerebral palsy, things like genetic predisposing factors, perinatal factors that can be impacted by genetics, then the subsequent fallout of what can happen to one's brain with epilepsy, pain, spasticity, all of these other things, how that then interacts with psychosocial factors, things like sleep, all of those experiences, and then the superimposed added on thing of the medications we use to treat any combination of those, and both the positive benefits they can have, but also the detrimental effects. So this is the intersection that we're talking about.
So no talk of in a cerebral palsy conference would be complete without actually defining cerebral palsy. But I do bring this up not because you guys don't already know this, but because I think it's important to segue in terms of how we're thinking about cerebral palsy in the context of mental health. So as you know, cerebral palsy is a group of permanent disorders that affect the development of movement and posture. And they're non-progressive, meaning that we don't expect to have changes in, the actual brain architecture or more brain injury over time. But as you all know, the symptoms may not be perfectly static over time. And sometimes as people get older, those symptoms can kind of flux or change. And we'll talk about that a little bit more today. Cerebral palsy is not uncommon. It occurs in 1 in 4 out of every 1,000 children in the U.S., and those children grow up and, as you heard about earlier, become adults. So a lot of people with both children and adults in the U.S. with cerebral palsy. We do know that black children are affected more than white children. That has to do with some very complex factors. But it's also important when we're thinking about access to things like mental health services, things where there is a lot of disparity there. We also know there are significant impacts on the physical, social, mental, and economic health, both of the individual and of the family unit. Now, I just want to pause here and say, today we are focusing on the individual with cerebral palsy. Families, we see you. We know this is hard. And we know that your mental health is important too. So while we're not going to focus on that today, I just want to take that moment to let you know that we recognize that, okay? Cerebral palsy comes in different flavors. So the most common one is spasticity, which is that velocity-dependent catch. We have dyskinetic, which can either be dystonia, where you get these fluctuating movements going from one posture to another. Chorea, which are more of these twishy or flowy movements that go from one joint to another. And then ataxia, which is difficulty with coordination. And as you all know, many people have a combination of both just to make things trickier when we're thinking about things. The reason that this is important when we think about mental health symptoms is depending on where the dysfunction or injury in the brain is, that then relates to certain types of motor symptoms. So if you have, for example, an injury deep in the gray matter of your brain, you're more likely to have those disconnected symptoms, where if you have an injury in the cerebellum, you're more likely to have ataxia. Similarly, these parts of the brain are very important in our behavioral and mental health. So for example, if you have a lot of injury to the frontal lobe, you may have more problems with executive function, ADHD, attention. There's, a lot of our conditions that affect the basal ganglia oftentimes are associated with OCD, anxiety, mood disorders. So we can't just think about mental health from a behavioral standpoint or environmental standpoint. They're actually important biological factors that are going into that relationship between cerebral palsy and mental health. Similarly, this is a topic that you guys may be hearing more about. It's a really big buzz in the neurological world. We're finding that a lot of people with cerebral palsy have either a genetic cause of their cerebral palsy or genetic factors that contributed to the cause of their cerebral palsy. So up to 23% are going to have an etiology found when they get whole exome sequencing, which is kind of a big, broad look at genes. When you look at something to look if there are big chunks that are duplicated or deleted or something called a microarray, 5 to 9% there. So that's not trivial. And the reason is, Dr. Hopman is about to discuss, many genetic conditions with CP also have neuropsychiatric conditions. So we can't just look at brain architecture. These genetic predisposing factors may also be a risk factor for mental health conditions.
So dovetailing on what Dr. Reardon is saying, you'll hear us talking repeatedly about this layering of different factors that can contribute to issues with surrounding mental health for individuals with cerebral palsy. So while there's a lot of buzz in the last couple years about certain potential genetic predisposing or contributory factors for developing cerebral palsy, there's a whole separate literature, often involving some very similar or identical genes within the mental health and neurodevelopmental literature. So this is just a few. We could have pulled from like 20 or 30 different genes for this slide, but we picked a few that we both have some more experience with and felt like they kind of exemplified this point. So on the left, you'll see a few specific genes. In the middle column, you'll see the associated motor manifestations that tend to be more commonly described for individuals with those mutations who develop cerebral palsy. But then on the right, we see from, again, this kind of separate literature that there are psychiatric and behavioral phenotypes, like a lot of neurodevelopmental, neuropsychiatric, and other associated mental health and behavioral symptoms associated with some of those genetic causes. So the most common and sort of the easiest for us to talk about is at the bottom. There's a condition called 22q11 deletion syndrome, which has fairly recently been associated in some individuals, a small percentage of individuals, but certainly with some individuals who have cerebral palsy. There's an entire literature on that population and their high risk of psychosis and schizophrenia, autism, anxiety, ADHD, and other neuropsychiatric symptoms. So when we then combine these, we're sort of trying to add to this layering of potential factors that could be contributing to somebody's mental health beyond, the things that we commonly think of, the psychosocial effects, pain, sleep, all the things that we might more commonly associate. This really fleshes out how many different pieces are part of this puzzle. Oh, this one's yours.
Yeah. So again, adding to those layers, in addition to the genetic, the areas of brain injury, people with cerebral palsy oftentimes have other co-occurring neurological conditions which in and of themselves are highly associated with neuropsychiatric disorders. And this is important because a lot of times these other disorders have more research, so it helps us as a team or as a community lean into those to justify why we need to talk about this important topic. So we know that stroke, even 15 years out, has a very high rate of anxiety disorders and depression. Epilepsy, similarly, almost 40% of people have co-occurring psychiatric disorders, and many of those people will say those psychiatric disorders bother them more than the symptoms of epilepsy themselves, which I think is really important for us to be listening to what's actually bothering people with these conditions. Importantly, in both of these situations, there's data that shows that that's above and beyond what we can explain by the level of disability. So for example, in the epilepsy study, they compared this to people with children with diabetes, and they found that even still controlling for all the medical stress that come with diabetes, the people with epilepsy had a much higher level of anxiety. We talked about genetic disorders, and as we're about to talk about cerebral palsy, while there's a lot we don't know about mental health in CP, we do know that that mental health disorders are very common, occurring in up to 60% in some studies.
And so, like we've talked about, we tend to think about mental health and sort of neurological or motor health in these very siloed ways. And it really is such an artificial distinction in so many populations for so many of the patients we work with, but in particular for folks who have cerebral palsy, the relationship between these two sort of artificially separate columns really, cannot be separated. To describe where somebody's motor symptoms and the impact and effect from something like anxiety, depression, insomnia, where one starts and the other stops is really impossible. And they are so interrelated that for us to manage one without even thinking about the other, for one, from a clinician's perspective, means that it's much harder to provide care, and the care that we're providing is going to potentially be inadequate. And we know from individuals and from families' perspectives, it often leaves so much to be desired in terms of really fully appreciating what's going on. Furthermore, when you try to separate something like a neurologist managing somebody's neurocognitive symptoms and a psychiatrist managing somebody's, say, ADHD, that's such an artificial construct that it really makes it impossible to separate those two. So we just want to emphasize that and describe that to really provide person-centered care, we have to be integrating these as much as possible. Spasticity, I think, provides such a clear example of this because I think it's very rare that somebody might be sent to a psychiatrist when it comes to a question of spasticity. But from our shared clinical experience, certainly from patients we've worked with together, and from a very small literature, but I think a burgeoning awareness, the interrelationship between something like anxiety or depression or insomnia and spasticity is very close, right? If somebody is very anxious, their spasticity may get worse, or their increase in spasticity for some independent reason could worsen anxiety. And it's very hard to manage one of those without the other. Then when you add other things like pain, sleep disturbance, and then you pile on the medications that we're talking about for managing any combination of those, it becomes so hard to tease apart. Many of the medications that might be used to treat spasticity can positively or negatively impact mood, anxiety, sleep. Medications that are being used to treat something like depression could positively or negatively impact a person's spasticity. So it becomes this cycle that at very least we have to try to pay. We may not be able to, as much attention as we could pay to it, it might not provide like the optimal solution to the problem, but if we're not trying to address these different components of somebody's experience, we're not going to be able to be successful in trying to be helpful.
Okay, so with that, we want to segue into more in-depth discussion about what do we know about mental health in individuals with cerebral palsy.
So to begin with, we just want to acknowledge how small and limited the literature on this subject is. There, in the last few years, have been more studies, which is wonderful, but it is a very small literature. And comes with a lot of caveats and limitations as a result. But you can see, just from one study, there's an enormous range of psychiatric symptoms or diagnoses found in children with cerebral palsy. But even at the low end, we're heading to about 30%. So 30 to 60% of children with CP would have significant psychiatric symptoms or meet criteria for formal diagnoses. So we want to make sure to acknowledge that one study pointed out that pain and activity levels were very important contributing factors for depression in children with cerebral palsy. So a large component of people's depression may have been mediated through the experience of pain and limitations in activity, which is just crucial for us to acknowledge. when we think about sleep, pain, and other modifiable factors like bullying or social engagement, these all contribute significantly across the board to the kinds of psychiatric symptoms that can be present for an individual with CP, but don't fully explain it. So it's not as though this is something that is entirely a result of these kind of secondary factors, going back to our point earlier about the layering of genetic and specific brain regions and all of these different contributions. In kids with CP, anxiety, depression, and behavioral symptoms were probably the most common, but as we look into adulthood, we start to see across the board elevated risks of almost all psychiatric disorders. We'll talk a little bit about adults in a second, but looking at sort of transitional age, and this is a study that looked at kids at 7 and again at 11, so heading kind of into pre-adolescence and adolescence, to try to see what's happening during this transition. And it was, I think, really interesting and enlightening. So essentially, having some psychiatric risks at 7 increased your likelihood at 11, as one might expect. But and this is just based on sort of the language from the kinds of research measures they used. But it's really important. So behavioral disorders are defined as things like oppositional defiant disorder, conduct disorder, or ADHD. So things that are thought of as more like externalizing, sort of potentially more challenging to the people around you than to you necessarily yourself. And emotional disorders were things like anxiety, depression, and those kinds of symptoms. So between 7 and 11, the rates of the behavioral disorders was stable, but there was a very significant increase, a 4-fold increase in the emotional symptoms as people aged, right? So anxiety and depression seem to become much more prevalent over time. And this is something that both Dr. Reardon and I have, I think, a real interest in and kind of are looking forward to more in the literature about this in the future. But there was a little bit, there was a looking at, well, can we think about CP subtypes? So whether a person has unilateral versus bilateral, dyskinetic versus ataxic CP, what does that tell us about certain risk factors? And it seemed like there were non-significant predictors of psychiatric symptoms. So it might be that in larger studies, there could be more information to pull out of that to help us predict. But at the time being, it doesn't seem as though having specific subtypes of CP gives us a huge amount of information about what person might be at risk for. And then finally, again, to the point before, modifiable factors, social supports, community engagement, and then things that potentially we can impact medically, sleep, pain, and activity level, again, in adolescents and then in adults, play a significant but not absolute role. So within adulthood, we see higher rates of almost all psychiatric diagnoses compared with adults without CP. And this is a point that we like to bring up a lot because whereas there are a few diagnoses that clinicians tend to pay a fair amount of attention to, depression, anxiety, we see even with diagnoses that we're a little bit less tuned into, schizophrenia, bipolar disorder, other diagnoses like that, rates are elevated for individuals with cerebral palsy. So it's something that we just try to emphasize the importance of clinicians and families being wary of, being attentive of, not in order to make people anxious or nervous for the future, but more just to realize that those symptoms should be part of the conversation too, and that this is not limited to just talking about things like anxiety or depression.
So when we think about the prevalence of neuropsychiatric comorbidities, we see a lot of overlapping through things. And it's important because, we've talked about the biological rate of like epilepsy has a high rate of anxiety, things like that. But some of these things have a direct effect on it in other ways. So for example, pain is incredibly common in this population. And we know that pain has a long association with anxiety or depression. So addressing that is there. Communication disorders are very common in our individuals with cerebral palsy, both in terms of of dysarthria, expressive language disorders where you have trouble getting words out, but also, you know, are we giving people the language they need to be able to communicate their emotions and things like that. Similarly, ADHD is very common, up to 20% for people with cerebral palsy. And then when you take it out and kind of, ADHD is a diagnosis, but there's also something called executive function, which is basically all the tasks we need to function in life, like, you know, starting tasks, finishing tasks, control, you know, managing our emotions, things like that. And when we look at all of those things together, 40% of people struggle with these things. So that also will then feed into it, because if you're struggling to keep up on life, if you can't get your stuff done at school, things like that, that's going to contribute to some of those things like anxiety, depression. So they all feed into each other. So, you know, just to kind of step back and summarize what we've been talking about, you know, historically there are kind of three ways that people have approached mental health in people with cerebral palsy. One is you can look at it as under a shared etiology, this brain injuries, brain malformations, genetic disorders that put you at risk for cerebral palsy, but also put you direct risk for mental health disorders. There are shared risk factors that we have. For example, prematurity is a risk factor for mental health disorders as well for cerebral palsy. We talked about epilepsy, birth complications, same thing. And then there's this cause and effect, which I think is the easiest association we think of, which is, you know, these people with cerebral palsy deal with a lot, right? They just do. And there's medical stressors of frequent hospitalizations, frequent surgeries, having to come and get Botox, doing therapy, missing out on social things, either because they're in therapy or in the hospital, or because the world's not set up for them to be able to participate appropriately, especially as they get into adulthood. Bullying is a problem, and you know, something I haven't seen literature on, I like to call it the grief of normalcy, that a lot of our kids hit, especially around that 11 to 15 years of age, where at that age, everybody just wants to be typical. Whatever typical means, I don't know, but that's what they want to be. And when you have a very visible disability, it's, you know, it makes it very hard not to be that typical that they want to be. So it's a tough times. So we can think about all these things separately, but the reality is it's more like this. So if we really want to focus on somebody's well-being, we need to see this global picture, and we need to see the way all of these things are interacting together to affect somebody's mental health, their participation, their well-being. So with that, we're going to kind of, again, segue into some approaches for treatment. We know that this is more common. What can we do to help?
So we'll start out with just talking about some sort of general principles, things that we always recommend to clinicians or to our trainees, but also we really want families to just be thinking of and maybe trying to help clinicians remember as well, if necessary. So first, when somebody with cerebral palsy comes in with some new complaint or new concern or worsening or changing of an underlying symptom, we really want to make sure that this is not the immediate result of some kind of modifiable medical condition. Common ones that we very frequently typically see, things like GI concerns, constipation, so common. Other medical illnesses, pain or occult infections, these kind of things come up so often. Or conditions that could be completely unrelated to CP, but because of challenges with communication, we might miss things like gallstones, other infections, dental issues, these sorts of things. So we always try to really have as much collaboration as possible with other specialists in terms of diagnostic and treatment options, and we'll talk a little bit more about the specifics of some of these. And then focusing on psychoeducation both with clinicians and with families, and focusing on family-based interventions and psychotherapies prior to thinking about things like behavioral medications. Not that there's not a role for those, not that those things cannot be incredibly helpful, but the last thing that we want is for somebody to come in with, you know, an exacerbation of constipation and for us to start a medication that would definitely worsen that. Or for somebody to come in with a behavioral issue that is a manifestation of, you know, a life stressor or something that could really be managed through different forms of talk therapy or behavioral interventions, and for us to focus only on the medication sides of that. That is going to be less effective from a treatment perspective, and also increase the likelihood like we looked at before, increase the likelihood with side effects and all of these relationships to potentially, worsen various symptoms. So then we try to take into account what medications somebody's on, if they're on medications already, and seeing where we can optimize that overlap. If somebody's on a seizure medication that also potentially at a higher dose could be helpful for certain behavioral symptoms, we would probably rather slightly tweak that medication than add on a whole new medication in a different category, for example. So we try to take advantage of those, consolidate or minimize therapies, try to pull off medications where it could very well be a side effect of those medications. And that really often requires a pretty in-depth conversation between clinicians. It can be challenging if you have an argument between two different specialists about whether or not the medication the other one is prescribing could be contributing to worsening symptoms. So just being aware of what those conversations are like and that they can get complicated in their own right. And then where possible, we try to base decisions on the literature. If things are FDA approved, wonderful. Often they are not. Often there is some small literature, sometimes there is not, and we're going based on our own clinical experience or people who have been doing this for longer and who are wiser than ourselves. So there's this kind of like stratification for different ways to approach these questions.
So when we think about strategies to approaching mental health in individuals with cerebral palsy, I think, the first thing, like we mentioned, we want to make sure the psychiatric symptoms are not due to an underlying cause, like pain, intrathecal baclofen pump malfunction, shunt malfunction, common things like dental problems, hearing, ear infections, things like that. And obviously we want to make sure that we're not the ones causing the problem as physicians, right, with medications or the treatments we're prescribing. Collaboration is so important in terms of kind of thinking through these things together. You guys know more than anybody that oftentimes you're left to be the ones to try and be the in-betweens as much as possible, trying to help people get together and get on the same page if you're hearing conflicting things from different people. Is really important because psychiatric symptoms can worsen physical symptoms. Like if you're very anxious, that'll kick up your dystonia, for example. But the other way thing can happen too, where having having a psychiatric diagnosis can, give us an opportunity to treat in different ways that we may not have thought about before. We always want to maximize the benefit of the medications we're already on. Many people with cerebral palsy are already on a long list, and the more medicines you add, the more risk you're at for interactions between medicines. So we want to take opportunity for anything we can kind of use and take advantage of, and then minimize side effect profiles whenever possible. When we think about, Dr. Hopman talked about behavioral treatments, and I think we don't talk about this enough. We medicalize cerebral palsy so much that we don't think about these things like we should. But there is a little bit of evidence for certain things in cerebral palsy. Certainly, there's a lot we can extrapolate from the general literature. When we think about behavioral intervention, there's kind of two big categories. One that's focused on the parent and the family, and one that's focused on individuals. When we say focus on the parent or family, I want to be clear, this is not because the mental health is your fault, okay? This is because people who have special needs need special interventions to be able to help them to be able to work through this, the same way that somebody who has anxiety for anything benefits from having help through there. But parents have the ability to be able to be there 24/7 with their child, whereas a therapist can only be there once in a while. So similar to when you go home and take exercises from PT, this allows you to take some skills from a therapist there and bring those home as well. There's a few different programs that do have a little bit of evidence, which is really exciting. There's not a lot in this talk that has evidence, but there's at least one study that shows that the Stepping Stones part of this positive parenting program, or what we call the triple P, can be helpful for younger people with cerebral palsy, as well as this acceptance and commitment therapy can be helpful. There are some more general principles that can be definitely helpful. Parent management training and parent-child interaction therapy, which is a very cool program where a therapist will watch you working with your child and give you tips which is, can be very helpful. The other side is individual-focused therapy. So the most well-studied treatment for our anxiety and depression and other mood disorders is cognitive behavioral therapy. It can be very useful for our patients who are able to communicate sufficiently and engage in that in a meaningful way. If you have somebody where they're being kind of triggered in their mood symptoms or anxieties being triggered by sensory components, because that can happen. Working with an OT to work on sensory symptoms can be helpful. Similarly, sensory symptoms can sometimes affect attention and mood, attention focus in other ways, so sometimes it can be helpful for that. With executive function. And then for those people who have co-occurring autism or significant intellectual disability that makes it hard for them to participate in some of these things like cognitive behavioral therapy, applied behavioral analysis can sometimes be helpful.
And one thing I want to make sure to be clear about is the lack of we don't have a large list of specific therapies to recommend, not because there's evidence that these are not helpful, just there's a lack of evidence across the board. And it's something that the psychotherapy literature, I think, often struggles with when we have populations that are so broad and include people with such different capabilities and challenges that it's very hard to come up with single therapeutic interventions that could be applied to everybody across the board. So it makes it difficult to give a global recommendation in the way that we do in terms of oh, well, the treatment for depression in the general population is cognitive behavioral therapy first. It's just harder for us to do that. So, as Dr. Reardon said, it's crucial from the clinical perspective for us to engage both the patient and family in these interventions. And a lot of the kind of that focus is going to depend on what the individual's communication strengths and weaknesses may be, as well as what the particular concern is. That will guide a lot of our decisions about what kind of therapeutic interventions we might focus on. So one thing, as any part of kind of integrating behavioral therapies or psychotherapy into treatment, we need to make sure that we understand for an individual how communication and intellectual function or intellectual disability may impact behavior. So we will often try whatever the therapeutic modality that we're focusing on, making sure to integrate augmentative communication, visual prompts, storyboarding, and then trying to include language around emotions and cognition in sort of our standard parts of routine care. This slide over on the right comes from specifically working with populations who have autism spectrum disorder. But this is a kind of a nice stand-in in general for certain ways to approach particularly aggression, agitation, or violent behavior in individuals who have a neurodevelopmental disability pretty broadly. So what often happens is we, as clinicians, we may not hear anything about this for a while until there's some severe fallout of some of these behavioral challenges, and then it becomes heavily medicalized because the things we may have to offer are medications, often fairly intensive ones, to try to focus on those episodes of acute dysregulation. The goal of especially family-based therapies are to try to figure out how do we recognize what's leading up to those, what are the antecedent events, what are the triggers for these things that start to kind of push the ball kind of over the edge and start rolling downhill. And then how do you intervene at different phases of this? Because it's going to be different. The thing that you have to do to keep somebody safe and comfortable and make things improve when somebody's at that very 100 out of 100 place in terms of an episode of aggression, self-injury, those kinds of things are going to be very different from what you try to put into place as you're just starting to notice those warning signs. And so having a plan, sometimes even written out for, well, when this happens, we do this. When this happens, we do this. So you really have a plan for different phases along the way for how you might intervene from just a behavioral perspective. So that's just one example of how some of those behavioral techniques might be integrated for this particular question of especially kind of more like agitation, aggression, or self-injury.
So when we think about different conditions, we're not focusing as much on anxiety or depression in this particular slide because the things aren't as helpful. But we wanted to kind of put out some ideas for you guys about different treatments for different symptoms and how we might pursue this. So I think a good example would be our self-injurious behaviors. So if somebody's having self-injurious behaviors, we'd first of all start out with our behavioral techniques, safety interventions, and try and optimize what we can there. We want to make sure that there's nothing like pain that's leading to that self-injurious headaches. If they're knocking on their head, is it because they're having headaches or shunt malfunction? That would be important to know. And make sure that we're giving them opportunities to be able to communicate their needs as much as possible, because you can imagine how frustrating that is to have something that you can't express. If that doesn't work, we might start with some medications that have low level of side effects, and then kind of go up from there to things that may have more side effects, but maybe are working in a different way that may be more effective for that individual.
So this is not a comprehensive slide by any stretch of the imagination, and almost everything here is off-label, but this can be helpful to just think about in terms of first, second, and third line treatments. We like to use this in a lot of different talks with variations of this for folks with different neurodevelopmental disabilities, because often clinicians really do have their sort of go-to medication that they tend to focus on. But, for having possible options that could be helpful with fewer side effects early on and going stepwise can be, I think, very useful. And just thinking about different ways in which we can optimize treatment by trying to use as few medications to cover as many possible symptoms as we can. So this slide focuses on that. So this is a chart of a range of different symptoms and a range of different medications. Again, certainly not comprehensive, but looking at potential overlapping benefits of these medications. So you can see where something like clonidine, which is an alpha agonist, historically it's been used for blood pressure, but often has an approval for ADHD, but can be used for anxiety or agitation, or headaches, or autonomic storming, right? You can imagine how you could get a lot of birds with one stone with that medication. Or you could imagine each of those being treated with a different medication.
So on a similar note, we also want to make sure that we're not making things worse and that we're thinking about things. So there are some medications that we might be using for neurological symptoms that may worsen some of our neuropsychiatric symptoms. Like Keppra, for example, is one I think most people have heard of that sometimes can increase agitation. Similarly, some of the medicines that we may use for mood disorders or for behavioral symptoms may worsen some of our other comorbidities. So it's very important to kind of keep this in mind, again, that balance between potential benefit versus potential risk for each individual patient, for each individual needs. One caveat I will say as we're looking at this slide is that because people who have had some sort of injury or something different about how their brain is functioning, I think they're done. So I think, sometimes what we find is that people with cerebral palsy or other neurological conditions don't react typically in terms of medication, so that you may find that when you take a medication that usually makes people sleepy, it makes you wired, or vice versa. So I've been in this field long enough to what I tell my patients is that's not a typical reaction, but I never say never because I've seen too much. So I think that's important to acknowledge too as we're thinking about potential side effects. If you are seeing that, sometimes weaning off the medicine for a little while and then a retrial can help you know, was it just a fluke or was it really this medication, as a way of kind of a proof of concept, because you have to be careful. The longer you go, like the more medicines that you go down that list of whatever your provider has, you're going to hit those medicines that have more side effects. So sometimes it's worth it to retrial or really be 100% sure that first medicine was causing a side effect before you give up on it, so that you're not ending up with something that potentially could cause more problems down that list. So with that, we'd like to move to a case example of how this looks in real life. So the patient that we want to talk about is a 10-year-old girl. She has a history of prematurity at 26 weeks with a history of intraventricular hemorrhage leading to hydrocephalus that's been shunted. She has a history of seizures secondary to this injury and has spastic hemiplegia. And she's presenting with worsening impulsivity and violent behavior. So as we're thinking through that, the first thing we want to do is we want to make sure there's not a medical concern, that this isn't a medication side effect that we're causing. So we're going to think about seizures. Seizures are actually a pretty rare cause of behavioral disorder, of behavioral symptoms, but very rarely, if the symptoms are really stereotyped or odd, that can be a frontal lobe seizure, or if people are having very frequent subtle seizures, sometimes that can come out in being agitated because you just don't feel good. We also want to make sure there aren't any psychiatric causes. Sometimes I think it's important to recognize that sometimes symptoms like irritation can actually be due to underlying anxiety, or depression kind of masquerades as that one thing, especially if there's problems with communicating what you're actually feeling. We see that a lot in kids and teenagers, right? Depressed teenagers tend to be really irritable, so that's something we see a lot. And then also look at what psychosocial stressors are going on. Is there something going on at school? Is she getting bullied? Is there stressors at school? Is she struggling? So with this girl, we started a medical workup, screening for constipation, infection, dental or other pain. We wanted to look at the shunt, make sure that that's not malfunctioning, she's not having pain as part of this. An EEG to make sure that there's not something different with her seizure, since this was an acute change that we were seeing. Looking at neuropsychological evaluation to see, is there something with school that's not getting addressed appropriately. Looking at psychosocial and educational factors, and then also psychiatric evaluation to look for underlying mood or anxiety disorders, ADHD, things like that.
So fortunately, when the results of all those tests came back, this was somebody where no medical cause could be found. So there was nothing that acutely had to be done, like managing her shunt or anything like that. Neuropsychological testing actually showed normal range IQ, but a very wide split in some of her subscores. So this is something that if folks have looked at neuropsych testing for their kids or other family members, it can be very confusing because we often have a tendency to think about IQ as one number when in fact it's sort of an average of a bunch of different numbers. And so that one number, especially when the range is pretty broad and the strengths and weaknesses are, a lot of peaks and valleys, can be extremely confusing because it can look as though somebody's functioning at a higher or lower level than you might anticipate. So in addition, a diagnosis of autism spectrum disorder was given, and anxiety and ADHD, which had been suspected, were verified. So this gives a whole list of potential interventions and tools. This was an individual for whom I think the conversation with the family was really crucial and really sticks with me to this day, because this was a family that really felt like it was their fault, everything that had happened to this child, and that the behavioral challenges were their fault. It was a result of bad parenting. And so for us to go through and talk through her MRI, all of the different things that had been part of their experience, the shunt, all of this, was, I would say, one of the most helpful things we could have done, because it really contextualized that this was not an issue of fault or culpability or anything like that, but a very complicated child who had very specific needs that we were working on trying to find appropriate solutions for. So that in and of itself was something that felt, that seemed to be particularly helpful. Beyond that, coming up with a new IP, appropriate school setting, all things that I know have been already discussed a little bit earlier today. And then addressing anxiety through first psychotherapy and then antidepressant medication, and then a couple of options for ADHD. So kind of standard psychiatric medications. Things overall improved, kind of rocky over the course of the next couple years, but with a lot of ongoing maintenance, things really went a lot better for this young woman. And then she had another acute worsening of these behavioral symptoms that initially started out as, again, aggressive, sort of violent behavior, but was a pretty acute change. And so those studies were redone, and this time it was actually found that this was happening in the context of shunt malfunction, which was rapidly addressed. Fortunately, very positively, with a good outcome and improvement in the symptoms, as well as managing her hydrocephalus. But I think this so clearly emphasizes how that similar spectrum of symptoms could be a result both of this complicated sort of set of developmental and psychosocial and educational things, as well as like a very neurological underlying cause that needed acute management. So she's doing pretty great. Yeah, so just this, we hope really clearly kind of helps emphasize the workup, some of what the management techniques are, and how vigilant we have to be that, that these things can be very dynamic symptoms, even as we're starting to feel more comfortable with how somebody's doing when they're feeling stable.
So with that, we wanted to open up the floor to all of you, because I'm sure that there are people in here who are having experiences with this and have thoughts or questions to ask each other as a group, and also we're happy to help out where we can.
Hi, everybody. I'm Chris Geddes. I am a fellow member of AACPDM with a background in education and federal government programs. I'm 57 with cerebral palsy. I would like to address, there are children that are being checked neuropsychologically, but as an adult, you know, nobody checked me as a child that I know of. And if they did, you know, I've had IEPs in school, so you know that. But, you know, as you age with cerebral palsy, other things happen. And I mean, I'm not afraid to tell y'all I have bipolar. I go to a psychiatrist for that. I know many people with cerebral palsy that have that. We're dealing with brain injury and differences in brain chemistry. So, you know, 21 years of therapy is wonderful. I have PTSD from childhood difficulties in therapy that were inappropriate, so dealing with therapists has been difficult over the years. I would like to talk to you at some other time, but I do think that it is extremely important to be able to look at the pharmacology of adults, because I can tell you, nobody looks at my pharmacology except a nurse, and I only have 10 minutes with a doctor. And if I'm sitting there needing to talk to her about a neurogenic knee or a sternotopy with corpectomy and needs for referrals, I don't have time to go over the fact that I've been on the Mixol for 15 years and is it working? And my other doctors just want to put, you know, I had a psychiatrist a while ago, but he just wanted to over-sedate me. And that certainly isn't going to work with a pain medication. So I think we need to, you know, I heard somebody say, well, I don't have bandwidth for you. I'm this kind of doctor. Go to your CP doctor. And then my CP doctor says, well, I'm this. I've seen 50 providers since the last conference. If you add physical therapists, occupational therapists, speech therapists, neurosurgeons, gastroenterologists, urologists, let me just continue. I'm not talking about the pharmacists or radiologists that read my scans. And I am now saying, well, I can't go see anyone anymore. My husband and I are going to go bankrupt, you know, because we need to divorce for me to get Medicaid. I won't do that. All those things said, I encourage research that allows people like me to not feel like there's shame in taking these medicines, because, you know, I drive with hand controls. And sometimes I don't want to be on a medication because I'm a responsible, defensive driver who's never gotten a ticket, and I have 2 adult children, and I'm going to be a grandma in January. And so we need help with how to frame how we look at ourselves. Because, you know, I know there's changes in my brain, but I'm scared to death of a neuropsychological exam because I am brilliant and I don't want to be stupefied. So please do something that we do not allow stupefaction as a way of dealing with anxiety or trauma or CP and the fact that my brain is different. And those brain images, I can give you a million. It's criminal and it's malpractice to not have some of those on me. That's my opinion. Because your children are going to be me. And you're going to want to know how their brain changed. Because they're going to go through other things, and their brain does change. So thank you. I hope I've helped the discourse. I do need to step out, but I would like to hear if you have any responses. I agree. Bravo.
Thank you so much for sharing that. I think it's heartfelt, honest, raw, and so important that we listen not only as a community, but get this message out to medical providers. I wish I could say that your experience was unique. I know it's not. We need to change that. But you know, I really appreciate you being raw and open with us about this. If there's something we can do, or if you want to connect later, we're more than happy to. I also want to say thank you and congratulations on your future grandchild.
One thing that we didn't, just to dovetail on your point, we didn't really talk very much about PTSD and trauma, which is something that we see in so many of our patients, between the medical experiences that they've had, surgeries, sort of growing up being in so many medical institutions. And this is separate from the fact that there's very good evidence that people who have really any childhood onset neurological condition are at increased risk for pretty much any of life's traumas. So it's something that we see so often in the folks who we work with.
Can you address, just based on maybe your your experience in your clinics, how your experience with intrathecal baclofen and how you think that may or may not impact an overlay with these other medications that for bipolar disorder? You're nodding your head, so I've been particularly
That's a really hard question, but also one that we've seen not too infrequently. I do not know if there's much data for us to lean on in terms of recommendations. I can certainly say that I've seen patients for whom, well, I'm not sure about the bipolar element, but I've certainly seen a lot of complicated interactions in terms of spasticity and anxiety and insomnia in particular, and especially once you get into things like people needing revisions or being, you know, when there's uncertainty as to the efficacy of the pump for an individual in managing their spasticity, or whether it might be impinging on a nerve or causing local irritation or pain. I'm not sure if you can speak to that side, but it's a complicated relationship.
No, it is a very complicated relationship, but I'm glad you brought it up. I think, again, to the best of my knowledge, I don't know of any data specifically addressing this. So much of what I'm going to say is theoretical or anecdotal, just to be very clear. I think that from a theoretical standpoint, the advantage of intrathecal baclofen in a theoretical realm is that the brain sees less baclofen than it would if you're taking it orally. That's why theoretically you can have a higher, more potent effect without having as much of the sedation as you would on an equivalent effect of baclofen. So from that standpoint, from a theoretical place, it should have less interactions with seizures and mood disorders, and because it's not going through the gut, there's less of an interaction with medications and so on and so forth. Now, in the real world, does that hold true? I think we need studies to show that, because I would say anecdotally, I haven't had people have, in your daughter's specific position, but I will say I have had some people who felt like they felt more depressed on a higher dose of oral baclofen. I'd say that's the exception, not the rule, but we need to be paying attention to the exceptions as well, right? Because they matter, and I don't think we can say the rule stands for everybody and so such and such doesn't happen. But I think we definitely need more data. I think it would be a great study to do.
Question. On your slide, propranolol is also Inderal, right? Is that the same drug? And you had a plus or minus on your under the column of depression.
Yeah. So there were some older concerns about propranolol potentially increasing risk for depression. Subsequent studies have not borne that out. I think it's still thought of as a theoretical risk factor, but it's a very commonly prescribed medication. So it's something that kind of goes as a little bit of a red flag because there historically has been some concern about that. But for the most part at this point, is not something I've seen clinically very often, but I think it's just something that we flag for awareness.
And you think it has, do you think it has efficacy for anxiety?
For some people, certainly.
Okay.
Yeah.
Last question, and I'll give up the microphone. Can you address tardive dyskinesia in terms of how often you're seeing that as a result from some of these medications?
Yeah, sure. We were just discussing this the other day. So tardive dyskinesia, and I just want to make sure, is there feedback from having the two mics, or are we good? We're good? Okay. Oh, great. So tardive dyskinesia, which is sort of most commonly something that we see from long-term use of antipsychotic medications, and is its own movement disorder that generally is reversible if it's caught quickly, but can require a lot of intervention, and if it's not caught or treated and people continue on these medications for a long period of time, can be an ongoing movement disorder even if the medication's withdrawn. There are certain antipsychotics which are considerably higher risk for causing tardive dyskinesia or contributing to it, and there are certain risk factors, including having an underlying neurodevelopmental disability, right? So certain populations already having a movement disorder could potentially put a person at risk. And especially if somebody has like, I would say it depends on what their motor manifestation of CP is, but it can be hard sometimes to recognize superimposed tardive dyskinesia if somebody already has a lot of dyskinesia and spasticity, because it's something that, you know, what we're supposed to do every time someone comes in is a very specific examination to check for signs or symptoms of tardive dyskinesia, which are very hard to do if somebody already has a movement disorder. And you have to be like pretty aware of what somebody's baseline is. So it's part of, I think, good practice from a psychiatric or neurological perspective to really like document well before you start the medication. I think especially in folks who have more like aggression, self-injury, more of these like externalizing kind of symptoms, medicines like risperidone or aripiprazole can sometimes be used pretty early on. It's why we like to emphasize using therapeutic interventions first, alpha agonists or other things second, and putting antipsychotics later on, because it really is very complicated in general, but specifically for individuals with cerebral palsy.
Follow up on that, a couple things from a movement disorder standpoint. Cannot emphasize the importance of knowing your child's baseline, because I try and document, but I promise you that I'm not going to remember your child as well as you, and other people may not be even paying attention. So if you're seeing something that's different for you, like new facial movements or things, it's important to note that and to trust yourself. I think the second thing to know with these medications, since we're talking about this overlap between neurology and psychiatry, is these medicines like Abilify, risperidone, these anti-dopamine drugs can sometimes actually be used to treat chorea and are one of the most effective treatments we have for that. So if you have somebody with choreiform cerebral palsy, you'll see us actually using that to either treat the chorea on its own or to co-treat mood or behavioral disorders as well as the chorea. Similarly, there's another side effect called dystonia or dystonic reactions that can rarely happen with these medications. And it's something that historically I have been nervous, that made me nervous about using them in people who have baseline dystonia. I don't know of any studies that have looked at this, so I'm putting on my anecdotal hat, so I want to be really clear about that. I would say I haven't personally seen them to worsen dystonia in my patients who have underlying dystonia. I think that's important. So at this point, I personally am not somebody I'm not scared of using them if I feel like they need to be used to treat other symptoms in patients who have dystonia. But I always caution people to really pay attention that if they're noticing a change in that dystonia when they start these medications, to let their doctors know, again, not wanting to worsen the movement symptoms by treating the psychiatric symptoms.
And the time course of those, the dystonia is generally something you would see almost immediately or very early on in using these medications, whereas tardive dyskinesia is something that we really need to continue assessing for, and rates in risk increases over time, overuse. So that's something that you really need to continually be looking out for.
It is usually easier to treat and stops when you stop the medication as compared to the tardive dyskinesia. So that's another reason I don't worry about it as much, because we can address it.
Can you point to literature for the support for ABA therapy for non-autistic persons with cerebral palsy?
Understanding, and I'm going to turn to you, is actually the initial data came out of people with intellectual disability, not specific for autism, although it's become more commonly used in autism. Now, getting insurance to pay for it if you don't have an autism diagnosis is where it's really challenging, but there are studies out there for that.
Yeah, I would also just caution, I think sometimes, especially because schools have such limited options for treatment that's done like within a school setting, sometimes we hold up ABA as the thing that we're like really looking for somebody to get, but it's not always clear that it's going to be beneficial, and it's a pretty intensive intervention. So it can be, I've seen people really struggle while getting ABA if it's not an appropriate therapy for them. So it's a little bit of a double-edged sword. It's a wonderful thing if it is an appropriate therapy, but we want to look at other options potentially that might be more nuanced if somebody has other kinds of concerns or underlying issues.
Let me say thank you, because I think you really made Benjamin feel seen today, which is important to me, his mom. But I have a question about, first, please do more research. I mean, if we need to volunteer, if we need to help recruit people, we need more information, we need more studies, we need to know more. Second, my question really though is, how do we bring this up with doctors? He has a fabulous doc who really listens to him and tries to treat everything about his cerebral palsy, but we really are in a cycle where his anxiety is causing reflux, which is causing him to vomit in public, which is causing anxiety, which is causing reflux, which is causing him to, and so we're in this horrible place, and she keeps increasing his anxiety meds and then increasing his reflux meds, and then trying to swallow all the meds is making him have reflux, we're just in this horrible place that we can't find the right answers, we can't find the right experts, and it's causing him then to have a social anxiety of being out in public, as maybe you can see today, that he wants to be here so badly, but this is really hard because of this horrible cycle he's in. Have you seen that? How do we start the conversation in treating it? Fix it, please, is what I'm saying.
Well, first, thank you so much for the question and for being here. I'm so glad that you came and are part of this. So I'm hearing sort of two questions in there. One is specifically in that circumstance, what could be considered, and how do you talk with your provider who you really like and have had a good experience with? How do you talk with them about something not working and maybe wanting to try something different or see somebody different? Is that, yeah. So I think I would hope that most of us would be pretty comfortable with folks getting second or third opinions. I'm always happy when patients or families ask me if they can see somebody else to get another set of eyes on a problem. I think especially if you've been working closely with somebody for a long time, it's easy for us to get myopic. It's easy for us to think that we've got a solution. I think that just broaching the subject pretty openly like that, like we've really had a wonderful experience, we want to keep working with you. We do feel like something's not working. Is there somebody who you might suggest could weigh in for an additional opinion, or who you might suggest that we go to for a single consult for another set of ideas, something like that. And I think, most clinicians, I would hope, would respond pretty well to that. I don't know if that's your experience.
No, I think, first of all, I want to commend your doctor for actually thinking about the anxiety and the reflux, because we are in a world where doctors are so short for time that a lot of people will go into the state of, I only see epilepsy, I only see this, and not think about the global picture. I agree. I don't know any neurologist or physiatrist who's going to complain about a psychiatric evaluation or consults. I think that most people would be incredibly open to that if you feel like you're getting to the point where you need that. And they'll be honest with you if they have other ideas that they want to try first, but it helps to, I don't think anybody would be offended by that.
Finding a psychiatrist who works with folks who have CP or other neurological conditions can sometimes be a challenge. I think it's actually a little easier in, I'm not sure if this is exactly right. Let me see if this is right. It may be easier in adulthood because there is a whole field of adult neuropsychiatry, and there are dozens of training programs in adult neuropsychiatry, whereas there's not in pediatrics. So you can find providers who work in that intersection within adulthood. You may want to look, the American Neuropsychiatric Association is the national organization that boards those providers, and they have a list of everyone in the country who is boarded in the field of behavioral neurology and neuropsychiatry. Whether their focus is on working with adults with neurodevelopmental disabilities versus focusing more on dementia and later sort of progressive neurological diseases sort of depends on where you're at, what their practice is like, but that could be a good population of providers to look to.
I would say also a lot of people have connections. If you have a neurologist or have any connections with any neurologist, I'd ask them if they have any suggestions, because a lot of the conditions like Huntington's disease, Parkinson's disease, and whatnot, that some of these neurodegenerative disorders in adults overlap in cognitive, movement, and mood as well. So those may also be opportunities. Somebody who's comfortable with those conditions should be comfortable with seeing somebody with cerebral palsy. It's not a perfect overlap, but there should be some.
I just wanted to comment on that too. I'm one of the physiatrists here, and there's not many pediatric physiatrists in the country. And from that, I would never think that I'm the right doctor for everybody. And I always appreciate when people question what I'm doing, from both patients and families, and saying, I just want to see what else is out there. So either something that I'm helping with or something that isn't in my number one comfort area, because there is a similar training, but everyone's more comfortable and has more experience in different areas. So I think that you should always question everything. I think that's a good thing, and yeah, no one should have an ego to say, no, mine's the only way.
To echo on that, I would say I usually appreciate when people question and bring up the conversation. It helps me understand where they're at, but also helps me to take the time to step back and think, is there something that we can do better? Would it be helpful to have somebody else engaged in the conversation?
Thank you so much. I'm a developmental pediatrician, so I'm just going to weigh in on the ABA, but before I do so, I never get insulted when somebody wants a second opinion. I think that's, if somebody's insulted, I don't know how to comment, but they're in the wrong business, let's just say, because we really don't know a whole lot in medicine, and a lot it is more an art than a science. I know we're trying very much to put guidelines out and evidence-based and all, but it really is an art. About ABA, I just was going to comment. I have yet to be able to get ABA on someone that the insurance will pay for that doesn't have a diagnosis of autism. And I just was going to second that ABA may not be the right thing, that there are a lot of behavioral therapies out there that might be just as helpful. I'm a big fan of ABA, but it's very rigid in its mannerism of how people are treated. And so it's not right for everybody.
Helpful.
Is that it? Hi, I just wondered if in any of your research, if you took an individual's diet into consideration, how it impacts their mental well-being.
I think right now there's a lot on the internet about the intersection between celiacs or gluten insensitivity, health, and different diets and things. There's also a lot of literature on the way that just general healthy diet affects our mood and behavior. So I think those are two separate questions. I think there's a lot we don't know about these food sensitivities or dye. Certainly, I always in that area of caution, as long as you're not limiting everything you're eating to just, toast, and you want to try to get something out of your diet and see if it feels better, that's fine. I mean, we probably would all feel better if we got artificial, ingredients out of our diets. But I don't know that there's as much data. On the other hand, we do know that exercise, getting out and being active participating in the community, which is one of the things we really need to advocate, especially as people with cerebral palsy get to be adults and making a space for them. And also having a good, healthy diet, avoiding things that we know tend to worsen mood, like heavy alcohol use, things like that. All of those things are important. I don't know if you have other thoughts.
Yeah, I'm not sure specifically for individuals with cerebral palsy. This certainly comes up generally in the autism community. And people trying out different restrictive diets. There's not really much evidence for any of the particular diets that people try in terms of benefiting the underlying symptoms of autism. And the only exception, I think, of a diet that really does have good evidence is if specifically people have treatment refractory epilepsy, there's good evidence for ketogenic diets in some populations when it's done carefully. One does have to be a little careful with heavily restrictive diets because if you're already, for somebody especially who has like comorbid autism, if you already have some restrictions, already feel different from your peers, not being able to be at a party and eat things that other people are eating, you already feel like even more separate from what's going on. And given that we don't have good evidence in favor of a lot of those interventions, it's something that I would just caution folks. It can be potentially helpful, but also taken to a lot of extremes.
I think from a similar standpoint, for people who may have difficulty getting all of their calories by mouth, or just because of dysphagia or swallowing problems, it's really important to be thoughtful about nutrition. What I have seen is some people get so restrictive on the diets that they're using to try and help with, mood, behavior, autism, whatever it may be, that then there become nutritional concerns. So just be really thoughtful about those things.
Thank you for your talk. I'm actually an adult neurologist, but I have a 6-year-old with cerebral palsy and a lot of complex medical conditions. Do you have it? I struggle with trying to figure out if he might have anxiety or depression because he has behavioral problems. Are there any scales or measurements to help assess a nonverbal child, who has a lot of thoughts probably, but can't express them? And also, what type of provider would be the best to bring, we see a lot of specialists. Again, we have, a lot of people refer us to other specialists. How would you suggest assessing for that?
Well, first of all, I think you're asking the million-dollar question, and there's actually a session later on that I'm going to be attending in the main conference that does talk about how do we assess these things. I think it's a conversation as Dr. Hopman and I have talked about a lot. There's a scale called the SDQ that has some evidence in cerebral palsy, but they didn't differentiate for those who are verbal and nonverbal, and I think that's where it becomes particularly hard, not only in children, but also adults who are nonverbal, who haven't been taught language because they've been so focused on the physical side of things, or who have dysarthria, so it's hard to understand them. It can be a really big issue. I think that, you know, if you have, I don't know if your child's treated by a physiatrist or neurologist, but if that individual is, I would start out by having the conversation with them, and if they're not getting there, I mean, in an ideal world, you're going to be able to see somebody like Dr. Hopman or get neuropsychological testing, but even starting with the psychiatrist can sometimes be helpful. I'm sure Dr. Hopman has additional thoughts on this.
And also along that line, can you do a full neuropsych testing in a child who's nonverbal?
Yeah, you can. Not necessarily full neuropsych, but there are modified neuropsychological evaluations. We're getting a little bit out of my wheelhouse, but the answer certainly is yes, assessments can be done. And I'd be very curious what comes of that conversation later in the conference about specific like questionnaires. I think we often look for other sort of more motor or autonomic or other kinds of signs or symptoms of distress. But sometimes it really is difficult for us to tease apart. But a lot of tracking or even using apps to sort of track causal relationships between potential stressors and signs or symptoms that you're noticing could be helpful. It's difficult with things like dysautonomia, which we might use in other contexts, but if you start to notice those patterns, that could be good information. Yeah. Yeah, we can discuss that. There's some that I tend to recommend. There are none that I'm like involved with or have any sort of like formal, there are some apps that I have a tendency to use in more broad mental health. I'll try to think of them. Yeah.
Could you share a little bit about how you work with the other providers in the Kennecott-Gruder Institute? Because you shared about the case earlier, and it's a very complex case. How did you all work together to be able to support that child?
So that was a case of somebody who I had seen at a previous institution I worked at. I would say, every institution has very different sort of functions and relationships between programs and departments. Kennedy Krieger is wonderful for the huge array of available services. I think in some clinics there are multidisciplinary teams, so 4 different clinicians will see somebody on the same day or even in some combination at the same time. So sometimes that's done. That's not something that we have done in terms of caring for patients together. Yeah, we have a weekly neuropsychiatry conference where clinicians from all over the hospital or outside will present cases and will weigh in. It usually has a few neuropsychiatrists, neuropsychologists, sometimes PT/OT speech. Dr. Reardon is often there. So a lot of us will come together and coordinate through meetings like that. I think that having a sort of like semi-formal approach like that tends to work particularly well, just because otherwise, like any institution, like there are lots of silos that we're all sort of working within and between.
So in full disclosure, I joined Kennedy Krieger less than a year ago, so we're still, I felt very fortunate here. Not everybody has a Dr. Hopman that they can call, but there have been certain, but based on my prior experiences, one of the first things I did as a provider is find somebody like him to establish an informal relationship with so that when these things are coming up in clinic, I have somebody to back up, somebody that I can discuss cases with and think through and get resources, because it is so important. I was previously at Vanderbilt, lovely institution, psychiatry services in Tennessee in general are abysmal. So I couldn't, as a neurologist, the only way I could get my patients in with a psychiatrist at Vanderbilt was basically if they were psychotic. But I had a really good relationship with the psychiatrists where, you know, I had their cell phones. They said, call us anytime. But that took effort to build those relationships. So I think the onus has to be on us as a medical community to change the culture, have those. The places where it gets really hard is if somebody's followed by an outside psychiatrist, and everybody's very busy. So I certainly have had many times I've played phone tag with a psychiatrist or left messages and didn't hear back simply because it's just hard to get in touch. But I think with this intersection between all the medicines and stuff, it really does make a big difference to have those conversations and that line of communication open.
Do we have any more questions? Thank you all so much. This was an amazing conversation and presentation, and I'm tremendously grateful, and you've given me I do want to dispel a piece of misinformation that was given earlier. There is not a tour after this this meeting today. So after the adaptive sports is over, it is over. There will not be a tour. But I am grateful for you both today. Thank you.
The opportunity, and thank you everybody for all of your great questions. It gives us things to think about as we move forward.
Hi, everybody. Thanks for joining us today. First of all, I'm going to introduce those of us on the AACPDM Committee of Adaptive Sports and Recreation, and then we'll introduce our panelists in a few minutes. My name is Karen Romer. I'm a nurse, and I am a research coordinator in our CP clinic and in Memphis, Tennessee at Le Bonheur Children's Hospital that is run by orthopedic surgeons at Campbell Clinic. And then we have Dr. Susan Duff. Dr. Duff is an associate professor in the physical therapy Crean College of Health and Behavioral Sciences at Chapman University in Irvine, California. Sue works per diem as a pediatric hand and upper extremity specialist at Cedars-Sinai Hospital in Los Angeles. As a clinician and researcher, she focuses on the assessment, acquisition, and recovery of prehension and motor skills. Current research projects include the examination of key assessment tools, as well as the design and testing of targeted intervention strategies to augment recovery in function in infants, children, and adults at risk due to peripheral and central neurologic conditions. Sue is the incoming chair of the Adaptive Sports and Recreation Committee of AACPDM. And next we have Dr. Gavin Colquitt. Gavin is the executive director of the Blue Cross North Carolina Institute for Health and Human Services at Appalachian State University and professor in the Department of Research Management and Physical Education. He is a certified adaptive physical educator, certified strength conditioning specialist, and fellow of the American Academy of Cerebral Palsy and Developmental Medicine. Dr. Colquitt has developed multiple community-based programs to meet the needs of children with cerebral palsy. His research focuses on improving health and physical activity among children with cerebral palsy through home and community-based interventions.
All right, thank you everybody for sticking with us. I know this has been a long day, but we hope to share some really exciting things about some adaptive sport opportunities that are going on in this region. Really glad to have GLASA joining us today. I've known Cindy for several years. We actually met over COVID when we were trying to do some resource sharing for families who were, so they could still be active during the pandemic. So, and I do not have any financial relationships to disclose. So when we think about physical activity, we really have to think about it in different contexts. A lot of times we talk about the importance of being physically active, and that just kind of we think it's the same thing as exercise, but it's very different. And specifically, physical activity for people with cerebral palsy is very different. We've done studies where we know that, just for individuals with GMFCS4, for them to remain upright and maintain current postural stability, they're actually expending energy at a greater amount than a typically developing person. So we have to think of how are ways that individuals with cerebral palsy can be active, and we look at that not just through exercise, but also through sport, and then also recreation. We know that any form of physical activity can benefit and enhance the lives of people or anyone, but is specifically beneficial for individuals with cerebral palsy. One of the things that we know is that individuals with physical disabilities, so they've looked at adapted sport athletes, and they have found that it is a significant vehicle for the improvement in quality of life for those individuals. They're happier, they're more satisfied with life. Some of the feelings that they've experienced include, inspiration, motivation, and then it also has a beneficial effect on peer relationships. So especially during individuals in these formative years, that is extremely important, both inside and outside of the adapted sports settings, the connections that individuals can feel, whether it's being a part of a team, additional positive relationships with coaches and other older adults and mentors. And then overall, we know that sport and recreation and any form of physical activity is going to be extremely beneficial for individuals with cerebral palsy. For example, we've seen improvements in gait, balance, cardiorespiratory fitness, strength, pain. These are all things that can be improved when individuals are active. Now, there are just as there are different ways we can think about physical activity, the World Health Organization has guidelines on how much individuals should be active. And these were recently rewritten to include individuals with physical or with disabilities. However, we know that, again, the way individuals with cerebral palsy respond to activity or exercise or sport is a lot different. So there are specific recommendations for individuals with cerebral palsy on how to be active, and those were published in 2016. What we do know is that participation is one of the most important things. In many respects, physical activity is just a part of the potential benefits that individuals with cerebral palsy and other disabilities can experience when they are participating within a team setting. It's really important that these opportunities and these recreational activities take place within the community, that they are integrated into the community, so within the same local parks and recreations facilities or departments or whatever that typically developing kids are participating in. And we do know that there are significant barriers, and these barriers are real and substantial, but they can be overcome. And in this area, in the Chicago area, we're really lucky to have multiple facilitators, so to speak, such as GLASA here today. So I'm going to let Karen introduce our panel.
So I'm going to start with Cindy Hausner. Cindy is the founder and executive director of Great Lakes Adaptive Sports Association, which is GLASA, a nationally recognized nonprofit organization that provides adaptive and Paralympic sports programs to youth and adults, including veterans who have a physical or visual disability. Cindy's credentials include current track coach for Team GLASA, 2019 co-leader Team USA Paralympic Junior World Championships, Games Director for the Great Lakes Region Games and Adult National Open 2006 to present, Competition Committee for Move United, Co-Team Leader 2015 and 2018 International Wheelchair and Amputee Sports Foundation World Junior Games Team USA, past board member of Wheelchair and Ambulatory Sports USA, former executive director for the National Wheelchair Athletic Association, games director of the 2010 National Junior Disability Championships, and Team USA athletic manager for Seoul Paralympic Games. And then next we have Mac Dong. Mac is a leg amputee and GLASA program manager. Mac played wheelchair basketball at the University of Indiana, Champaign, and then professionally in France. Mac is originally from California and has participated in adaptive sports throughout his life. He coaches and oversees a number of GLASA's adaptive sports teams, as well as playing adult wheelchair basketball and football. Thanks, Mac, for being with us today. And beside Mac, we have Margaret Bodwin. Is that close? That's not. Okay, Margaret is a young woman who competes in para, track, and field, as well as participating in other adaptive sports. Now in her early 20s, Margaret has competed since early grade school. She lives in Michigan and has competed in meets on a national, regional, and international level. Margaret has also qualified and competed at the U.S. Paralympic Track and Field National Championships. Margaret competes as an ambulatory athlete and due to cerebral palsy has paralysis on her side affecting her arm and leg. Thanks, Margaret, for being here with us today. And then last in the rockin' pink wheelchair is Peyton Maningo. Peyton is a high school senior with cerebral palsy and ambulates in a manual chair. She competes in wheelchair basketball, field, club, race running, and many other sports. Peyton is an excellent student and is looking forward to competing at the collegiate level. She has also qualified and competed at the U.S. Paralympics Track and Field National Championships. Thanks, Peyton, for being with us today.
Okay, thanks so much for being here. What I'm going to do is lead the questions, and then we want to open it up to everybody to ask questions. But first I'll lead, and hopefully we can kind of go down the line, and that would be probably the best. So this will lead, but I'll also improvise a little bit. Can you just tell us, like, what specific sports or activities you're currently involved with, starting with, maybe starting with Peyton. You can just grab the mic and kind of go through.
I'm currently involved in track and field, and I do the 100, 200, shot put, discus, long jump, and javelin.
Nice.
Hey guys, wheelchair basketball's been kind of my main sport since I was 5. I played professionally overseas, over in France. I went to University of Illinois, where I was captain of the team, and we've kind of competed all across the nation with that. I've also been a member of Team USA Amputee Soccer, and actually they're traveling over to Poland pretty here soon. But yeah, I also play wheelchair football for GLASA. We're sponsored by the Bears, and I think they're going to beat the Packers today, so that'll be interesting. But yeah, just a wide variety of sports, and I'm blessed to be the program manager and able to help others find the sport that they'll love and that they'll continue playing into their later years. Yeah.
I just want to add, Margaret, you did forget one thing, and Margaret was just named to the World Ability Games, and she'll be traveling to Thailand this December to compete in her events. So yeah, what do you mean you forgot about that?
Congratulations, super. All right, I'm going to move on. I'm going to ask just some other questions. I think, how did you first get introduced to doing sports and recreation, and like who or what helped you get involved? Because I think that's a huge question for many people. So maybe start with Peyton, we'll kind of go down the line again.
So I first got introduced to the world of adaptive sports. I was at my after-school program, and my now coach, Keith Wallace, was there DJing, and he saw me, and he came over and was like, I run a wheelchair basketball program, and you should come try it out. So I did, and I fell in love with it.
Go ahead.
I've been in I've been I've been in track and field since I was in I'm trying to remember since I was in first grade, and I was just on the regular track team, and I was not running as fast as everybody else, and so we found out from someone else that there was adaptive competition in Saginaw, Michigan. And so we found the sport. We found the we found out about it, and then we tried to figure out. We found out that was running at decent times, and so we went up to Saginaw, and then I qualified for junior nationals, and it was in Saginaw that week, or the next month, and so I've been doing it ever since then.
So I've been playing wheelchair basketball since I was 5, but I actually found sport while I was pushing around at the local mall, and this blue-eyed blonde woman kind of came up to me and kind of, pulled my parents aside, like, hey, like, I'd love to see your son play sports, and, my parents we're from Cambodia, and so, of course, someone comes over and like, hey, yeah, let's go check it out. They were kind of freaked out at first, but I went to the first practice and kind of fell in love with it ever since, and now I've been doing it for 25 plus years. Yeah.
I just kind of want to add, I know probably geographically we have a large span of various states, but many of us that are in the Adaptive Sport Agency, we're not chasing someone down, because to be quite honest, it's hard to find, especially also in a rural area. The one thing COVID certainly has done is provided opportunities on a virtual level, and our agency, as well as others throughout the United States, do offer virtual. So we have kids that are in rural North Dakota, upstate New York, Flagstaff, so certainly that's a benefit. But a number of us looking around the room here, coaches and athletes, if we see somebody, we definitely will go up and say, hey, because it's truly the power of sports.
We may come back to that question at the end and that content. But I think the next thing I definitely would like to add is, I guess, did you have any obstacles that really, kind of like hindered your full participation in a sport, a specific sport or an activity? And then kind of right along with that, how'd you overcome those obstacles?
Okay. Well, I also do track for my high school, and especially the coaches are just not very understanding. And so I try to explain to them like how I can do the sport and what works best for me. And that's kind of how I overcome that obstacle of not everybody understanding. and just try to explain my disability to them as well.
Definitely talk about if there was an obstacle, though, too. Was there or not?
Just the obstacle of like people not listening when I'm explaining stuff, or like thinking I can do it one way when I tell them I do it this way.
I haven't really had any obstacles that I've had to overcome per se, but I've had trouble with like balance when I'm throwing and things like that. So I have had trouble. I've had trouble like doing a spin for discus, and it has taken me longer to do a shuffle step for shot put, and I haven't really had any obstacles that I've had to overcome.
So do you think perseverance was the key?
Yes.
There you go.
I think one obstacle that a lot of adaptive athletes, they kind of see is equipment, right? The equipment you kind of see up here today, this is about like, let me see, 1, 2, 3, 4, 5. That's probably about $30,000 worth of equipment right there. These things aren't cheap, and I think just trying to find different grants out there, different organizations that can help kind of pinpoint how to get the funds to get equipment is huge. That was a big obstacle for me, just because my parents, they're great. We grew up in a low-income household, but at the end of the day, I played for the Rancho Wheelchair Sports Association when I was growing up, and they were able to help me get connected with different like grant writers to help me find equipment. We at GLASA, we help our athletes find those grants, whether it's through Move United, or through Challenge Athletes. These are all different programs that we help our athletes utilize to help find those grants. Also, it's just finding the organizations itself. Adaptive sports is unfortunately still kind of one of the best well-kept secrets. And I say that because you don't necessarily know where to find it unless you know someone that's already in that world. And so our job is to make sure that we spread that word of mouth, and we help people find an organization near them wherever they are in the world. Just because we're out there, but I think people just aren't sure what the first step is to take. And that's one of the biggest obstacles, just finding it.
I just want to add, especially for Peyton and Margaret, a obstacle. So with the State High School Athletic Association, there's many states that have standards specifically for the wheelchair athlete, the individual using a chair to ambulate. And there's also standards for para-athletes who are ambulatory, such as Margaret, that has paralysis or an amputee. The states of both Michigan and Illinois do not have standards for individuals who are ambulatory and have a physical disability. So again, it varies state by state, but that is definitely an obstacle, because you can be top in the country, going international, and yet you cannot advance with your peers to the state level. And that, hopefully that's changing. We're trying to work with the various state high school athletic associations through the federation, but that certainly is an obstacle.
I think the biggest thing that we're on that Adaptive Sports and Recreation Committee, and right now we have a subcommittee that's trying to put together a toolkit that will go on the AACPDM website. But what we can't do, because the AACPDM cannot advocate for specific organizations, even though we put together one. We had put together a list from different regions because we're from throughout the country. But what we want to do is definitely create a PDF or a page to put on the website with how do you look for, different types of organizations, and what are some key words. And we would love to talk to this group afterward. Hopefully you could stick around. But I think that's a big thing. Like if you have, we kind of want to go down, and if you have suggestions on what someone could do, because there are others in the room, you know, clinicians, parents, and others who really want to know, how do you find them? Do you have suggestions? All of you might have a suggestion. If not, we'll kind of move on to the next thing.
Do you have any suggestions? So I think I can speak on it. I think the biggest thing, you know, we live in a world where social media is huge, right? If you type in adaptive anything, at this point in time in the world, you'll find someone showing off the latest power soccer trick, wheelchair basketball, you know, track and field. Using that to kind of find those different organizations is big. I also highly recommend utilizing the local organizations. So for example, GLASA, we can help pinpoint exactly where, like if someone is in New York City, we know different organizations there. And we have those different contacts. Also, a big governing body is Move United. So moveunited.org, they help find specific organizations in different areas as well, pertaining to what specific sport you like. If you say you want wheelchair basketball, there's a spot you search up, it's wheelchair basketball, wheelchair football, and what have you. But, you know, Cindy, what else do you think?
Actually, it's pretty good. Yeah, I would just say really trying to be resourceful and not giving up, and it can take phone call after phone call and email after email, because it sometimes is very difficult to find, so.
One thing we are going to do, I'm sorry, you can definitely talk in a minute. We are going to try and get clearance through AACPDM for specific national organizations that we could probably provide at least a link to, because that's the hardest thing. Who's the contact? And, you know, we'll see what happens. You know, we're optimistic. We're going to go slow because we want to get approval. So we're going to start with the PDF and a web page. So definitely I may want to stay, you know, at least get some keywords. Like I think adapted is good, or adapt, and then we can take it from there. But I think what I'd like to do is maybe open it up and really have Cindy speak a few words about what she does to actually help people, you know, be recruited. I think your strategies may be really insightful.
I would say, and I'll have Mac also add on, but it's really a multifaceted approach because not everybody is the same. So I think what keeps individuals in sports are definitely the people, right? It's the coaches, it's the relationships, it's the friendships. And so I think that with some individuals, it's one-on-one. It's making sure that we're sitting across from a table. Another individual may have transportation difficulties and they're not going to be able to get to a weekly program. So, so how do we work with that? It could be via phone call, it could be email. Really, we also, in the community, we have our medical facilities that are definitely referrals. I would say we're not, I think Mac probably would agree, and the rest of you guys, probably not getting enough referrals from medical facilities, so would love to see more. So love to hear from everybody in the room as to, hey, how can we do a better job with that? Certainly the schools, those that have, sometimes it's athletic directors, sometimes it's a school nurse, it can be an OT, it can be a PT, it can even be, in your community, who provides accessible transportation. So really looking at the services in your community across the board that might be serving. Also, talking about adaptive equipment, what about the equipment that is individual needs on a daily basis? So it could be a walker, could be braces, orthotics. I know we were just at, that's actually my husband who coaches over there, but we were at a prosthetist, a well-known prosthetist had a picnic, and we went out, and it was great because how many amputees we hit at once, individuals who are amputees, correct myself, but it was that one-on-one interaction. Mac, and as well as another of our program manager and our other coaches, we just attended a camp specifically for individuals with limb loss, and we did various sports across the board because not everyone's going to be a very competitive athlete. Some are doing it, for recreation. So I think it really depends on, the individual, but the more resources that you can touch, that could be a potential referral. So.
Yeah, the outreach aspect, it's incredibly important just kind of stay on top of people. I think one of my challenges as a program manager is I'll meet parents that have a young athlete that can absolutely play an adaptive sport, but it's kind of that fear of having their child like, oh, well, I don't want to put my child on display. It's like, we're not putting anyone on display. We want your child to come and become part of a community that's full of love and competitive, and that they can use sport as a tool to kind of get to where they want to in life. I'm really excited because these two young ladies to the right of me, they're going to be going, off to college and competing at the international level, and just being able to use that to kind of showcase their abilities in the world, not as just adaptive athletes, but athletes in general. For me, I've been able to graduate. I went to the University of Illinois on full athletic scholarship. There was no way in heck I was going to be able to pay for college unless I was playing a sport, and my grades were okay, but this sport really helped change my life, and I'm able to be in the position I am because of the people that I met, but also just being part of that community and kind of growing with it and just giving back to others. Cindy's always chasing people down at local state fairs, right? And we're always trying to find people and just staying on top of them, like, hey, like this is an opportunity for your child, your athlete to be something bigger than what the society thinks upon them.
Well, like going on chasing people down. There's people from all over the country on GLASA. There's people from on GLASA from California, all the way to, I don't know, New York, all over. Peyton or I could be at a track meet and say, you're not on a team, join GLASA.
Ideally, though, there would be an adaptive sports program in everyone's town. So it's not like, that's the ideal. But again,
I didn't mean it like that. But
as Margaret and Peyton and Mac, if someone does not have a program in their community, we're certainly there to provide support and also work with the individuals within that community so that they can start a program. But as looking at this adaptive equipment, it's very expensive. And again, we're 25 years old. When we started 25 years ago, we started with a budget of $0, and I am not a fundraiser at all. So again, had to figure out how to do it.
Yeah.
And
how did you do it? Because I think that's a huge question in general.
how did I? It was little by little. We had a board, which was consumer, pretty much parents, coaches, and then really looking at other nonprofits, not only in our area, but kind of across the nation, knowing that for us to have any type of income, we had to have board members that would assist us. And certainly that's been a huge, what would I say? Important aspect of what we're doing. We have a young professional board. Being in the city of Chicago, most of our young professionals are in the city, so that's another board. We have a women's board too, so it's really just touching, right? And just, really getting the word out and the importance of what we're doing. Working with the universities is a big aspect also, because we want to make sure that with our students, yes, academics comes first, but also providing an opportunity for them to partake in sports at the collegiate level. So there's, yeah, I was going to say there's not really a plan. It's
I hit it.
just more.
No, I think it's great. I also wanted to bring up Sarah Albus. I've been introduced to her. She's somebody who is actually from Baltimore, has her own company, and what she has done is she also has, you know, like almost every organization does, she has like fundraisers, and she has things like, you know, silent auction online and things like that, and that people make donations to. So I think there's a lot of options, and I was thinking, what could clinicians and teachers, educators, what could we do to kind of like get the word out? I think there's a lot that could be done, and maybe we can even like create some kind of like flyer or something like in addition to the PDF. I think there's just, we're just starting with the PDF, starting slow, but if you have ideas, definitely stay afterward, you know, give me your email and then I'll give you mine and we can actually, you know, take it from there. I didn't know if we wanted to try and show some of this equipment. Is that feasible or not feasible?
Sure.
I
yeah,
think that would be
absolutely.
great for people.
Oh,
Did you want to make a comment? Go ahead.
I was going to say there's a organization called CHASA that I've helped get all their CP athletes involved in adaptive track and field and adaptive sports. That I've done demonstrations at those retreats, and they've come out. And now they're come out when they were younger, and now they're older, but I helped them get involved in adaptive sports.
And that was CHASA, you said, C-H-A-S-A?
Yes.
Okay, wonderful. Anybody else? Yeah, we could, let's open it up first, and then we'll do some demos. Go ahead.
Curious, how does this work? Are you guys like Team GLASA, or are there different teams, or how, is it all individual, or how?
Yeah, it's very complicated. Well, so for example, you know, Peyton plays basketball, wheelchair basketball, with another team in the Chicagoland area. And in the Chicagoland area, we are really, really fortunate to have great adaptive sports agencies. Shirley Ryan itself has adaptive sports, and we all play well together, so we're not competing. GLASA specifically does track and field that other organizations at this point in time don't do. But how many basketball teams does Chicago have right now, ballpark?
4.
Yeah, 4. So again, so yes, it's team, but it's also, you know, it's also individual too. So I can understand, yeah, the confusion, so.
Hi. I have a couple questions, so I'm sorry. I'm a therapeutic recreationist from Canada, so I work at a children's treatment center, and so getting kids involved in sports and adapt sports is kind of what I do. So this is great, so thank you. My questions, have you ever encountered, especially with parents, the risk of pretty much anything and doing any type of sport, whether it's adapted or not, and how to justify risk versus reward for those kiddos and getting them involved, and like how do you approach those more, I don't know, complicated families when you see what the child wants to do versus what the parents think is okay? Every day. How do you support getting them involved?
That is a great question. So I think it's a case-by-case thing, right? You truly have to like know what that family kind of stands for. So you might have an athlete who absolutely wants to try everything, right? But there may, you know, the family might be in a situation where they can't make it to a practice. I can speak on our behalf. If a child has transportation needs, we're able to kind of help out with that, either utilizing public transportation, or I might go and pick up a kid using company vehicle. I think it's really, it just pertains to kind of the season too, in a sense, like, all right, if the athlete does multiple sports, you kind of have to prioritize, like, all right, if this person's coming up to track season, what are the resources we can provide for this athlete to kind of be able to attend the practice or the games? But yeah, it is individual based. Are you in Toronto, perchance?
Hamilton, so about an hour out from Toronto.
About an hour out. Yeah, so I did my internship in Toronto at the Pan American Center, Sports Center. So what they do, they have the Wheelchair Basketball Academy, and they essentially try and find funds for athletes to centralize. But again, that's just for basketball. You might have an athlete that wants to do goalball, or they want to do sled hockey. Again, it depends on the sport and what you're trying to accomplish. Yeah.
Hold on, can I add something?
Yeah, go ahead.
There's a organization called the Cruisers in the Brampton area, and I know someone that is on the team out of that area, so that would be another.
I would also say it's the power of parents, and I'm looking at these two right here. Because truly, if I have a new individual coming in, I'll do the very best to make sure that there's going to be another athlete of similar ability, that there's going to be a parent who can advocate, and I let that parent know, hey, can you be at excellent practice? We've got somebody new coming in. Because as a parent, it can be very scary, right? I mean, there are a lot of things, but there's also a huge parent network, various parent networks, right? I just found out about one this week. But so I just keep the multifaceted approach is huge, and the relationships with coaches, and that's, we went to the picnic, we had coaches there and we were talking, but definitely use your parents. And the medical community too, your OT, your PTs, because that, I know rec therapy, that's my undergrad, but your OT and PT, that's where they're getting therapy. And, they have been, to stand and to one of the biggest things we get, especially with some of our sports is, they've had PT for years so that they can stay upright. Why would they utilize the sports chair? And, hey, but they're only, one thing I will say to a parent, they're only going to be in a sports chair for 30 minutes or an hour, and then they're going to get right back out. So again, kind of knowing what those factors are when you're working with parents.
Yeah, perfect. I have a second question, if that's okay. When you're talking about adaptive sports, a lot of the work that we do too, where I am from, is we do a lot of integration into mainstream where we can. And I'm just wondering, from your perspective and everyone on the panel, where do you find is the value in creating space where athletes can participate among peers, or do you find that there's value in having more segregated programs? Where do you feel that you find the best value in sport?
Both. And I'll give you an example. Let's take swimming, for example. As soon as our swimmers can, regardless of disability, can swim across a pool, we want to get them in a club. So that's totally 100% inclusion. But if they're in a big club team, you can have 100 kids in a pool, right? And so they're getting the pool time, but they may not be getting the one-on-one instruction that they really need where they're really working on strokes. So what we do is also provide an opportunity for then the one-on-one, but we want them inclusion as much as possible. I mean, both you guys did high school inclusion, and then we also have practices that were specifically para, I would say, where we have, so it definitely 100% inclusion is great, and then having the support so our athletes can be independent on an inclusive basis.
I mean, adaptive athletes are athletes. I think one of the biggest things that kind of organizations overseas, they do a better job of including everyone regardless of abilities. So actually in Canada, they allow able-bodied athletes to play on the same team as someone with a disability. And it levels out the playing field. If you have an organization that has three athletes that have a disability, if they're able to bring in their brothers and sisters to bring in that fourth and fifth player for basketball or whatever sport it is to be able to provide the opportunity to play, that's big because you create more opportunity, and it's just about sport. However, there are those that push back because my child will be on the sideline if an able-bodied athlete comes and plays. But there's checks and balances within that can be included within the rules of a specific sport. But at the end of the day, everybody just wants to play. It doesn't matter.
Hi, this is more of a comment than a question. My son is also an adaptive athlete. He's 16. He was part of the Move United Junior Nationals the past 2 years. And I was with him in Colorado, but not this year at Alabama, only because I've been to Alabama before. And he often tells me that Glasser is the heavyweight. They've got the biggest team. They win all of the trophies, and he wishes he lived closer, but we're actually in Connecticut, and he's part of the NJ, the New Jersey Navigators.
Oh, yeah, sure.
So
we know the Navigators well.
yeah, so we're a big team as well, but not as big as you guys. And I just wanted to share a few other things as well. I think I met some of you before last year. I was here as part of Cerebral Palsy Soccer. So we're an organization that provides soccer programming for kids with cerebral palsy. It's completely free, just like Glasser is. I'm a parent. It's founded by other parents as well. And the only thing it's different to Glasser is really it's very much of a team sport. And I think some of the questions that you raised just now sort of resonates a lot with me as well. How is it's so difficult to find all of these kids and get them together. We're in New York, and you would think it's very easy to find these kids, but actually it's not, because kids with disabilities actually don't like to live in New York. It's very difficult to navigate there. And there's been a lot of challenges in finding these kids. But then to your point, you were saying, oh, the siblings can join in. And that's what we've done as well, so is really to create this community for kids. And we also have a program in Houston, and I think we probably share some of the kids with Glasser as well. I can probably name a couple of them. So some sort of shameless promotion on my side. Apologize for that, but really want to be able to sort of share that with you, so that when you create this PDF or something that will help the rest of the community, I'd love to be part of that as well. Something else I wanted to talk about was the reason why I was here last year is I did run a camp with Columbia University, and we sort of measured the health and the mental and physical benefits of team sports for people with cerebral palsy. Last year was a pilot program, and then a pilot camp. And this year we ran it again with Mass General, and we got a team of 10 soccer players. My son was one of them. Now that he's 16, he's more of a mentor, taking up more of a mentor role. So what we want to do is each year we run these camps and take these measurements. So the kids are wearing their heart monitors. We're finding out the efficiency rate of what they them doing their activities, and then doing these interviews, before and after interviews with the parents as well as the athletes, to find out their social, emotional sort of benefits or differences. But anyway, thank you for this presentation. Everything that you said I agreed with so much, but hopefully I'm not taking up too much of your time.
No,
Thanks.
I thought it was great. And I put this slide up just because these are our 3 emails, and definitely email. Hopefully you'll stick around and we can get information. But also, I didn't know, was that program associated with Andy Gordon, or was it something separate? Because he was my doctoral advisor.
I know Andy only through Columbia. It's not directly associated with him. It's associated with Dr. Catherine Dimitropoulou. She's an OT at Columbia. But I think she works very closely with Dr. Gordon as well.
Okay.
You're with a great group. We love the Navigators. So, yeah.
Share again, this is all possible only because of the parents, and the Navigators, they're all parents as well. We're so thankful of the tireless efforts that they put in for the kids.
Did anybody have another question? Because if not, maybe we can definitely want to get the equipment before everybody leaves the room. That would be super. I'll come get the mic. Yeah. If anybody has a question, just raise your hand and I'll bring it over.
Do you want us just to go over to the other?
She has a question. Yeah.
All right, thank you all so much for coming. It was great to hear. I'm a researcher over in Seattle, and I work with kids with CP. And my question is, if you've met any kids or talked with any kids who are maybe scared at first of trying the new sports. And I was curious if you have advice that maybe I could pass along to some of the kids I work with.
What you guys?
I mean, when I started sports, I was scared, but as soon as I got into it, I really liked it. So I think it's just all about trying it, making friends, and remembering that you're not going to be good at it at first. You just have to practice, and you'll get it. Don't worry about being the best. Just have fun.
I could basically go on what Peyton just said and more, because like sports have helped me so much ever since I was like 5, and when I was doing soccer, I wasn't the greatest at it, but I kept going and doing it, and I kept getting better. Like, you just get better at it. You get better as you go. But it just I'm trying to think. What? Yeah, you develop friendships, and then you have friends from all over the country, or friends all over where you live, depending on what sport you do. So.
I think just remind the kids you're just playing, right? I think there are some families that are thinking about the next level already. It's like, you know what, the kid's 5 years old. Let's let him play little sharks and minnows first before we get him out to the Paralympics. But just showcasing that there are a lot of other individuals out there that are doing the same sport that they are, and just being patient. Like, if you throw a kid into the fire too quick, that can absolutely intimidate them and kind of take away from that love or ever wanting to try it. But have an athlete show up to practice. They can observe, and then if they want to try it, that's fine. If not, maybe next time. Just being patient, and also, again, it pertains to the child and like how they're feeling, and just being aware of that. Yeah. Oh, I think she had it. Yeah.
Yeah, I just wanted to build on that, if that's okay. I think a lot of it is also some of the nerves that I tend to see with the kids that I work with, like, comes from the visibility factor. Like, they're nervous to do the sport because they haven't seen someone else do the sport the way that they do it. So I think a lot of it is just reassuring that there's other ways to play sport, there's other ways to do things. And like, if you can find that community, yes, the friendships are a valuable piece, but I also think the visibility of it, for sometimes, like, that's the biggest piece that gets kids involved, is that they're actually seeing people like them playing the sports that they want to, and then that can sometimes help alleviate a lot of the fear. Is just the visibility piece and understanding that it's okay for them to play that they need to play versus trying to fit into a specific box that sport kind of has sometimes. So, sorry.
I just wanted to add, a lot of times parents will say, well, my child doesn't want to come, he doesn't want to try it, and if the child has never experienced success, especially if he or she's been in a 100% inclusive environment, they are scared, and rightfully so, because they haven't experienced success. So kind of what everybody here is, I'll be like, just come and, just watch, or just, and once they watch, but again, you can't blame those kids because they have not, had success. So it's scary. So.
One thing I just wanted to bring up are not only group sports, but there are other things that kids can get involved in, like archery, or there's other things I see, like in my community. And what's interesting is one of the sports, like I live in California, it's called Life Rolls On. It's adaptive surfing. Then I have a friend because I lived in Philadelphia a long time, and they have that same Life Rolls On in New Jersey.
I just wanted to say, I'm Margaret's mom, but she loved sports from when she was little, so it was easy for us because but we had trouble finding things. And it's different in different parts of the country. In the Detroit area where we're from, instead of one big group like GLASA, which does a lot of different sports in Michigan, every sport is its own nonprofit, and so one group just does wheelchair basketball, one group just does sled hockey, one group just does water skiing and kayaking. And so it was hard figuring out where the resources were when she was little. She loved sports. So we tried all the local community stuff, which I think is a big thing. And we just kept trying. But my key was trying to find coaches who were willing to work with her and understand and give us some flexibility and be willing to listen. And if the coach wasn't going to think outside the box and work with us, it was like, move on, find somebody else. Because her being successful in whatever way she could was important. And so that made a huge difference for us as we just tried different things. One thing we found was Margaret was ambulatory, and almost all the organizations focused on wheelchair tennis, wheelchair this. So we did not think that she was eligible to go to that. And I remember going to do the adaptive water skiing one time, which is one of her favorite things to do. And they said, well, why haven't we seen her now? She was like 12, I think, when we did it the first time. And I said, well, I didn't, every picture on your website showed everybody in a wheelchair or more severely affected. I had no idea Margaret was welcome to come because she was ambulatory. So I think the inclusiveness of different ways of disability is also very important, instead of just being wheelchair or just being amputee or just being ambulatory, that the people think they're able to. We just happened to find a wheelchair tennis guy who said, oh yeah, well, I work with ambulatory people too, but the rec department had everything listed as wheelchair. So that was one of our first experiences being out there, but it was just trying to find things was the hardest thing to do. And trying to get involved in the regular events, and then trying to find the support to help her because she learned how to do things physically differently. But so that's a big thing, is the persistence and trying to find those resources. That's the hardest thing. And just reaching out to other people and sharing that. We found a lot of PTs and OTs didn't know anything about sports. They just did their job in their box, for example. And the doctors are the same way.
I just wanted to pass along some good news from Shirley Ryan. May be building a site in I don't know if it's in the Detroit area, but in Michigan. So I'm from Michigan originally, so that was very, wonderful.
I do hope to great.
She just wanted to say she does horseback riding for her sport.
That's wonderful. That's an individual sport, but I think that's wonderful. Horseback riding is fabulous. Love horses. Thank you. Anything else? Okay. Anybody else? Any other questions? I just want to, we have another one. This is great. Okay. No.
To follow up on your comment, that was really helpful, because our son is ambulatory, and that's one of the issues that we've had, and that was a follow-up question I had for GLASA. So is it when you do become part of the program, are there coaches that can adapt to however, and help the kids accommodate in their own way? Is that just part of what they learn?
100%. And we first recruit coaches sport first. Randy, do you want to say anything? She's out. Do you want to say anything? Well, as coaching, how do you adapt to our ambulatory athletes?
Yeah, and again, I'm Randy Hausner. I'm actually Cindy's husband, but I'm a full-time coach, or feels like full-time with GLASA. Okay. But I'm one of the track and field coaches, and yeah, the question is very good, because everybody is very, not very, but somewhat unique in their disability and in their drive to, what level do they want to exceed to. So we try to adapt, the word continues to come up, but there's a lot that can be learned. I participated in sports, not at a real high level, but enough to know that there's a lot of things that can be extended from the able-bodied community into the disabled community. And I don't think, personally, that a lot of coaches in the adaptive world necessarily draw upon that. So that's something I try to do is, look for the able-bodied community and what can then translate. But there are, unique things. I work a lot with the amputee population and the balance, and I won't get into a lot of detail, but there certainly are differences. So there is a lot of information out on the internet though as well, and so there's a lot of resources we can draw on as coaches and even as parents to to figure out what might fit for that particular athlete and what they would like to excel to do and be remain competitive. So
Where do you live? Oh. We'll talk to you.
Okay, I think we're kind of ready for two things. One is I did create a kind of like a write-in sheet, and on it I have like Google terms that you think would be good for our PDF, and then another would be add your email, then we can include you and maybe ask you if you don't add, if we have like a quick, few questions we may want to ask you for more information. And then organizations that you know of that are national that we could potentially ask AACPDM to, maybe include in a drop down or something that's maybe futuristic, but we're working on it. And then types of sports activities, like definitely I think the horseback riding would be great. Like I said, adaptive surfing, who knew? I think, and there may be others, but I'm going to put this in the back. One more second. And then I just want to mention that Jill is in the back, and she's going to say a few words first. Then you can say something. 1 second. Go ahead. Say it now. Go ahead.
No, I was just going to see what other adaptive sports there are, like things you can try. They have tried many.
Great question.
Go ahead. Okay, so I've tried adaptive surfing, kayaking, rock climbing, water skiing, and snow skiing. Anything else? Okay, yeah. On top of wheelchair basketball and para track and field.
There we go. Okay. So, so we were talking in our committee meeting this morning after this that everyone, we have kind of this similar sort of thing. Every year we talk about adaptive sports. Everyone gets really excited. I can feel the excitement in the room. Everyone wants to go home and participate in an adaptive sport of some sort. But we've never done any follow-up to see how many people actually are able to find something and get involved. So we're going to try and do a follow-up survey if everyone got their email in when they registered, or if they didn't get a place to write your email. We're going to send out like a really simple survey, a couple questions like, A, did you get involved with a sport? B, how difficult it was, and C, what obstacles did you run into? Was it transportation or fear, or the coaches at the high school wouldn't help, or whatever it is? And we'll find out, follow up, how y'all did.
Definitely time to maybe show some equipment. I think that'd be wonderful, or at least talk about it. Maybe Cindy, you can help out too. That would be super.
Yeah. Okay. Peyton, I would like to show everybody, we have a race runner, which is for individuals that may not, don't have the fine motor skills to possibly utilize a racing track chair. We also have a field chair, which is shot, discus, javelin, and Peyton, due to her disability, throws something called the club. It looks like a bowling pin, right? And one thing we didn't talk about really quick is classification. And classification is done by a sport-specific individual as well as either physical therapist or a physician. It's a series of functional tests that allows our athletes to compete against other athletes with similar disabilities. So Margaret has paralysis on one side, when she goes to Thailand, she's going to be competing against other athletes, adults who also have paralysis on one side. And there's a lot of different, but with specifically cerebral palsy, there's 8 different classes. 31 would be an individual such as yourself who utilizes a power chair, all the way to 38, which is an individual who is ambulatory, has cerebral palsy, and it might be just very slight with the gait. So again, I don't want to get into that, but just like with Peyton, when she competes, her classification is a 32, and she competes against other individuals, females, age group, that are 32. So, so it's equal, for the most part, equal participation. So should we show you Race Runner? This is Peyton's Race Runner. Where'd it go? Oh, right there. Do you want to help? This is the wrong seat, which she let me know this morning. But for Peyton, to be able to utilize a sports chair would be difficult with balance, with having your core. But yet, Peyton is not where she's going to be able to compete without an assistive device. How much did this cost, this one? Do you remember?
This is just under 2,000.
Yeah.
All right, so she would have a different seat, so just bear with us.
No. Whoa, 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 whoa.
So usually her seat would come down, so she just steps in and we pull it back up. This is new.
Yeah, this also would be up. So again, a lot of it is, and Mac is excellent at this also, but it's seating and positioning. Unfortunately, across the national aspect, to try to get somebody to measure even for a racing chair, if somebody's looking for a new profession, we would love it, because it's very difficult to find those individuals to measure specifically. But go ahead, do you want to? This is a Paralympic sport, so when you see the commercials on, they just started for Paris 2024. This is one of the, and so this would be a timed event. I feel bad, Peyton, because I know that seat is not correct. But this is, again, you can see how she's ambulating and against other race runners. So, I know, let's get her off.
This piece of equipment looks great, not even for just race running, just for getting around, walking.
But you can see, I mean, she doesn't fit right now. We need to do some definitely adjustments.
That's really big in Europe, and it's just
Yeah.
now catching on in the United States. So the United States is behind the
Got it, okay.
It's huge in Europe.
Do you want to talk? Yeah, you want to do the sled? Well, Peyton gets into her. I'll have Mac talk about the sleds.
Hey guys, so yeah, this is a sled that's used in sled hockey. Like Cindy mentioned earlier, seating and positioning is also big within sled hockey, just because depending on the athlete, depending on how many limbs they might have, depending on their level of disability, you kind of seat, you position their feet or whatever limb it is based on their height, their weight. As you can see down here, there are spacers and blades on the bottom here. Sled hockey is played on ice. And essentially, the athletes are able to propel around using 2 hockey sticks that have kind of hooks on them, or hooks on the edge of them, and they propel kind of moving forward, kind of like this. But this is also a Paralympic sport. U.S. typically takes gold whenever we're up for a Paralympic game, which is great. This also has different click straps. This is what keeps the athletes in from falling. Athletes typically have a lap guard as well, because you don't want to get stabbed by those hockey sticks. It hurts a lot, I can tell you from experience. Athletes also wear helmets just to prevent from injury to the head as well, and it's full contact, right? When you get out there, if you're expecting something cute and nice to see, you might be in for a rude awakening. There's a lot of hits, a lot of speed. It's a really great sport. Glass recently just won the Heartland League Championship, and actually they're looking to repeat again this year. So it's a really great group. You'll also see that there's click straps down here. This typically keeps your foot in. Again, this is a safety measure. You don't want kind of your limbs kind of flying around, to the side. And I'll show you guys the basketball chair next. So the chair that I'm in is essentially called an everyday chair. So I'll use this if I'm going out to, to work, if I'm just kind of doing something leisurely. But when I'm ready to jump in and play a sport, I hop in here. And it's the same thing. So I'm able to go a lot faster in my ball chair. And I'll just, you guys hear me? All right, so I'll strap in, and now my chair here, this basketball chair, it has cameras. So the chairs are, you're able to spin really fast. You stop on a dime. The wheels are slanted just so I'm able to spin and move around a lot quicker. This is fitted exactly for me. So as you see, it's a tight fit, but it's a perfect fit. My one leg is tapered in. My hips, everything, like I'm able to move around, not everything touching the wheels, so I can kind of spin around and get down the court without ever touching my wheels. And that's huge for just getting around defenders and avoiding contact. And one of these, so as you mentioned, this sled probably costs about $4 to $5 grand. This is about $4 to $5 grand. Again, back to our conversation about food being expensive. You want to make sure that it fits well and it's catered to you when you get your own personal chair. Next thing, Sydney, you want to talk about the fielder track chair? Yeah.
This is a track chair, and an individual, the more core you have, the better. If you don't have fine motor, you may not be successful in utilizing this, but this is the typical when you see the marathons and the 5Ks and the 10Ks, an individual will tuck, put their feet through here and their seat here, and then they're seated based on their measurements. They have to fit, based on their hips, based on how long their arms are, depends on the ring. And then these are the 3D printer gloves. So again, it's based on your hand size. So, but again, not everybody is going to be, even though they look really cool, not everybody's going to be successful, and that's why we give them choices. So I'm going to have Randy talk about the field chair. Here.
I'm going to use this to have a seat. This is a field chair used indoor and outdoor. Basically, the athlete is strapped onto the chair. The chair is secured to either the ground or the floor. Think of 4 long ratchet straps coming down from here, typically secured into the ground, holds it very, very firm. This pole, I'm right-handed, so this would be set up for me. Could do the reverse, so it's left-handed. Shot put, discus, javelin, and Peyton specially, the club, she throws backwards. So it can be used for all 4 of those different events, and the chair, can be sized to the athlete. The one thing I learned about seated chair is the rules very much push the athlete for independence. They have to be at a very, very severe disability to get assistance. Otherwise, they need to get in, need to be able to strap themselves, need to be able to do it all. That was a surprise to me, but that's the spirit of the sport.
But Peyton's can receive assistance. So Heather, mom, when we're at a meet, can get a waiver so that she can assist Peyton. However, if you have, let's say, a spinal cord injury, you have all your abs or spina bifida, you cannot have an assistant, and it takes X amount of seconds you have to get in. So again, the whole point is definitely independence, but certainly with Peyton's classification, she is allowed assistance. But Heather also is not coaching her, and she's out of the throwing circle at that point. So she's got a coach. So
I just wonder why it's so high. Is it high, especially if you have to get on and off so quick?
I think it's to keep their feet. I can't even put my feet.
Right,
on the
you
ground,
have to be.
It's to just the body and the chair, not any assistance.
So this cannot be over the throw. We have 1,000 rules, but it cannot be over the throwing circle. Obviously, at the beginning level, the big thing is having fun. We're not, you know, but as our athletes do move up, we want to make sure that they are receiving the best coaching they can. Margaret, one thing we don't have here today, and I know you've used it, is when you're starting using the, what is that called? No, what's, okay, yeah, can you, like, what's that thing called?
I was like, what are you?
There's a couple of things that ambulatory track athletes use, a couple of different things, that if they have an arm length difference, like Margaret does from her CP, she doesn't use it anymore, but.
There's a black holder for, like, here, you can talk about it.
Okay, so it's like a block holder. So it helps fill the gap between her hand and the ground. So actually, our previous coach, Dave, was the one who would teach us how to make them. It's like a block of wood and a tennis ball can, and it's all taped and everything together, but you have to make it to the height your athlete needs between. It gives them the support to go down in the blocks and push off. And sometimes athletes with cerebral palsy, because of the balance issues, they do not use starting blocks, and you're not required to use starting blocks because of the balance issues, but also the transition from being down to up. They lose momentum in the change of the way they do things. So actually, the Paralympic sprints coach told Margaret to go to like a linebacker stance, so she doesn't use the starting blocks when she runs, because being in that stance allows her to take off and go where she needs to go. But the one piece of equipment sometimes the ambulatory athletes use, which I want to talk about, was the carbon fiber brace that Margaret's wearing. When she was younger, she wore more of the hard plastic DAFO and Cascade type ones. But in sports, they don't move very well and give you you don't have enough ankle flexibility. But Margaret always hyperextended, so that's why we never went to a carbon fiber brace. But there's a lot more versions of a carbon fiber brace now. And so now she has one that works even with her hyperextending. But they fit it to make it. And the carbon fiber braces give a little spring to it and help with the balance and then being able to push off. She doesn't have ankle motion. So it helps with some of those things which make her more successful as an athlete. So that's carbon fiber braces you'll see a lot in ambulatory track athletes that need that.
I had a question for Cindy or anyone. I think if let's say you're a therapist or an educator or recreational therapist, what kind of things do you believe would prepare, like, even starting toddlers, young children, to get them ready for sports? What's missing? I think that's an important point.
Wow, that's a tough one. You know, as a therapist, I would just say continue working with the children, the kids that you have in your programs, so they can be as independent. And that's what you're doing anyway, and that'll help them transition. I don't know if you guys have any, yeah, no, go.
As a parent, the one thing that we found is through the school district, you lose your PT and OT services fairly early, especially if they're ambulatory. But I know it happens for people who are in wheelchair as well. If you can get in and out of the building or get around the building, then they're like done. And the one thing we were lucky, we had a PT at our school who wrote the goals. She wrote the goals to make it so that Margaret was included just as everybody else. So she had PT all the way up through high school, but it changed over the years. But in the beginning, she'd say, well, if she's going to participate in PE class, she needs to be able to throw the ball. If she's going to participate in PE class, so she wrote all the goals towards participation and being in the regular gym class. So she was able to get PT, maybe not 4 times a month, but she got it 2 or 3 times a month. And then when she got to high school, it was more consult, and Margaret took like strength and conditioning class, and the PT would go in with the teacher, set everything up, figure out what machines she should use, et cetera. And then she would just check in with her once in a while. So the PT thing, through the services through the school, that was a way we were able to keep getting services a lot longer than most other kids do.
I would say I know a number of parents, especially, you get somebody on a phone and they'll say, my child has cerebral palsy, and we'll talk about it. And I'll be like, how about track? Oh, no, they can't do track. They can't, nope, they can only ambulate. And then once we get, many times, we may have individuals, once you get, and with coaching and working with the schools, it's amazing where first you're just going to do 100, and then, we've gradually kind of increased that. So I think setting realistic expectations, but also kind of those reach expectations also are really important. Peyton, you have anything? Heather, anything? Nothing, okay. Matt?
Okay, I think the biggest thing is I may have some specific questions for people, but so hopefully you guys can stick around. But in the back, I would love, definitely everybody, look here and see if you could add any Google terms, add your email if we don't have it already, and any organizations that you think of that would be good for us to maybe see if we could add them to our list. And then any type of sports or activities. I wrote a few, but I have a pen here if you need it. There's also a sign-up sheet in the back for GLASA, so if you're local, definitely sign up. And do you want to sum it up?
Yeah. Hi. No, thank you for coming today, GLASA. As a parent of a young woman who has cerebral palsy, who actually participated in sledge hockey, because I'm from Canada, and actually with the Cruisers. So it was interesting to say, here you mentioned the Cruisers, and she actually even did some sports with the women's national team. To see these kids in the change room with their peers talking, that's an experience that not a lot of our kids get, and I can't even begin to say the benefits of just seeing them with their peers, finally finding somebody that they're comfortable talking with, and they're excited, and they're out and they're getting exercise, and even as a parent as well, meeting other parents, and having, sharing like interests, and just, complaining sometimes, so maybe things aren't the best all the time. No, thank you, GLASA, and thank you for the panelists as well for coming today. Just housekeeping before you guys go, if everybody can put their visitor badges just outside on the desk. They need those afterwards. And then you can always visit the American Academy's website, go on the Community Council. There's lots of pre-recorded sessions from the years previous. And there's also, if anybody's interested in joining the council, there's a link for that as well. And we're still here if you have any questions on the way out, okay? But thank you, everybody, for what a wonderful day.